Rizwana? Ah, Rizwana, could we make a sound check?
Yeah. Hello?
I heard something, but not very loud.
Now?
Wonderful. Good
This is
morning,
better.
Rizwana.
Good morning. Wait, let me put my camera on and see if you can see me.
Yeah, you are not on screen yet, but we can see at least in the Zoom. See you.
Yeah.
Very good.
Okay,
Great.
awesome.
Now we
Awesome.
can see
Thanks.
you. Okay. Thank you, Rizwana.
Thank
So
you.
you still
Bye-bye.
have 8 minutes.
Yeah. Is it clear? Is the picture clear?
More or less. You look wonderful. Don't worry.
Okay. Cool.
No, but we see you well. Don't worry.
Thank
Thank
you.
you.
Yeah, there's like a haze on it.
Here I am.
Oh, I can see you.
Okay. Good. Bye bye. See you in a second.
Bye. Thanks.
So I think we start. People are coming in, and I think it is the first session in the morning. People will come in. We know more people are joining, and because otherwise they told us that we have to be sharp in time. So all fine. So welcome to our session on personalized medicine, the future of personalized medicine. And the main aim of this session is to explore opportunities and challenges and ways how India could join the International Consortium Personalized Medicine. And you will hear about more what is personalized medicine. So, but first I would like to introduce you to the chair. We have here with us the Honorable former MP, Dr. Amar Patnaik, and BGT national spokesperson and also head IT wing, I guess from Odisha, Odisha, India. And he's an esteemed, really, national leader and policymaker. And in his tenure as MP, he did so many things. He's one of the few politicians, from my observation, who really made an impact. And I think this is really something which is beautiful. And so you also addresses key issues in like economic technologies, data privacy issues. You know about the personal data protection. So all areas which are also linked to personalized medicine. And just to say, before your political career, you also served, I think, almost 30 years, if it's true. Yeah. In the Indian Civil Services as an AI and AS officer with the CHG, leading India's external audit mission to the UN, FAO, etc. And yeah, I would like, one thing important I forget, very important, you're a member of UNITE, but I think you can better explain how important the role is of UNITE. And yeah, I would like to give the floor for you. It's an honor to have you here. Pleasure. Would you like to from here? Speak from here? Yeah, sure.
So good morning to all of you, and thank you so much, Angela, for such very generous words about me. It's really a privilege to be here today as a former member of parliament in the Rajya Sabha and a proud representative of the UNITE Parliamentarian Network for Global Health. This is the only global network of over 500 current and former parliamentarians from 116 countries, excuse me, united in advancing equitable health and the right to health for all. Today, I speak not only as a former parliamentarian, but as someone who firmly believes in the power of science, technology, policy, and political leadership to transform lives. Few areas demonstrate this potential more powerfully than personalized medicine, a field that is redefining the future of healthcare. Imagine a system of care that doesn't just treat a disease, but treats the individual, taking into account their genes, their environment, and their lifestyle. For too long, medicine has been reactive, waiting for symptoms to emerge before responding. Personalized medicines offer a new model, one that predicts and prevents disease, offers targeted treatments, and actively involves patients in their own health. In a country like India, where non-communicable diseases account for about 66% of all deaths, the usefulness of this shift would be crucial. India is uniquely positioned to lead this revolution for personalized medicine Our genomic diversity is unmatched, which is also a scientific resource of global importance. Initiatives like Genome India and iHub Data are mapping our population's genetic makeup to create more precise diagnostic and treatment pathways. At the same time, our strong foundation in digital health, led by the Ayushman Bharat Digital Mission, gives us the infrastructure needed to scale innovations across the country through smarter development of different health tech products, leveraging the enormous capability of Indians in artificial intelligence. From AI-driven diagnostics to personalized drug responses, Indian researchers, startups, and public health institutions are moving fast. We have the talent, the tools, and the momentum. But to turn innovation into impact, we need effective governance. This means strengthening our laws around data protection and privacy, establishing clear regulatory frameworks for genomics and AI in healthcare, and investing in infrastructure and public systems that can deliver personalized care equitably. We must ensure that these innovations do not become privilege for a few, but as a right for all. This is where policymakers and parliamentarians like me come in. We are not merely policy enablers. We are the link between scientific progress and societal benefit. We are accountable to our citizens, and it is our responsibility to ensure that this revolution reaches every corner of our country, especially those who need it the most, the underprivileged and the underserved. Today's discussion focuses on three critical issues, as I understand: the current landscape of personalized medicine in India, both in research and implementation, the potential for greater international collaboration, including identifying key global funders and partners, and long-term positive impact personalized medicine can have on India's health system and its role on the global stage. The future of healthcare cannot be built in silos anymore. We need collective leadership, international collaboration, and a shared vision that prioritizes inclusion, ethics, and equity. India has already shown that it can lead in digital public goods. India has become an opportunity to lead in personalized medicine by developing ethical, scalable, and inclusive models that can guide the rest of the global south. Let us work together, scientists, policymakers, and communities, to ensure that the future of medicine is not only personalized, but people-centered, equitable, and just. Thank you so much.
Thank you so much. This was really, I couldn't imagine a better really introduction to this to the whole field, and I think it was very convincing. Also your statement how important it is that India gets really personalized medicine on the agenda. And now I would like to invite the speakers to the podium. And first, so we would have now an introduction of ICPermet and of initiatives also of ICPermet in other continents, like in Africa, South Africa. So from now we have virtually joining Ritswana, Dr. Ritswana from the South African Medical Research Council, and you have been there, Dr. Taruna, quite often. So can you please open the link? But I would first, Ritswana, are you there? Good morning. Very early. We can't hear you.
Hi, good morning.
Good morning.
Yes.
So Dr. Ritswana Mia, she's the vice chair of ICPermet, the International Consortium for Personalized Medicine, and also the South African partner on the EU-Africa Permet project on personalized medicine. She also leads the South African Human Genome Program and also the South African Precision Medicine Program, between many, many other things, Rizwana. I'm sorry that you could not join here in person due to visa problems, but we are happy that you are here. So please, now
Thank you so
the
much.
floor is yours.
Thank you so much. So I hope you can see my slides. Let me just share my screen. Okay. Sorry, I'm just trying to share my slides.
It shows also how active that the initiative, and we will hear more, came from Europe, but how active, for example, also other continents, other countries are in paving the way.
Just let me know when you see them coming through.
Not yet. We tried it out before.
Yeah.
Thank you very much. There we are.
You can see my
All fine. Yeah,
slide deck.
wonderful.
Thank you. Okay, so let me start quickly. The EU-Africa, I'm not going to give you the definition. I think Monica will cover a lot about IC-PERMED and EP-PERMED, and the broad definition of personalized medicine, which we got a very nice one from just now with our esteemed speaker before me. So I'm going to talk about EU-Africa PERMED and fostering research, innovation, collaboration between Africa and Europe in personalized medicine. So, why should low middle income countries develop personalized medicine? Like South Africa and I think India as well. In fact, India has a higher non-communicable burden disease as well. South Africa and Africa, it's not yet quite quantified, but we experiencing a quadruple burden of disease, with both non-communicable disease and infectious disease being rather prevalent, as well as maternal, newborn, and child health. And we have a pandemic of violence and injury as well. And I know it's quite astounding if you're looking at the numbers. So besides dealing with this quadruple burden of disease, we also have to worry about the climate and health nexus. And are we building solutions to rapidly tackle the burgeoning non-communicable disease area, as well as managing infectious diseases? And if you think about it, and I think that our esteemed speaker also mentioned this, is that currently, we really are driving siloed approaches to research program development. And science conducted generally within country borders, especially in our dynamic, we find is done in silos across the value chain, from basic research to applied research. Project funding, answering small questions with little consideration in ecosystem development. Yet we've created enough excellent training programs, etc., and wonderful research that is coming out. However, this leads to low intellectual property generation, low ecosystem empowerment, lack of infrastructure and thriving institutions, and no real sustainable capacity as the job market is dwindling. And especially in Africa, this is the case. So the challenges to patient-centric healthcare, it's obviously a crossroads. Are we technology ready? Is the ethical and legal issues being dealt with adequately for us to now bring in this patient-centric initiative? What about direct-to-consumer testing? And this enormous issue around cost and insurance. And is infrastructure ready? Do we have a skilled workforce? Do we have enough doctors to patient ratio to offer patient-centric healthcare? What about public versus private care and access and equity in access? And then are we building a robust research and innovation pipeline to support personalized medicine solutions in our healthcare system? And do we have a thriving digital health ecosystem as well? And so, these are the endless questions that we need to tackle if we want to evolve to patient centric healthcare. Now, the global north is moving fast to revolutionize medicine towards personalized medicine. Modern medicine is evolving in the age of digital science and artificial intelligence. We're seeing the costs of omics technology becoming more cheaper, more accessible, and more driven within the clinical setting, and they are more cost effective. And obviously, sustainability is now becoming a key factor in healthcare as we look at healthcare costs also rise. And personalized medicine is seen as that key to not only drive research, but ecosystem development and ecosystem enablement. So, around about 2021, we joined the European African Personalized Medicine Project. This was set out to facilitate and strengthen research and innovation collaboration between Europe and Africa in personalized medicine, fostering joint projects and programs, as well as facilitating the participation of African organizations in the International Consortium for Personalized Medicine. It is a coordinated support action under ICPERMED, and you will hear Monica give you a very strong understanding of how ICPERMED is structured and that whole skeletal structure behind ICPERMED, EPPERMED, and the other co-fund initiatives that have taken place through Europe. And the project started around 2021 and will end in July 2025. And it's funded through the European Commission Horizon 2020 research program. Essentially, it's made up of 13 partners. Those from Africa, representing the different regions in Africa, South, East, North, and West. And then we have partners that are in Europe, based in Spain, in France, Italy. If you think about what we envisaged to do and what we achieved, so we started off by mapping to understand the scientific and policy landscape in Africa, identify and contact stakeholders and develop a robust stakeholder database, look at the potential for cross-border collaboration, how do we drive the science to policy area, and how do we facilitate this through the International Consortium for Personalized Medicine, and building capacity as well as being able to disseminate all of the outputs from the program. Our main outputs, we've got a lot of relevant documents that have been developed in publications to understand the African context for personalized medicine research and innovation. We've output a mapping report, giving you a policy brief, opportunities to advance personalized medicine in Africa, a list of needs, gaps and needs analysis as such. We supported translation of personalized medicine research into practice, looking at hosting webinars and understanding and sharing what's being done, what can be done, how do we foster the way forward, and supporting the setting up of regional personalized medicine stakeholder groups and consortium from the Southern group, the Eastern group, the Northern group, and Western Central group. And just to give you a broad understanding in terms of the dynamic in Africa, often enough it's mistaken to be one country. But, Africa is vast. It's quite massive from north to south, east to west. And we found that if we could at least categorize countries, rank them, and split the continent, into different regions, we could then look at the strong countries and start developing initiatives within strong countries to actually develop more regional focus and have those strong countries then regionally develop Africa. And that's kind of the idea we want to try and push. So far, we also have 3 African members, organizations that are now part of the International Consortium for Personalized Medicine. We have developed a very concrete EU Africa Permit action plan. It's a roadmap for facilitating and fostering and promoting collaboration for Africa. And, we were also a project that was selected to contribute to the EU-AU innovation agenda. And we launched a Dakar Declaration in June. So just to give you a little bit of understanding on this action plan that was developed. Essentially, it's a baseline to developing that policy agenda, addressing the gaps and needs that were previously identified and transforming these into concrete suggestions for the South to South collaboration, South to North collaboration, including 26 distinct topics of collaboration formulated as research actions and research supporting actions. And, how does that translate it for South Africa? We've become part of the project. We've become part of ICPIRMET. Well, essentially, firstly, South Africa is one of the first sub-Saharan countries to have a precision medicine research and innovation agenda in our research and innovation policy. So in 2022, it was also easy for us to join ICPIRMET with focused funding in this area and a small research portfolio at the time. And then through our government, we also were supported to be part of the co-fund called the European Research Area Network in Personalized Medicine, which Monica is going to tell you more about as well. And obviously, what have we also benefited from the project as such? Because as South Africa, we ran the Southern African Regional Stakeholder Engagement, and from this analysis, we then moved towards developing a national genome program, and that could be leveraged to support sort of Pan-African initiatives as we realized how South Africa has played a role within the continent. And in July 2024, I was appointed as the vice chair of ICPIRMET, being able to actually have a seat at the leadership chair to direct and to initiate and to help develop our country's context through the platform of ICPIRMET as well. And in December 2024, we just recently joined the European Partnership Joint Transnational Call in Pharmacogenomics, where we're looking to have a large-scale research being conducted transnationally between South Africa and other participating countries, as we are now going through the process of looking at applications that come through that. And we've just recently also become now a member of the European Personalized Medicine Consortium. So, what is it to build personalized medicine? It's about developing an ecosystem, and it requires a global community. And there's an African proverb that if you want to go fast, you go alone. But if you want to go far, you go together. And with that, I'd like to say thank you so much for your time.
Thank you very much. Thank you very much, Rizwana. That was a very nice example, really, and I would say also a success story within ICPIRMET, how a process can be really very systematic, be organized, how to involve the right policymakers, funding organizations, etc., and to move forward. So thank you very much, Rizwana. Are you still joining, or will you be able to? Thank you very much. Then I would like to hand over to Monika Frenzel, but first I would like, of course, to introduce you, Monika. Dr. Monika Frenzel, she is from the French National Research Agency in Paris, and she leads the working group on the internationalization in ICPIRMET, and also in the European Partnership for Personalized Medicine, EPPIRMET, which is a new funding scheme. She's coordinating the activities of personalized medicine research-related funding and support. But Monika, that's not this. You are really, from the beginning, one of the founders and really driving force behind the International Consortium Personalized Medicine. And we are here now, I think, really because of mainly you. Thank you, Monika.
Thanks a lot, Angela. That's too much for my presentation, for taking time, but it's great to be here, and I would like to thank you all for being here, especially also to the panel. Thanks, it's a very important discussion. It's a first starting point, and I hope it is really a start for longer collaboration coming afterwards. It is a pleasure also to speak after the first two speakers, because you said so well the framing. Angela, I agree with you. Amar, it was a wonderful presentation to set the stage for India. And after these 2 days of meeting here, I can say, from my perspective, India is ready for personalized medicine. And I think we really have to see how we foster collaboration across borders. And also, I would like to thank Rizwana, because I think what we have to remember when we are thinking about new concepts, personalized medicine is not changing of, it's not a new disease field that needs to be explored. It is it's a changing of a concept. It's bringing the patient more into the center, and it takes time. And this is also what I would like to show a little bit with the story of IC Permanent. And when I was looking at Rizwana's last slide, specifically how fast things can go when you are joining also a consortium, you are joining, learning from others, and then you can bring new ideas and technologies and concepts in your country. Yeah, as a framing that Amar was already starting, but I would like just to underline what we noticed with personalized medicine, and you are all in collaboration. Collaboration can only start if we are having a common aim and a common goal. And sometimes it's simply a definition. So what are we talking about? Where do we want to arrive together? So everything started in Europe in around 2013, 2015, with a first definition of what is personalized medicine. It is very short. It could be much longer. There are much more points to say. But independent of what term we are using, precision, personalized medicine, 3P, 5P, there are stratified medicine, there are many terms. It's not important what is the term we are using. It is to understand that we are coming to an era soon where more and more health data are available electronically, and new technologies are coming up. And we can use these technologies and data even better to even prevent diseases, but also to have better diagnostics and to make, as Amar was saying so nicely, therapy more tailored. So to bring the patient in the center and to go away from a general approach of providing healthcare. So where's IC Permanent acting? And what we have to do is in fact this. Our current healthcare systems, they try to be efficient. They are working how it is shown on the left side. A patient is coming to a hospital, a set of patients are showing the same symptoms, and we are putting them in the same box, we are treating them the same way, but what we noticed is there are some patients that, of course, the treatment is working, they're happy, and they continue their life. Some, they have no effect, so the treatment is not working, and even worse, some, they have really adverse effects. So we are starting a trial and error, changing the system process for those patients, what means we have a waste of medication, a waste of healthcare forces, a waste of time, and even we might lose our patients and citizens. So it is really a system that is not efficient. So where now personalized medicine and IC Permanent would like to act is to open this box and to look inside, to have a better stratification of patients. Maybe even to develop new technologies, to go to rural areas with telemedicine, for example, but also to start with prevention, avoid that the person is even getting ill, and of course to have the right treatment for the patient, and also to help the patient to follow the treatment in the right way, but also working with clinicians, with the healthcare providers to be able to provide personalized medicine with the right technologies, decision support tools, for example. So overall, we of course hope to have our patient, as on the right side, being more happy and staying a part of our society. So the journey, and this is why I would like to take away the pressure. Personalized medicine might not be tomorrow. Sometimes it takes time. In Europe, it is running very intensively since 10 years. The first strategic research and innovation agenda focusing on personalized medicine, a new concept at that time, was developed by a first project in 2015. And I very much like this picture on the right side, and I heard it a lot during this conference. If you would like to advance, you have to bring every stakeholder around the same table. And this is somehow what this picture shows. In this case, the researcher, the clinician, the patient, the healthcare provider, but also the payer specifically, and the policymaker. So that is what this first agenda is showing. Based on this first agenda, the different countries have decided, okay, we need to work on this, to push strategies, to push policies. And this is why IC Permit was created. IC Permit consists of policy organizations only, ministries of health and research, funding organizations. Why this high-level platform? Because those are the organizations that can develop strategies, but they are also in the first position to implement them. For example, through research funds, etc. So it's really, they didn't want to just to create a tool that is developing strategies, but nothing is coming afterwards. So you can see also IC Permit on the right side. There are some of the different strategic documents that were already developed. But most importantly, being part of IC Permit is participating in really activities that are pushing personalized medicine. Rizwana mentioned specifically one that is a funding program. For example, IC Permit members in 2017 have decided to create a funding program. It was supported at this time with the co-funding through the European Commission. But important points were different funders have decided to push together research. Instead of funding research in personalized medicine only in individual countries, so duplicating efforts, they have decided to join and to launch calls together. And we had over 5 calls, 42 different funders from 32 different countries, from Europe, North and South America, Asia, and Africa participating in the calls. In 5 calls, we have in totally funded 111 projects with around 130 million euro. This is enormous, and it was of this kind of program, the biggest one that have funded the most projects and with the highest budget for a very new topic at that time. So here's already a success story. This is now ended. But also IC Permit partners participated in other initiatives, pushed reflections, for example, on implementation. What is the specific needs for clinical trials? What is personalized prevention? What is the health economic part? So we talked also about HTA in this conference. And also the international perspective. So these are the ones in yellow that are highlighted. It is important in this topic to work internationally because we have drugs, and you will know it. Drugs developed on a certain clinical setting. The drugs are finally approved, and then they are on the market, and we notice they are working potentially very nicely in Europe. But then we are coming to Africa, to Asia, to maybe South America, and they are not working anymore, or they are even harmful. And we can only avoid this if we are starting to work from the very beginning together and to bring together different data sets. So there were already many organizations who have joined and have understood this benefit, who have joined IC Permit. I highlighted mainly those that are not European, we are really happy, for example, so on the left side you can see the countries that are already part of IC Permit. Just to let you know that it's a high policy platform, we have also even the European Commission being part of IC Permit. And on the right side you can see the different outreach we are having and candidate organizations and countries that are just before joining the International Consortium for Personalized Medicine. And I sincerely hope that soon we have also India joining the International Consortium for Personalized Medicine. It's a platform, maybe I didn't mention before, that has no end. So this is a platform that is running endlessly as long as there's interest to push together this agenda. And if I talk about agenda, and it's one of the most important agendas that was just recently launched or published, it is the new Strategic Research and Innovation Agenda for Personalized Medicine. And just to show you what IC Permit can push as activity, so based on this strategic and innovation agenda, a new program was launched. It is a European Partnership for Personalized Medicine, and sometimes also for policymakers we have to talk in numbers. So it is a program that is of course running for 10 years, so has an impact, but mainly it has an impact because there's really a budget behind of 375 million euro put on the plate also from the European Commission, but to the biggest amount from the different members being part of the European Partnership for Personalized Medicine. We just learned from Rizwana that also the SAMRC, so South Africa, is going to join this partnership. But IC Permit is, to come back to IC Permit, who can join? So I would like, this may be a discussion also for today, to have an Indian organization or more joining IC Permit. Who is able to join? I said it, IC Permit is a policy platform. So it is open for ministries from health or research or others that are supporting health development and for funding organizations. It is not eligible for research organizations, but just as I explained, because we would like to have the implementers sitting around the table. It is easy to join. We request a letter of intent, a contact form, and a letter of motivation. It is, as I said, a strategic platform. What is really the advantage? There's no buy-in necessary. You don't need to come with a budget. We ask you to come with the will to exchange, to share knowledge, and also, well, to actively be there and be willing to push the agenda of personalized medicine. What is the advantage to become a member of IC Permit? Yes, of course, first-hand information. Learn from others to avoid making mistakes or to not do the same challenges in your country. Going fast, I had the feeling when I listened to Rizwana, this is exactly what happens in South Africa. Sharing and promoting activities, make everyone aware of what is happening in your country. So that there is a network created where, for example, Indian organizations are part in research, but also connect patient communities. And then, of course, being there when new strategies are developed, place the needs of your country in the strategies that are published. Yeah, so I talked already too long, and I would like to underline that we are hoping to have India joining IC Permit, and I would like to thank you for your attention.
Thank you very much, Monica. I think that was really a great overview. And yeah, so the success story, I put it like this, is really that it started not like a regular project, but really to get the high-level policymakers funding bodies into it. And I had the pleasure to be on the advisory board and also from the very beginning. So I'm amazed how it really flew. Now I would like to give introduce to you Dr. Taruna Madan-Gupta. She's a head of the Division of Development Research at ICMR. And when we talked, Taruna, I think 2-3 years back, we visited you and your team, and it was about regulatory issues. And then I mentioned IC Permit, and then you said, it should not happen that India is not part of it. And so thanks also, you had been always really, we talk about an enabler also in certain areas where we had the pleasure to meet, HTA also and others. So you are in your team, in your division, you're spearheading the ICMR's new initiatives to strengthen the medtech innovation ecosystem, and there is, and I think you will talk about it also on medical devices, for example, the medtech Mitra, then also phase 1 network intent, for example, and also, and that's, I think, very important in this context, also coordinating the ICMR's extramural grant support to investigator-initiated research proposals from institutions and medical colleges across the whole country. And but also I would like to mention just that you are a really outstanding scientists, having been abroad, coming from immunochemistry, but you have been in Oxford and Harvard, and also the former president of the, is it true, the Indian Immunology Society, and yeah, now the floor is yours, Taruna, and I think you have a lot to tell us.
Thank you, Angela. That was a very kind introduction to the roles that I play at Indian Council of Medical Research, and definitely I have been a bench worker for most of my life, and now I come to the other side of the table and become a funder. So both the experiences have enriched my thought process and my perspectives about things. And personal medicine is definitely a goal that every human being aims for. When you are taking your parents, for example, to a hospital, what would you like them to have? Or your children, you would like them to have a personalized attention, personalized care, personalized medicine, because that is the key to their getting well soon. So that is the whole thing, and our Prime Minister thinks about the whole country the same way as we are his children. So the idea is that personalized medicine implementation across a big country like India definitely is challenging, and we have lessons to learn from what the African countries have come forward with and what are their experiences, and we will definitely learn from the Europe and African collaboration which has been ongoing for last 5 years. So the challenge is that we are still struggling with conducting clinical trials for those medications that are required en masse. So personalized medicine definitely comes the next. But it doesn't mean that we are going to be left behind. For example, India has got their own CAR T cell therapy now, which is at 1/10 the price of what it is available globally. And the CAR T cell therapy is definitely a very good example of personalized medicine, although it is not too personalized, but definitely we are able to stratify the patients, and then we are able to give them the right medicine. So you are taking the cells out from the patient, you are modifying them and giving back to the same patient. So it is a personalized medicine, but the antigen receptor that you use, the chimeric antigen receptor that you use, that is a common one, because we know that all these patients identify a common antigen on the B cells that are lymphoma afflicted. So this is the pathway that we are following. It is a challenge for the industry as well to come out with therapies which are so individualized, because the kind of challenges it has is that even for rare genetic diseases, we don't have solutions in India, and we are really struggling to meet that end. And when you go for personalized medicine, it is even at that micro level. So how to go to that level at that nation where the per capita expenditure for R&D is still very, very limited, though we are really moving forward. It is not. For example, ICMR's budget has grown almost 5 times in the last decade. So that is a promising note that government is ready to spend in, and the kind of innovative ecosystem that we are developing at ICMR is also giving us a hope that yes. And as as Amar sir mentioned about the Genome India program, so we do have our genome sequencing now available to every researcher, that they can think of personalized medicine. For cancer, we already have identified panel of mutations that are happening in Indian patients. And for example, I'll just give you an example of stratifying the patients and groups of patients, because for breast cancer, for example, you have those 3 markers that we screen for. And if you have HER2 antibody, and if you are HER2 positive, you can give that monoclonal antibody to only those patients who are HER2 positive. And if you are responsive to hormone therapies, you are expressing certain markers, and we are evaluating, diagnosing for those markers all breast cancer patients, and then they are giving kind of a personalized medicine. So we are doing our bit. It is not that we are not, but not at that massive scale that one is looking forward to, and that is where we would like to become a part of IC PersMed, so that we can learn from you and don't make the same mistakes, and the kind of strategies that you have built, and if they can be adoptable in the Indian environment, we would like to definitely catch up on those lessons. And to tell you about the Indian ecosystem or the ICMR ecosystem that we are making. So we have built a national network, as I was informing the audience yesterday, that we have a 75 sites, big national intent network, which is carrying out regulation compliant clinical trials. And these are late phase trials, phase 2 and phase 3. Another important thing is these are made to de-risk the industry. So for example, if the industry has a molecule for a rare genetic disease, say type 1 Gaucher's disease, Zydus came forward and they said that we have a medication. Would you like to invest money? And so we are doing the trial on our own. The molecule is given by Zydus, and we have our own sites and we are funding our own sites, and we are getting that medicine being tried upon the cases, and then this is a phase 3 trial that we are doing. So this is, and as you mentioned, we do have a phase 1 first in human safety network as well, where we have 4 sites across the country. One is in Chennai, SRM Chennai, another one in North is PGI, and then we have 2 in the West. We don't have yet in the East, and the expansion is on the horizon because we were waiting what kind of response we get from the industry and from the innovators, and then we will be expanding it. So these are Center for Advanced Research. They are built with all the capacities needed to carry out a globally competitive phase 1 clinical trial in India, and we are expecting that more and more innovators and industry will come forward. And the other thing that is at a very ground level, where the innovators are actually working in their personal spaces, or maybe in institutions, but they do not have an idea how to take their innovation forward to the last mile, to the logical end, reaching out to the patients. And for that, there are valleys of death, and we all who are working in the pharma space are very well aware of these valleys of death. The first valley of death is that you have an idea, but you don't know how to work on it. You need partners for it. We see to it that whoever is coming through the MedTech Mitra, which is just a 5-minute application online portal, that you reach out to us. So it is not that the government is not reachable to you. And an immediate response email goes, an auto response email, which gives you an application number, and we reach out to you within a week's time. That is the goal we have set for ourselves. Within a week's time, we will be reaching out to you, and then we will ask you for more information that is needed, and we will be signing some agreements if needed, because if you have intellectual property and you would like to not reveal to that extent, so we sign agreements with the innovators, and then we take them forward. So the next step is that we give them regulatory advice, we give them Atal Innovation Mission incubators to make their prototypes. We fund them to give proof of concept through our extramural grants, and they are small grant, intermediate grant, and Center for Advanced Research, and including now the first in the world challenge that we have floated. So the important thing is from there, when you have the proof of concept, many of the innovators just stop there. They have achieved a patent, they have achieved a publication, and they move on to the next innovation. And now who takes care of that? So that is the responsibility that we have taken, that we will be pursuing with the preclinical, the clinical studies with the ICMR grant. The innovator just has to reach out to us that he has reached this stage, he or she, and then we take it forward. And after that, we have Department of Health Research, which are doing health technology assessment. And we have a Center for Guidelines in case there is a new innovation, a path-breaking, groundbreaking innovation, which needs change in the guidelines. So we change the guidelines to suit the new innovation that has come in. And then we take it forward to the government procurement system. then we need to do the field feasibility studies. So the clinical trials are at the institutional level. They have not checked the feasibility of adopting that or implementing that innovation in the field. So we have field feasibility network through our model rural health research units and multidisciplinary research units, almost 200 of them across the country, where we carry out these field feasibility studies in collaboration with NHSRC. We also have on board Department of Pharmaceuticals working hand in hand, because we need to have those test licenses and the manufacturing licenses which have to be granted to industry. An institution is not recognized by our regulatory body as a trialist. We need to have a sponsor, and the sponsor is the industry, because there the rules and regulations have to be followed. And so the Department of Pharmaceuticals is playing a key role through their PRIP mission. They are funding the innovative industry, the research and development in the industry. And that is not a small grant. It is a 5,000 crore scheme of Government of India, which is going to really be a game changer for Indian innovation ecosystem. So once these innovations come forward, and we do have already in the grant programs, people are doing omics studies, descriptive data. We have, images, databases that are being developed by Indian Institute of Science, and they are now available at the MIghty portal, which we call it as AI Kosh. That is, artificial intelligence Kosh means treasure. So India is creating and moving forward towards personalized medicine through all these efforts. Thank you so much.
Thank you so much. Thank you so much, Taruna. I think this was a lovely overview, fantastic overview. And I think now we have to catch up. In other countries, it's really, having been now 12 years in India, and I have to say, yeah, I can see that maybe, and India, the biggest country, may lead the way. Yeah, maybe we will see why in our next discussions also, why I think this is really how it's going.
So our visionary leadership has given us that there are 3 very important C's that we need to follow. And what are they? Collaborate, collaborate, collaborate. Right. So that is what we expect, that if we become a part of the ICP Med, we would like to be, collaborating with you, learning the lessons. And of course, it is a mutual sharing. Whatever lessons you get from India may be applicable to other developing countries as well.
Thank you so much. And now I would like to introduce to you the next speaker, Dr. Sindhura Kanapati. And you are of the office of the PSA, Office of India, the Policy Science Advisor, but you are coming from another field, not another field. It belongs, and we forget often about it, very much to personalized medicine. You are a veterinarian originally, but you are spanning a lot of fields. And also sectors, so clinical medicine, biomedicine, then also business development. You also have worked in global health and in policymakers. You had been the deputy director to the president of Global Health Division and program officer of the Gates Foundation. And you worked in areas like One Health very much. So you're really bridging sectors, I would say. And maybe this is your head you have today in the discussion. And so I would like to give the floor to you, dear Sindhura. Pleasure to have you here.
Thank you, Angela. Very generous of you. And thank you for making me part of this session. And I asked this to you and Anurag, why am I here? And I don't know, hopefully towards the end it'll be a little more clear then. So my perspective also will come from that point of view of being complete outsider to this. So I struggle with this topic. I'm just going to share things. It's a pretty intimate setting for a personalized medicine topic. We are in a very intimate, personalized setting, so we can have a discussion on this. So the reason I struggle with this is the definition of personalized medicine. For me, I'm from a pharmacology background. I'm a huge fan of technology of all kinds. I'm a kid in the candy store, any type of technology, funding them, being part of that global system. But I'm also becoming more of a technology skeptic. Omics, all kinds of omics. I funded them, in touch with global leaders on that. So for me, the personalized medicine, even going back to my pharmacology days, has this heavy bent of genomics, other omics, tools, and technology centric. If I go to first principle view of what is personalized medicine, for me as a person, either preventive or curative, I would like to get the best care possible. It's as simple as that. Now, if I have lower back pain and I need some care, what all could possibilities? I would like to see that person who is addressing me look at, is it because I am stressed, which is more of a mental health or that side of things? Is it because of bad posture, takes me through a different trajectory? Is it because I have some underlying conditions? Then comes a lot of biomedical approaches. And I could go on. And treatment also is the same thing. What helps me more? Is it a good Ayurvedic massage or a little more difficult approach of exercises and things I need to do? Physiotherapy, that's the word I was looking for, thank you. Or a guidance on diet, or what to eat, what not to eat, or counseling if it was related to. See, I don't see anything about omics in this at all, at least apparently. You could make a case for anything in omics. On the other hand, if I end up having something to do with, say, AML, acute myeloid leukemia, I would want all kinds of typing done. Cytogenetics, sequencing, HLA typing, bring it on. Therefore, now coming back to now the issue of where I see India, having grown up here, having gone out, come back, there is, I find, a huge spectrum of thought processes that I would love to see bridged. The scope of what the Ayurveda and other traditional medicines that look at it from a completely holistic view, and the advancements that happen through allopathic and model biomedical medicine. There is an amazing new thought process, completely different from the way I even think about it. That requires, I think there is a way to think about it, even in this space. For example, I had personal examples of seeing some of these. An Ayurvedic doctor who used modern medical, he used what Sushruta said is one of the Ayurvedic person from thousands of years ago. He uses that today, but he blends, he gives anesthesia. He gives, not like holding 4 people when the anesthesia wasn't around, right? So blending from that perspective. And for my own mother's diabetes, I type 2 diabetes, went around looking for physicians and finally found one doctor. Low-key, house-like setting, and he's a MBBS, the allopathic doctor, bringing all the aspects of things that usually in medical field they don't teach. What to eat, can you eat papaya? In the nutrition of modern medical side is very rudimentary, I would say. I've worked in nutrition field. Whereas in this case, in the Ayurvedic system, it is, I think, very advanced. So finding those good things and blending. Therefore, when I look at this aspect of where does personalized approach sit, we have to think from both biomedical research perspective, how you develop drugs or therapies, etc., even how you test them. The clinical trials and the randomized clinical trials and statistics don't lend themselves nicely, cleanly for these kind of fuzzy things. We have to reimagine how clinical trials and outcomes are assessed. And second, in how the care is provisioned and how the education itself, medical education and medical education in terms of broad medical education, not just MBBS, nurses and physiotherapists and all kinds of things. And the blending of these so-called Eastern and Western thoughts of approach. So I would like to just think about this in three categories in the context of India, and I'm very happy to hear what Dr. Taruna said. It's not that in India it is not happening at all. It is happening extensively. Like currently I have a close relative in the hospital going through AML. That's why I use that as an example. And all of this is being done extensively. And on the other hand, we don't want to fall into the peril of, I have this fancy tool called omics. Originally it was genomics, then came proteomics, then metabolomics, then epigenomics, and then big data. And it's an increasing funnel. It's a fancy tool where what are the nails I could hit with it. It's a very dangerous, slippery slope. And costs, yes, of omics are coming down. Yes, it was, previously costed 1,000 times. It is less now by 1,000 times. But I do not see a future where anywhere that it broadly applied indiscriminately. I think we should be very careful about that. And therefore just categorize this. There are areas where it is three categories. That's my last comment. Very clear where it is applicable. Today it is pretty clear, like the cancer example I gave you. And then there are areas where it is quite questionable to a common sense perspective. And then leave them out for now. And then in the middle, there is a lot where we are unsure. I think that's where a lot of discussions and thought process happen. So to answer the question on should India be part of it? Absolutely. Because I love that 3 C's. Because you learn a lot. But I'd also like to go at it from a purely first principles perspective to ask, where does this thought process sit? So we may end up with a completely new paradigm itself rather than scaling the current paradigm. Thank you.
Thank you so much. Thank you so much, Sindhura. And I think really I cannot echo more also the role of the traditional medicine, because I think we are stuck in the moment in the Western medicine because we have a bias. We have a bias that we, I think the Ayush biology, the doshas, so the first stratification of the whole population is truly individualized. And then Western medicine came and was stratified. So pushing you in a stratified concept, although you had been very individualized. So we had one panel also, keynote panel was on that field. And so I asked, shouldn't we turn around the question and say, how can we include Western medicine into traditional medicine? So to start with such an individual stratification, because we go on with biases, systematic biases, and we will not get there where we want to go. So that's another reason, I think, why one could say Indian will lead the way. It's a new paradigm, so thank you very much for this. Now I would like to introduce to you Dr. Pooja Jha. Jha, no, is correct, Pooja. You are the founding editor-in-chief of the Lancet Regional Health Europe, and you are also the co-chair of the group of the Racial Equity, CRACE, which is advocates for the opportunities and resources needed to achieve racial and ethnic equity within and outside the Lancet group. And before, you had been with the Nature group in the Nature Metabolism. You are by training scientists. We have a common dot, how to say, both, that is MAHE, Manipal Academy of Higher Education. You have a background in life sciences, and you're bridging really India and Europe, because you're based now in Europe, in Germany, but your training was in Bangalore, at MAHE, and also in Austria in the end. So now your floor is yours.
Thank you, Angela, for this kind introduction. And firstly, I'd like to thank you for giving me the opportunity to be a part of this platform. So really thank you for that. So for me, as an Indian who's been in Europe for the last 15 years, and now I champion European science and European personalized medicine, so it's really an honor for me to sit here and advocate for India's inclusion in International Consortium of Personalized Medicine. And whatever I will talk today is more focused on science, hardcore scientific data, and what we see published in major scientific journals. So when it comes to personalized medicine, the basic ingredient we need is diversity. If you don't have diversity, personalized medicine cannot reach its full potential. That's the bottom line. And this is where India comes in. India is the only country with the highest genetic diversity. We have around 4,600 distinct population groups in India, which is unparalleled. We don't see this anywhere in the world. And this is very important. The diversity and the diversity of genetic data is very important for personalized medicine. Now, personalized medicine is very advanced in Europe and in US, but still, it hasn't reached its full potential because we don't have genetic diversity in Europe. We don't have genetic diversity in US. So even the West is at a loss with not including countries like India or not having the diversity of African continent in the personalized medicine space. So at the global stage, the whole global world will benefit out of including India in ICPERMED because we will have such a rich genetic diversity. Now, even if you take the whole field of personalized medicine, it's not that advanced because it's only in cancer, in oncology, and rare diseases that we see more use of personalized medicine. And even if you take oncology, only less than 10% of cancer cases can be treated by personalized medicine. And this is because we don't have the genetic diversity at the genetic level. So we need more diversity, we need more genetic testing. So in India, we have such a diverse population. Where we are lagging behind is genetic testing and more clinical trials. It's encouraging to hear from Taruna that more clinical trials are happening, and I would love to publish the phase 3 clinical trial at the Lancet, so please send it to us when it's ready. But we do need more, and we are seeing in the past 10 years, of course, all clinical trials are dominated by European population and from Americas, but now China is picking up. In the past 10 years, there's been an explosion of clinical trials in China, which will benefit the Asian population. But it hurts me to see that we don't see a lot of clinical trials from India, and I would really, really like more clinical trials from India, because that is where we can benefit out of personalized medicine. And just to give you a statistics, globally, 1 in 30 individual is a migrant anywhere you are. But if you take Europe, just Europe as an example, 1 in 8 is a migrant. So even with the high level of personalized medicine that is there in Europe, it's not serving European population because 1 in 8 is a migrant. And if I can take example of 2 recent drugs that have been like blockbuster blockbuster drugs, semaglutide or Wegovy, commonly it's, yeah. So it was tested in European population. We still don't know if it works as effectively in Asian population. And the second blockbuster drug is lecanemab, donanemab for Alzheimer's. Again, in US population, European population, we don't have diversity there. So we need more clinical trials from diverse population. And one thing that Lancet has started doing in the last 2 years is that whenever we get a clinical trial, we go back to the authors and we tell them, give us data of stratification of your patient data from ethnic and racial point of view. So they need to record what was the background of the patient, and what was the ethnic and racial background. And if they don't have the data, they need to write in the paper why they don't have the data. And the whole point of doing this is that next time when trialists do trial, they think about this. They think that they have to report the data from different ethnic background. And I think this is very, very important, and we should do this in India as well. You know, India has people from different states, so much of diversity, and I think clinical trials should report the ethnic and racial data of all the participants. This will be a huge step towards personalized medicine. And just the last point, now we are living in a very precarious geopolitical environment with what is happening in US. Trump has doubled down on EDI, the Equity, Diversity and Inclusion Studies. Fundings have been cut, which means that Europe and the rest of the world needs to unite to uphold scientific integrity. And I think it's a big opportunity for India to partner with Europe and stand up for holistic science for personalized medicine. So thank you.
Thank you very much, Pooja. Thank you a lot. Thank you. And also your offer really to publish real time, and maybe it could be even a series in your journal about that. And now I quickly introduce Helmut, Dr. Helmut Brandt. We have a personal and private and professional journey for the last 30 years. It's not easy to introduce your husband. Dr. Helmut Brandt, he was a founder, director of Prasanna School of Public Health at Mahe for the last years, and now ranked number 2 in India. I think this is really nice. But he is a professor for European Public Health at Maastricht University and worked on European integration, Global Health Europe, so Europe going global, and also was leading the European, president of the European Health Policy Forum, so also a little bit policy background. Helmut, you will summarize the discussion, the takeaway key messages. So you have we'll wrap up in the end. So I would now give a little bit more time again to before the floor is yours to Dr. Patnaik, to Amma, and because I think we need to understand also how politics works in India, and it's very complex. The national level, the state level, then also what are the responsibilities, and also to tell a little bit about Unite. Again, and maybe to summarize, and also because you have been very active also in digital health, to bring this component maybe in it.
Thank you so much, Angela. I think we've had a brilliant discussion on this topic. Personally, for me, it's an extremely knowledge-earning session for me, actually, because one has got to know what it is. But I just thought I'll respond to some of the discussions. I may be corrected if I'm wrong. I don't think I see personalized medicine would supplant the existing
medical ecosystem that we have. So if it doesn't supplant, then I think the first clinical reactions or whatever we are doing so far will probably not get eradicated or completely get erased. If I'm right on that front, then I think personalized medicine would probably increase the chances of preventive action in a scale which is better than what you are having, but doesn't really mean that you have to get into a personalized medicine system in which is not probably necessary to administer a drug, because you can actually take care of it even without it. So I think it shouldn't supplant. And that's what I'm just trying to react to, Mr. Ganapathy, because I thought he was suggesting that it would probably supplant. It will not supplant, it will be there. However, his point relating to merger of traditional medicine or the synergy that can happen with traditional medicine and the existing medicinal ecosystem that you have is a continuing discussion that is happening all over the country, and I think even globally at some level, and rightly so, because the benefits to population can come from this synergy. But once again, I thought, since you talked about politics, I spoke in Parliament once relating to this issue of whether we can have the three different fields of medicine to work together. It can work together only if the basic belief system or the basic principles and assumptions of the three systems are same, which is not the case. So to artificially try and merge it may not really work. I have spoken in Parliament on this. But coming to the question of politics, health is a state subject in India. State subject in the sense the provinces of the states have the right to administer health policies. But what we see in India is that health and education, the two most important social sector schemes, the national level policies are made by the government of India and has worked very well. The implementation part has been left to the states, which are in the best position to actually deliver. Because if you take 60% to be living in rural areas, depending on primary health care and the primary health centers and sub-centers, it is important that the infrastructure and the knowledge and the technology, everything improves there. I see, however, a big equity issue in personal medicine, because I think it should not so happen that it only gets delivered at the tertiary centers and not at the primary centers. To deliver it at the primary centers, it has to be a part of the universal health care system, which is a very tall order. But it can happen. The states have been, engaged. I think most of the states are engaged more in delivering this, get people into the universal health care as a kind of response to a disease. So it has to be equitable, it has to be affordable, it has to be accessible. To go to the next level, which is of personalized medicine, would require, as I said, a lot of investments. While research can take place at the central government level, which is the place where it should be, and I was just talking to Dr. Gupta relating to the huge amount of data that we have. I thought I would inform you. We have the National Health Observatory, about which I really didn't know until recently, which developed during the COVID pandemic. And the enormous amount of data that is available, I don't think it will be available anywhere globally. I've taken British and German, a cross-section of members of parliament from other countries to the observatory, and they were amazed. So I think we have the data, we have the technology, we have the brilliance. We have to actually merge these two, but the big challenge would continue to be how to take it to the primary healthcare level or universal healthcare. Most of the politics in India is more at the level of health not being accessible, health services, healthcare not being accessible, medicines not being affordable, generic medicines may not be working, may not be cheaper, affordability is the issue. So politics currently, the political discourse, the narrative is at this level. To take it to the next level would require a real huge effort by the political class. But one thing good is, health and education go beyond political parties and political ideologies. Everybody in every political party would want that every Indian gets proper health care, gets affordable health care, gets health care whenever it is required, and the best possible health care. If if personalized medicine can be introduced, taking care within this framework, then I think the political class will put it on their agenda in their manifestos, that I ensure that in the next 5 years when I come to power, I'll ensure that in these villages or these panchayats of India or in my province, I will have personalized medicine to this many number of people. But even at a suboptimal level, you have, let's say, Japanese encephalitis in Orissa in a particular region, sickle cell anemia in a particular region, not all over. So if those small communities, not at the very personal level, but at a semi-personal, I think at a community level, if it can be delivered, I think it will be a huge benefit to the people, and it will actually have a lot of political traction. This is all I have to say. Thank you.
Thank you so much. I think you really showed a way how to go, how to. I think this is a signal. We are close to. I think we should. Yeah, it's just a start. We have to continue. That's very clear. Shall we allow one question from the audience? Yeah, one or two questions from the audience, please. Please. The mic is shared. You can have my mic. Yeah, you can come to the front. Fine.
So thank you very much, the panelists, wonderful sharings, and this is Tuyen from Taipei Medical University, and I'm also advisors for some hospital in Vietnam. We know that personalized medicine is very important, but we concern very much, just now you talk about the genetic diversity and going to the therapy treatment, and we start from the personalized screening, diagnosing, right, treatment, and prescribe and many other things. So we concern very much about the infrastructures, right, including the human resources and also facilities, and also the all of the process to personalize all of these activities in hospitals setting. So if you have any pictures about how we're going to do this, how to convene the leader, policy maker, and so hospital leader to implement this in the short run, not 5 or 10 years, but as soon as possible. People talk about personalized medicine in many parts of the world, but we see that not many implement it successfully. Just do it for a certain period of time, and they stop it, and they back to the traditional manners, right? And especially when we talk about traditional medicine, the traditional medicine, you know that how you get the bag of the medicine. It's not really personalized, and how we can do that with traditional medicine also. That is a complex of this combined this question. Thank you.
Just to also say you are leading also the health literacy chapter in Asia also, and I think that's also if you brought in. Who would like to answer, please?
Just a quick reflection on this. So, to tell you the fact, on ground, no healthcare system in the world is presently equipped to integrate personalized medicine full scale in their health system. This is a fact. So we are still not there. We are very, very far from implementing it on the ground because we need a lot of work before that, and I think we need a lot of money. That money should come from private investors, from these tech pharmas, to upscale and to make the testing very cheap. Once we get to the cost effectiveness level of personalized medicine, we can then talk about integration. Right now, it's very specialized, mostly for oncology and rare diseases, but we are still not there.
Thank you.
Yeah, maybe to answer, well, I don't have the 100% answer, but I think what we need is, yes, infrastructure is needed. But again, personalized medicine is not something that is going to be invented. It is something that is coming naturally because diagnostics technologies are developed. They are used by the private sector. We might not think about omics, genomics as a public system. The private sector will do. I don't know how many of you had the possibility in Europe, it's so fancy now, to give a sample and to get your DNA analyzed, and you get a mini percentage of the information of maybe where you come from, and the rest is used, and you pay for it. And there is personalized medicine being developed by the private sector because they see the benefit. And I think we should not lose the public sector. We should not, I don't want to say control, but we should not use the advantage to make our public healthcare system better in being prepared. Now, developing infrastructure. What I can see is, this is why what I like in IC Pyramid, it's sharing of good practices. In Italy, there's one hospital, for example, taking care of children, kidney diseases. They have developed, they have identified a specific gene. They have translated it in a technology that is implementable in a hospital setting for diagnostics. They are centralizing it in the region. Different clinics are sampling. They send it to a clinic, a specialized center. So I think here is where the implementation begins to be possible, in also trying to, of course, create knowledge, very important on different levels, but also the structuring. And there's a moment we have some champions starting, then the public sector needs to take over to make this creation of networks, and then it begins to be implementable. So just one example.
Thank you very much, Monika. Now I would like Helmut to please wrap up this. There had been so many discussion points. So I would like to hand over to you now.
No, I would summarize it up in 11 points, very fast, and you might realize your words again. India has the infrastructure to implement personalized medicine, especially by Ayushman Bharat, an infrastructure that really is useful. And the second point is we need the governance to secure that personalized medicine as a right for all, as it was said, and as a public good. And this has to be on central, state, and community level. The EU-Africa cooperation in personalized medicine can be seen as a good example for cooperation. And what we saw is that there is already a blueprint for India with a regional focus what to do, because Africa has done this. So the Dakar Declaration can be a daily declaration. Then things can develop fast when you work in a consortium. And we can move from trial and error to a strategic approach in this. And the key stakeholders in this are not the researchers, but the funding bodies, because they direct what research is done, and they do not have a deadline. Very important. Every project has a deadline, and everything disappears. Funding bodies stay. We see that India has already built up the infrastructure that is working already and needed for personalized medicine in clinical trials and in databases. And especially the CCC solution, collaborate, seems to be a very important issue. India's role in the consortium could be to integrate traditional holistic medicine with the classical Western medicine, to blend East and West. Not a blended whiskey, but a blended, yeah. And India can help to clarify in which conditions omics can be used. I think that's very important. And the other important issue is that India can bring in the really needed diversity of genetic data. Otherwise, PM cannot progress. So that were the 11 points. And I think that's something for 1.5 hours where you all contributed to a clear vision how India can go ahead. Thank you.
Thank you very much. Thank you very much for this really, I think, lively discussion this time and input. It was more between the panelists. We promise in another session here, maybe in India, would be nice from IC Permit that we also take into the questions of the audience. We have to close here now, unfortunately, to time constraints. So thank you very much for joining us also from your side. And yeah, let's drive the, how to say, go with the flow is the Indian way. It's beautiful. We should take a picture. Can we take? Drive the flow. Beautiful. Can we have one picture all together?
morning, ladies and gentlemen. We would need to start. I'm so sorry. We had a wonderful session before this. So, can we have a huge round of applause for the session that was before this? Come on, guys, can we have a huge round of applause for the session that was before this? It was a beautiful session. We're going to start the next one. My mic is closed. I know I have a loud voice, but can I have the mic? Wonderful. Okay, great. So we will request the room to please settle down. Thank you so much. Thank you for coming. Give us 2 minutes to get our tech checks done, and we will be starting right away. We don't have any particular. Good morning, everyone. A very warm welcome to all of you to the panel discussion on climate vulnerability and health, amplifying marginalized voices for inclusive adaptation strategies. Thank you for choosing to attend this panel discussion. I see almost a full room on a Sunday morning. Thank you so much for choosing to attend our panel discussion. Please allow me to welcome the moderator for today's discussion. Thanks, Shri. I don't think people were able to hear me earlier. Please allow me to, I'll have to use my loud voice then. Please allow me to welcome the moderator for today's panel discussion, Ms. Spriha Atre. She manages partnerships at Swasti and also leads Indian Alliance for Public Health Preparedness. Spriha, over to you.
Thank you, Sabi. Thank you, everyone. Indeed, not easy to be here on a Sunday morning. I mean, ask me, it's difficult to kind of have a full audience, and great to see the room brimming with eager faces looking to learn. And we do have a very interesting session on climate vulnerability and health, amplifying marginalized voices for inclusive adaptation strategies. The panel this morning is supported by Swasti as well as Blockchain for Impact. And we have a stellar group of panelists who I'm ready to welcome on stage now. Today we are speaking to, we have this privilege of speaking to an inspiring group of panelists who are working on the front lines. These individuals represent organizations that are deeply engaged in protecting communities, responding to emergencies, basically engaged in advocating for long-term solutions for the communities they stand for. I would like to welcome our first panelist for today, who is Mr. Johnson Topno, a seasoned development sector leader with over 24 years of experience in advancing social justice and inclusive growth. He is currently the executive director at FIA Foundation and has led transformative initiatives across rural livelihoods, climate resilience, governance, and migration. His visionary leadership was instrumental most during the COVID-19 crisis, where he spearheaded the State Migrant Control Room in Jharkhand, which aided over 1.6 million migrants at the time. Thank you for being here, Johnson. It is my pleasure next to introduce to you Mr. Sandeep Verma, who is an advisor at Yodha, the Youth Organization for Democratic Development and Help in Action. Sandeep is a committed grassroots leader and policy advocate with extensive experience working with India's informal workforce, particularly street vendors. With over a decade of hands-on engagement, he's been a pivotal figure in the implementation of the Street Vendors Act, where he advanced inclusive urban governance and social protection mechanisms. Thank you, Sandeep, for being here. Thank you for joining us. Next, we have with us Dr. Aisha Chaudhry, who is the India Director of Women Lift Health. She is a healthcare innovator by training and has previously worked with the Government of India as an officer on special duty with the Office of the Principal Scientific Advisor to the GUI and as a director at the Atal Innovation Mission, Niti Aayog, where she was deeply involved in creation of a science-based entrepreneurial ecosystem in India. Many credits to her name. She's the co-founder of a medtech startup and has worked in the healthcare industry as well. worked with the World Bank, Stanford Bios Centers for Biodesign, and a professor at the IIT Jodhpur. Aisha, thank you so much for joining us. Please take your seat here. All right, we also have with us Mr. Pranav Savanur today, who is the Global Partnerships and Strategy Lead at Khushi Baby, where he spearheads resource mobilization, scale strategy, and the organization's climate and health portfolio. A public health and policy professional, Pranav brings extensive experience in non-profit leadership, health advocacy, and social movements. Pranav, glad to have you here on the panel. Please join us. Our fifth panelist today is Mr. Peter Borges, who is an assistant professor of social work at Goa University and a doctoral research scholar at TIS Mumbai. He has over 2 decades of experience in public health, and he's worked in adolescent well-being and social justice. Peter is the founder of Human Touch Foundation, a global advocate for adolescent health working on HIV prevention, sexual and reproductive health, and substance abuse in collaboration with UNAIDS, UNICEF, UNFPA across multiple countries. Peter, thank you so much for being here with us. Please take your seat. And finally, to complete the panel, we have Mr. Satya Prakash, who is the CEO of FXB India Suraksha, an Indian NGO that provides development assistance to marginalized children, women, and communities in rural and urban India. He's a seasoned expert in child rights, human trafficking prevention, and social protection with over a decade of experience as a practitioner, researcher, and trainer. Satya, thank you so much for joining us. We are ready to begin the session today. And as I said to all of you outside the room, we want to keep this session very grounded, very real. We've heard a lot of catchphrases and a lot of theories about what should ideally be done in the face of climate change and its impact on human health in India over the last 2 days. But today, I want to personally hear from you about what is it about the communities that you work with. What are some of the stories that need to be out here? Because let's remember, this is about amplifying marginalized voices, voices of the community, people who are not here, but you represent them. And what would they want to, people here at the World Health Summit to hear about their lives? So let's focus on that. And I'm going to ask the first question to all of you about, was there a specific moment or an event when you realized that climate change is affecting the people's health in your respective communities? So Johnson, would you like to share your thoughts first?
Hello. Good morning, everyone, and Johar. Thank you, Spreha, for setting the context, which is very, very important today, in today's context. I'm Johnson. I come from Jharkhand, and I represent an organization called Partnering Hope into Action, that's FIA Foundation. We work in 10 states, and we associate ourselves to those communities, marginalized communities like Adivasis, Dalit, minorities, women, person with disabilities, and what's happening to them in their world, what's the crisis they are facing. So that's where we are. And to me, because I come from a Munda tribe, which is predominantly second largest tribal communities in Jharkhand. And when I look at climate change, last 2 days I have been hearing a lot about climate change and its action, what should we do doing it. But from the ground, that what I see, like if I look at, while we are working in 10 states, one of the largest that we did it on the migrant labor in Jharkhand and their families and what's happening to the youth and the productive age. And that was very, very clear during the COVID crisis time when we find that large number of migrants from Adivasi community go to every city. You find them here in Delhi, Mumbai, everywhere. Men, young women, boys, girls, all of them you find them doing a lot of works which we will hear it. And I think climate change is very, very real. If you look at Jharkhand, out of 24 districts, 13 districts which comes under drought-prone areas, and it's increasing every day. Even if we are supposed to be, when I was a child, I used to remember that by 15 June used to start, monsoon used to start. And the preparation for agriculture used to begin 15 days before. And now, almost a month, there is a delay onset of monsoon, which triggers a huge, in the agriculture production cycles. And I believe that also triggers a migration. Natural seasonal migration that begins in Jharkhand is from, January after Christmas that begins, and people come back by towards the end of May or early June, they come back to do the agriculture. But now things are changing. Even if there is a delay by 15 days, it affects the agriculture productions. And you are not very sure about the food security, and you need cash. There are a lot of social protection programs that's happening around, but your lands remains barren for rest of the months, because you are not able to see when the cultivation, the plantation, paddy plantation begins. And therefore they need cash and they need to go to the cities because they don't have local employment. And that's how. So I would say that there is a real climate change impacting life and a huge pressure on women, I don't have any study to really substantiate, but what I see is that there is an issue with respect to the menstruation cycles. There is a pressure on women, young women who are dropouts. They have to go for a cheap labor for working in domestic workspace. And it is actually impacting women at large, because the young boys and productive age are out there and entire household works. Plus, taking care of the family is something burdensome for the women. Getting water from distant locations. Water is very, very scarce. While Jharkhand, if you look at from the climate perspective, we get around 13 to 1400 mm rainfall every year. But because of the hard rock strata and high, the topography is very, very undulating, and therefore runoff is very high. We are not able to hold, and degradation of forest is also there. So that's where, so I would say that this has directly impacting women, directly impacting Adivasi communities, because I see almost 80% of the people from Adivasi communities are migrating, leaving families behind and older people behind. And unless and until there is an action plan around climate change and how do we work around it, there are many works that we have already done it, which I perhaps come later. And what are the measures that community is doing it, and the government together we are working on something to really safeguard the communities from the vulnerable communities, to really talk about climate action, because we cannot talk climate action here in Delhi, but down there with the Gram Sabhas we need to really work around. What is that? They are actually protecting us. We are getting best of best oxygens by virtue of their contribution and sacrifices. But how do we really go back and tell them that the work that you are doing, you are making our life better? So there is no relationship as per se. You protect your forest, you ask them, don't cut forest because of the firewood and so on. But then we are not giving them enough support system. So really, why should they protect? What is the incentive that they are getting? It's something we need to discuss with the government, the donors, and the community themselves. Yeah.
Thank you, Johnson, for introducing us to this topic. Sandeep, आपसे same question पूछते हैं, और we'll keep this conversation both Hindi and English में, because as you all work with communities, आप भी दिखाना चाहेंगे अपने ये talk अपनी वापस teams को and communities को, तो mix में रखते हैं. संदीप, आप बताइए कि कैसे climate change की वजह से the communities you work with, और आप कितने सारे associations of street vendors के साथ काम किए हैं पिछले 10 साल में, तो उसमें
जिंदाबाद साथियों, मेरा नाम संदीप वर्मा है. बाय प्रोफेशन मैं सॉफ्टवेयर इंजीनियर था, और पिछले लगभग 9 साल पहले ऐसी एक मीटिंग के बाद आई जस्ट स्विच टू वर्क विद द स्ट्रीट वेंडर्स कम्युनिटी. तो बेसिकली जब से हम काम कर रहे थे, तो स्ट्रीट वेंडर्स का, मैं स्ट्रीट वेंडर के बीच में काम करने के लिए भी इसलिए आया कि जब इन माई चाइल्डहुड मैंने भी एक बार स्ट्रीट वेंडिंग का काम किया था, एंड दैट टाइम पुलिस आई और पुलिस ने मेरे से पैसे कुछ ले लिए. तो वो टाइम से मेरे दिमाग में एक बात था कि मेहनत हम कर रहे थे, काम हम कर रहे थे, तो पुलिस पैसे क्यों ले गई. तो ये सवाल मेरे दिमाग में था. आई वॉज स्टूडेंट ऑफ 10th और समथिंग 9th 10th स्टूडेंट, आई वॉज देयर. तो उसके बाद फिर वो दिमाग में कहीं रह गया और उसके बाद स्विच टू 2015 इन अ मीटिंग लाइक दिस आई गॉट टू नो अबाउट द स्ट्रीट वेंडर एक्ट 2014। 2014 का में एक कानून बना है स्ट्रीट वेंडर्स के लिए और उस समय जिस तरह के या स्ट्रीट वेंडर्स जो हैं आप सबने देखा होगा कि स्ट्रीट वेंडर के साथ जो बिहेवियर है अथॉरिटीज़ का वो कभी भी डिग्निटी का नहीं होता है। दे ऑलवेज बिन मतलब उन्हें लाइक सड़क के कचरे से ज़्यादा कुछ नहीं समझा जाता। कभी भी कहीं से भी उठा के फेंक देंगे, कभी भी कहीं से भी उनका माल उठा के ले जाएंगे, उनके साथ जितना मिसबिहेव कर सकते हैं, मारपीट कर सकते हैं, गाली गलौज कर सकते हैं, वो सब करते हैं। इन सभी चीज़ों पे इन इश्यूज़ पे हम काम कर रहे थे और पिछले 9-10 साल में मैंने काफ़ी प्लेसेस में काम किया। स्टार्ट मेरी जो अगर एक्टिविज़म जैसी चीज़ों की बात करूं, मैं नहीं कह रहा कि मैं एक्टिविस्ट हूं, लेकिन जो भी अगर उस तरह की बात करें तो ये मेरा महाराष्ट्र से शुरू हुआ था। मुंबई में मैं था और मेरे सामने पुलिस वाले माल उठा के लेके जा रहे थे एंड जस्ट स्टॉप देम। तो वेंडर्स को उनके एक्ट के बारे में नहीं पता, कुछ भी नहीं पता। वेंडर्स को सिर्फ इतना मालूम है या उन्हें सिर्फ इतना चाहिए कि लेट मी वर्क, मुझे सिर्फ काम करने दो, मैं पूरी मेहनत करने तैयार हूँ। मैं सुबह 4 बजे उठता हूँ, मार्केट जाता हूँ, अपने सामान परचेज करता हूँ रोज़, क्योंकि उसके पास ऐसी कोई व्यवस्था नहीं है कि वो बल्क में कोई परचेज कर सकता है, कोई स्टॉक मेंटेन कर सकता है, कोई स्टोरेज मेंटेन कर सकता है। सो दे हैव टू वर्क ऑन अ डेली बेसिस कि आपको सुबह उठ के जाना है मार्केट, अपने परचेज करने हैं, उसकी तैयारी करनी है, देन यू गो टू द मार्केट। सो इन दैट सिचुएशन उसे सिर्फ इतना पता है कि लेट मी वर्क और मुझे सिर्फ काम करने दीजिए, मुझे डिस्टर्ब मत कीजिए। तो ऐसे सिचुएशन में उन्हें उनके बारे में क्या हो रहा है, उनके साथ क्या इश्यूज़ हैं, क्या चैलेंजेस है, उसकी तरफ देखने का उन्हें मौका ही नहीं मिलता। वो इसी अपनी सस्टेनेबिलिटी को मेंटेन करने में इतने ज़्यादा परेशान हैं कि हर दिन उन्हें बिल्कुल पता नहीं होता कि आज मुझे काम करने का मौका मिलेगा या नहीं मिलेगा, आज मैं अपने घर में शाम को 200-500 रुपये लेके जा पाऊँगा कि नहीं, या फिर आज मेरा माल तो कहीं उठ के नहीं चला जाएगा। तो इन चीज़ों में वो परेशान थे। लाइक सिंस यू आपने पूछा मेरे से कि क्लाइमेट की चीज़ों पे हम कब से बात कर रहे हैं, तो इन चीज़ों की लड़ाई हम लगातार कर रहे थे और रिसेंटली पिछले 2-3 सालों में मैं दिल्ली में ज़्यादा एक्टिवली काम कर रहा हूँ और कई जगह पे ऐसा आया कि हमारे पास ये न्यूज़ आने लगे कि इस मार्केट में आज वहाँ उसकी तबीयत ख़राब हो गई है या ऐसा सारा कुछ हो गया। एक मैं लाल किला के पास हमारा एक यूनियन है, वहाँ पे एक वेंडर जस्ट काम कर रहा था और काम करते करते वो बेहोश हो गया, वो गिर गया, उसे हॉस्पिटल लेके जाना पड़ा। तो ये खबर हमारे पास आई, हम भाग करके गए, तो हमने पूछा कि भाई तुम्हें कोई दिक्कत थी तो तुम क्यों आए काम पे? बोला नहीं मुझे ऐसी कोई दिक्कत नहीं थी, मैं सुबह उठा, माल लेकर के आया और अपना काम कर रहा था और बात करते करते मुझे अचानक से ऐसा कुछ फील हो गया और मैं बेहोश हो गया। तो वो टाइम में फिर हमें समझ आया कि नहीं कुछ तो चल रहा है और फिर हम उस डायरेक्शन में थोड़ा सोचने लगे कि इसके अलावा जो एग्जिस्टेंस की लड़ाई है स्ट्रीट वेंडर्स की, उनके कानून के इम्प्लीमेंटेशन की जो लड़ाई है, जो सस्टेनेबिलिटी की लड़ाई है, इसके अलावा और कैसे चैलेंजेस हैं। तो उन चैलेंजेस पे हमने क्लाइमेट और उनके हेल्थ इम्पैक्ट के ऊपर बात करना शुरू किया, उनसे उस बारे में हमने चीज़ें समझनी और जाननी शुरू की और वो पूरा चैप्टर फिर हमने धीरे धीरे एक्सप्लोर करने की कोशिश की और फिर हम इस पे लगातार काम कर रहे हैं। और पिछले 2-3 सालों में जो चीज़ें हमारे सामने, मैं आपके सामने वो चीज़ें रखना चाहूँगा कि एक स्ट्रीट वेंडर्स का जो क्लाइमेट जिस तरीके से बदल रहा है, जो कार्बन एमिशन की हम बात कर रहे हैं, स्ट्रीट वेंडर और ये जो फ्रंटलाइन वर्कर्स हैं लाइक रिक्शा पुलर्स हैं, कंस्ट्रक्शन वर्कर्स हैं, इनका कंट्रीब्यूशन कार्बन एमिशन में नेग्लिजिबल है, नियर टू जीरो है। हम इसे नियर जीरो कार्बन एमिशन फोर्स कहते हैं। You can compare any other urban occupation compared to street vendors. वो सबसे कम कार्बन एमिशन करते हैं, उनके पास कोई बिजली का कोई व्यवस्था नहीं है, वो कोई एसी नहीं चलाते, कुछ नहीं करते, उनके कोई शॉप में बिजली और बत्तियों और इन सब चीज़ों की कोई ज़रूरत नहीं है। वो स्ट्रीट पे काम करते हैं, सुबह आते हैं, शाम को चले जाते हैं। तो वो ये बिल्कुल वो फोर्स है, वो वर्क फोर्स है जो क्लाइमेट के गड़बड़ी में जिनका योगदान बिल्कुल ना के बराबर है। लेकिन वहीं पर ये वो फोर्स है जिसको सबसे ज़्यादा इम्पैक्ट फेस करना पड़ता है। दे आर फोर्स्ड टू वर्क इन अ पैथेटिक वर्किंग कंडीशन। वो सड़कों पर हैं, वो कचरों के बीच में हैं, वो गाड़ियों के प्रदूषण के बीच में हैं और उसके बावजूद उन्हें काम करना है और उन्हें फिर भी ये समझ नहीं आ रहा कि उनके हेल्थ में जो इम्पैक्ट आ रहा है, उनकी फैमिली में जो प्रॉब्लम्स आ रहे हैं, या उनकी तबीयत जिस तरीके से बिगड़ रही है, वो किस वजह से बिगड़ रही है, कैसे काम हो रहा है उसके ऊपर। तो हमने रिसेंटली पिछले साल हमने इसके ऊपर एक प्रॉपर स्टडी कंडक्ट किया और एक रिपोर्ट है अब हमारे पास इन आंकड़ों के ऊपर बात करने के लिए। एंड यू विल बी सरप्राइज्ड कि जब हमने इस पर बात किया तो ड्यूरिंग द हीट वेव या ये जो पूरा, और दिल्ली शायद वैसे भी हमें पता है दुनिया के सबसे प्रदूषित शहरों में से एक है, तो दिल्ली में हीट वेव खाली प्रॉब्लम नहीं है, दिल्ली में रेन भी वैसे ही प्रॉब्लम है, फ्लड का प्रॉब्लम हो जाता है, और दिल्ली में कोल्ड वेव भी वैसे ही है। लेकिन ये जो गर्मियों की बात है वो दिल्ली में सबसे ज़्यादा है, शायद हम यहाँ 8 महीने से ज़्यादा गर्मियाँ ही फेस कर रहे होते हैं। तो ऐसे कंडीशन में जब हमने बातचीत करना शुरू किया तो लाइवलीहुड जो है उनकी जो कमाई है वो रिड्यूस कर जाती है बाई 50%, और उनके एक्सपेंसेस जो हैं वो बढ़ जाते हैं, लाइक दुगने हो जाते हैं, क्योंकि उन्हें अपने आप को हाइड्रेट करने के लिए पानी खरीद के पीना पड़ता है। उनके आप दिल्ली के किसी भी मार्केट को इमेजिन कर लो, अगर आप दिल्ली में हो या देश के कहीं पर भी किसी भी मार्केट को इमेजिन कर लो, वहाँ पर कोई सिविक फैसिलिटीज़ नहीं है, कोई टॉयलेट नहीं है, पीने का साफ पानी नहीं है। और इन सब में टॉयलेट वाली बात जो है वो बहुत इंपॉर्टेंट है, क्योंकि हमारी महिलाएं जो स्ट्रीट वेंडर्स के तौर पे काम कर रही हैं उनके साथ तो वो इतनी बड़ी समस्या है कि वो दिन भर पानी भी नहीं पीती हैं, बहुत कम पानी पीती हैं, ताकि उनको टॉयलेट नहीं जाना पड़े, क्योंकि उनके लिए वो व्यवस्था ही नहीं है। और अगर ऐसी कोई व्यवस्था है तो वो पूरी तरीके से चार्जेबल है, पानी खरीद करके पीना है, टॉयलेट आपको पे करके ही यूज़ करना है। और ऐसे में जो उनके हेल्थ चैलेंजेस हैं उसके बारे में वो सोच भी नहीं रहे, उनकी सोच सिर्फ यहाँ तक है कि आज मुझे कोई पुलिस वाला आकर के या आज मुझे कोई एमसीडी का म्यूनसिपल का बंदा आकर के मेरा माल ना छीन करके ले जाए और मेरे से मेरा पैसा नहीं छीन करके ले जाए। पब्लिक ट्रांसपोर्ट फैसिलिटी ज़ीरो है, आप किसी स्ट्रीट वेंडर कोई भी स्ट्रीट वेंडर अपना सामान लेकर के किसी भी पब्लिक ट्रांसपोर्ट में ट्रैवल नहीं कर सकता। तो दे आर फोर्स्ड टू वॉक 10 to 15 किलोमीटर्स, 5 किलोमीटर्स ऑन डे लाइट, मतलब पूरे उसी धूप में, उसी ये में उन्हें अपने घर से या अपने जहाँ भी उनका स्टोरेज या ऐसी व्यवस्था है वहाँ से चल के मार्केट आना है और वैसे ही पैदल चल करके जाना है। तो ये सारे चैलेंजेस उनके साथ लगातार हैं। और जब हमने इस पर चीज़ें की तो महिलाओं के साथ जो प्रॉब्लम है इस पूरे में, हेल्थ इश्यूज पूरी रिपोर्ट है हमारे पास, उसमें कई सारी चीज़ें हैं। उनके बीपीज़ बढ़ रहे हैं, उनके मेंस्ट्रुअल्स की जो बात कर रहे थे आप महिलाओं के साथ, वो एक बहुत बड़ी समस्या है, उनके साथ बढ़ती चली जा रही है और उनका उस पर ध्यान भी नहीं है। वो सिर्फ ये सोच रहे हैं कि जब हम उनसे ये सब बात करें तो कह रहे कि ठीक है ये तो हमारी रोज़ की समस्या है, इस पे हम अगर आप बात भी कर रहे हैं ना तो हमारे लिए सिर्फ इतना बात कीजिए कि हमें आज कोई पुलिस आकर के परेशान ना करे, हमसे कोई पैसा नहीं उठा करके लेकर के जाए, हमें सिर्फ आराम से काम करने दे, हम उतने में ही खुश हैं, हम उतने ही में ये कर लेंगे। तो हम उस पर लगातार बात कर रहे हैं। और हमने लास्ट टाइम जब ये रिपोर्ट पब्लिश की उसके बाद हम काफ़ी अथॉरिटीज़ से मिले, हम पॉलिसी में, हाँ एक और बात मैं मेंशन करना चाहूँगा, मैं जस्ट बिल्कुल ये बोल के ख़त्म करता हूँ फिर अपनी बात अभी, कि पॉलिसी में जो स्ट्रीट वेंडर एक्ट बना उस एक्ट में प्रोविजंस थे कि हर स्टेट अपने लेवल पे स्कीम बनाएगी, रूल्स बनाएंगी। आपको जान के हैरत होगा इस पूरे देश में अलग अलग जितने भी राज्य हैं सभी की स्कीम स्टडी की है मैंने, उस पर रिपोर्ट्स भी बनाई है। एक स्कीम ऐसी नहीं है जहाँ पे क्लाइमेट को लेकर के, लॉस एंड डैमेज को लेकर के किसी भी तरह की कोई बात की गई हो। पिछले दिनों में जो हमारे कच्चा माल का काम करते हैं, जो फूल बेचते हैं, खाना बेचते हैं, उनका सामान लगातार ख़राब हो रहा है। जब गर्मियाँ बढ़ जाती है, क्लाइमेट का चेंज है, उनकी कॉस्टिंग बढ़ गई है क्योंकि उनको जो पहले माल मिलता था वो सस्ते में मिलता था। क्लाइमेट चेंज है, जैसे सर ने बताया कि एग्रीकल्चर इम्पैक्ट हो रहा है उसकी वजह से, तो उनको जो मटेरियल्स मिल रहे हैं वो बहुत महंगे मिल रहे हैं और उन्हें अपना प्रॉफिट मार्जिन कम करना पड़ रहा है ताकि कस्टमर उनसे ख़रीदें और उनके साथ काम हो सके। तो उनकी लाइवलीहुड पे भी उतना ही इम्पैक्ट पड़ रहा है और उसके लिए कोई सोल्यूशन नहीं है। और हमारी पॉलिसीज़ में इसका कुछ नहीं है। एडवाइजरी जारी हो जाती है, गाइडलाइन जारी हो जाता है कि आप 12 से 4 काम मत कीजिए, लेकिन ये कॉम्पनसेट कैसे होगा इसके ऊपर कोई बात नहीं की गई है। तो कोई रिलीफ का कोई प्रोविज़न नहीं है, कोई लॉस एंड डैमेज की कोई बात नहीं है। और हमने जब ये रिपोर्ट की तो हमने उम्मीद की कि शायद सरकार इस पे काम करेगी। हमने पॉलिसी मेकर, हमने करीब 1 दर्जन एमपीज के साथ मीटिंग की, बातचीत की और हमने उनसे कुछ डिमांड्स की हैं। हमें प्रॉमिसेस किए गए लेकिन उसके ऊपर कोई काम नहीं हुआ। इस बार अभी हमने अपने लेवल में कुछ इनिशिएटिव लिया है। अभी जब सेशन कंटिन्यू होगा, अगर उस पर हम बात कर पाएंगे तो हम थोड़ा उस बारे में भी मैं बोलूँगा।
थैंक यू संदीप जी। आयशा, आप नेक्स्ट जाएंगी।
थैंक यू वेरी मच। आई थिंक मैं यही कह सकती हूँ कि जो हम यहाँ पे आज सुन रहे हैं वो सही है, लेकिन ये भी है कि सरकार अपनी तरफ से अपनी सोच के हिसाब से काम करती है और जो फील्ड पे काम होता है वो अपनी सोच से अपने हिसाब से होता है। कहीं ना कहीं ये गड़बड़ हो जाती है हमसे एज अ कंट्री, एज अ नेशन, कि हम वो दोनों को इकट्ठे एक लेंस से नहीं देख पाते हैं। सरकार अपने लेंस से देखती है और सिटीज़न अपने लेंस से देखता है। एंड अगर इसको हमको और बड़े से सोचना है तो मेरे हिसाब से दिक्कत ये होती है कि जो रियली में सिटीज़न अफेक्ट हो रहा है उसकी आवाज़ वहाँ तक पहुँचती नहीं है जहाँ पे पॉलिसी बननी है। एंड संदीप जी ने एकदम सही बोला कि सेंटर वाले पॉलिसीज़ बना देते हैं, देन ऑफ कोर्स इट गोज़ टू द स्टेट लेवल एंड स्टेट्स हैव फुल फ्रीडम टू सी दैट हाउ एज अ स्टेट आई कैन मेक दिस पॉलिसी मोर इफेक्टिव एंड मोर यूजेबल फॉर माई कम्युनिटी। नाउ अगेन व्हाट हैपन्स इज कि जो विमेन लीडरशिप है वो ना के बराबर है व्हेन इट कम्स टू सच डिसीजन मेकिंग। एंड जैसा हम अभी सुन रहे हैं कि विमेन आर द वंस हु आर मोस्ट अफेक्टेड, डिसप्रोपोर्शनली अफेक्टेड बाय द क्लाइमेट चेंज इम्पैक्ट। सो आई वुड से हम जो काम कर रहे हैं आज की डेट में वो ये है कि हम एक क्रिटिकल मास ऑफ विमेन लीडर्स बनाना चाह रहे हैं जो कि मीडिएटर बन पाएँ बिटवीन द गवर्नमेंट, नॉट जस्ट गवर्नमेंट बट ऑल द हाई एंड डिसीजन मेकिंग पावर and the people who are on the ground, because ये दोनों लोग आपस में बात नहीं कर पाते हैं. So our mission is really to be able to say that how do we create this critical mass of women leaders who will ensure कि ये community की जो voice है वो decision making table तक पहुंच पाए, and decision making पे जब design हो रहा है solutions का, they are able to really not just look at the problem from a scientific lens but a social lens. बिकॉज बहुत बार सॉल्यूशंस तो बहुत ब्रिलियंट बन जाते हैं, बहुत अच्छे अच्छे उनको अवार्ड्स मिल जाते हैं, पैसे मिल जाते हैं, लेकिन वो सॉल्यूशंस फील्ड में इम्पैक्ट नहीं क्रिएट करते हैं क्योंकि वो सोशल सॉल्यूशंस नहीं होते हैं, वो साइंटिफिक सॉल्यूशंस होते हैं. सो आई थिंक एंड वी हैव ऑल्सो रियलाइज दिस कि हेल्थ, क्लाइमेट, एग्रीकल्चर, फूड, इन सब एरियाज में यही हो रहा है कि decision making is not connected to the reality on the ground. So we come with a mission ki how do we create a critical mass of these leaders, especially women leaders, because we do believe कि women leaders bring to the table lived experience, और lived experience के बिना आप कोई भी social कंप्लीट कॉम्प्रिहेंसिव सोल्यूशन नहीं बना सकते हैं. आप सोल्यूशंस बनाएंगे जिनको अवार्ड्स मिलेंगे, जिनको ग्रांट्स मिलेंगी, लेकिन इम्पैक्ट नहीं होगा और प्रॉब्लम सॉल्व नहीं होगा. सो आई थिंक दैट इज़ हाउ वी आर लुकिंग एट दिस प्रॉब्लम. एंड about 30% of our women leaders really work on the ground in the community space, where they work at these intersections of health, agriculture, food, nutrition, climate, all of that. And उनसे भी हम यही सुनते हैं हमेशा that इतना overburdening हो जाता है in frontline workers का, because everybody wants to come do technical capacity building for them, but nobody wants to look at them as leaders. So I think the second big thing that we are really focusing on is to say that stop looking at these frontline workers as resources, but please start looking at them as community leaders. वो आपके एक्चुअली में जो मासेस का प्रॉब्लम है सॉल्व करने हैं, तो इसलिए उनको लीडर की तरह व्यू कीजिए, उनको चेंज एजेंट की तरह व्यू कीजिए, सिर्फ एक रिसोर्स की तरह व्यू नहीं करना चाहिए. सो आई थिंक दोज आर सम ऑफ माई इनिशियल थॉट्स, एंड थैंक यू सो मच फॉर रियली इनेबलिंग सच अ प्लेटफॉर्म जिसमें हम एक्चुअल में वो बात कह सकते हैं जो हम मन में सोचते हैं बट कभी बोलते नहीं हैं. थैंक यू सो मच.
थैंक यू आयशा. I'll repeat the question. We are talking about what is that one incident or event when you realize that climate change is actually impacting the communities you are working with.
Okay, thank you for that. Thank you for having Koshi Baby on the panel as well. Just for context, Koshi Baby has been working in India for the past 10 years. We started off in Rajasthan, which is India's largest state by geography. And the topography is very beautiful, but it gets harsher and harsher once you move away from the Udaipur tourist-centric locations and where all the Bollywood celebrities get married. So one of the core values of our organization is going to the field. So what that has really brought in is more than 250,000 hours that were spent on the field, listening to community health workers as not just the doers, but as researchers and experts in their communities, as Dr. Chowdhury also mentioned. And through this, in many ways, to identifying the product fit to our technical innovations was the realization of cultural drivers and then climate drivers of determinants of health. So in rural India, or even in urban India, we all know that women during their third trimester of pregnancy go to their maternal house from their in-laws. And we were also seeing in rural Rajasthan that many of their husbands, especially in the district of Udaipur, were going over to Gujarat as labor workers and daily wagers because of drought and then lack of agricultural yield. So in many ways, because of climate-induced livelihood factors, communities were displaced from where they live, and then the health system were not able to track them successfully, which led to more cases of malnutrition, more cases of zero dose, more cases of TB if they're working in mines, factories, etc. So your socioeconomic determinants of health in many ways has also led to environmental determinants of health. So the communities we serve, out of the 50 million we have reached, we classify close to 6 million of them as vulnerable. I'll get to what vulnerable means later, but these are people who are at risk because of their occupation, because of their risk by gender, because of the risk by just where they live, and existing health outcomes, more or less. And if you go to the communities, you already know that these vulnerabilities exist. So when we talk about these communities and serving them, I think we put this in this framework of the rate of change of progress in the work we do. And global forums in Geneva, in DC, or in New Delhi, we have global action plans for climate change and health, national action plans, now you have state, and now you're eventually moving towards district action plans for climate change and health. And I think that beauty of localization and personalization will come at the district and the block level, where a lot of this participatory approach needs to be done by what we call the vulnerable communities and providing them the agency to actually prescribe what they need from the government in terms of resources, in terms of structures, to actually make that bridge happen to also what was mentioned earlier of the policy intent exists, but we need to move towards that intent of policy to practice.
Thank you. So I'm Peter. I'm going to give some of my thoughts from climate change, protection and health perspective. So what we are saying, especially in the context of Goa, climate change is affecting a large number of people. But more important point for me to notice and share is a lot of climate change impact which is there in other state. There is a huge migration which is happening because of that. And especially as I worked in protection issues, I see huge migration from Latur and Osmanabad coming to Goa, because I think those are drought hit areas and there is crop failure and a lot of things which are there, and they ultimately land up in Goa on streets, trying to make their living in a seasonal pattern. But what I see is that the system is not ready to accept them. As a chairperson of the Children's Commission, my expertise has been, trying to change that narrative. I realized that, even in the centrally sponsored scheme, where 60-40 pattern is the, there is this huge, not willing to accept, especially what we see in Maharashtra, the same thing in Goan, like migrated people, like, we don't try, the native Goans are not ready to accept the fact, and we are not able to fine tune our policies to their welfare and protection. So that is one aspect I want to highlight, because finally I had little success because I was heading a statutory body. Otherwise it's very difficult to change, especially even the state don't want to include in this migrated population in their annual action plans, especially when it is even funded by central government. So that is a worrying, I don't know how it is in other states, but this is something which is very important. The other thing is a mental health perspective. We need to redefine, we use these words often, vulnerable, marginalized, but in our context, in every state context, we need to understand who are these, because it's not only by income and location. There are several factors, the systemic issues which should be taken into account when we define who are the vulnerable and the marginalized in our setting. So I think that's something which we also need to take into account, and I had some success in putting these words and defining these words in the public policies or schemes or guidelines, especially the sponsorship scheme under Mission Vatsalya. There was a huge resistance to include migrant children as beneficiaries of the scheme. So that's a little of my success. Another thing, most of the expertise has been in HIV and sexual and reproductive health. Now when I see, when it compare it to climate change, access to this kind of services is something which is getting affected. These are services which requires confidentiality, which there is a taboo, this thing with the services. When this become disrupted, like the whole aspect of mental health also comes, because it's not only a disruption of services, but it's trauma, despair, anxiety, everything. So what we have done, as a person who has worked with young people and adolescent, there is something, even when you talked about children right, there is something called right to participation. Now even today on our panel there should have been, voices, children's voices, like, participation is very important, whether it's young people, whether it's children, because we need to get their voices, they need to be part of the policy making. So what we have done, this is a very strong point, that even in the context of HIV, we whenever we design program, we involve them. Now this aspect, we especially in the mental health care, we have trained mentors to administer psychological first aid. See, not every mental health expert can reach at a very grassroots level, and so this type of training, little training on administrating psychological first aid or addressing the first needs whenever it comes to mental health, this is something which we have done and we found a success. Yeah, thank you.
I think by now we have kind of connected the dots, and I don't think how differently I'll be able to present the work which FXP does. However, looking at the intersectionality of the issues, I would say that there is some direct linkages. We see that how climate change is affecting your health, but maybe taking it a bit forward, that it's just not health. What are the indirect, the impact a community, a family, and an individual carries? So maybe I'll center around what we are experiencing within FXP. To tell you, FXP is an implementing agency and currently works in 13 states. We directly implement program, but we also value partnership, where we enter into collaboration with the technical agencies, etc. We work in different domain of livelihood, health, education, and protection safety. Now, one of the piece for FXP is to look at into integration and into the intersectionality. And I remember almost a month back in the same venue, there was an event hosted by Government of India in partnership with the Harvard University and called India at 2047, Building Climate Resilient Future. Now, one of the things which strikes me and connects the dot from this event to this event almost like a month, how things are shaping up, So one of the thing, like what Sandeep said about the hawkers, the unorganized sector. Now we are working in the urban slum areas. Now we are not just looking at the hawkers per se as an individual, as the head of the family who's bearing the burden, but look at the challenges with their children the family carries. So what we realize that there is a steady dropout from their schools. So we used to run a hotline, child helpline. I'm sure it's a very known number. We used to run for Noida for almost like 12 years. Now, one of the things we realized that the early child marriages, is happening just not because that, okay, the family is not able to carry the burden of the family, but also for the effect that, things are not steady as it was, and I don't need to repeat because Sandeep has, well established the fact that how even the urban space, the people who are living in the urban slum, is getting affected because of it. Secondly, if we look at it, the whole care economy which the woman has to carry, and I still remember that the Government of India last year, and we were part of that initiative where the livelihood mission, they wanted to create some model, and we really liked what our Prime Minister is looking at, creating some kind of a multi-sectoral care facility where the burden which directly the woman carries at the moment, which remain unrecognized, how government can be a party to it, how they can facilitate that they can still go on their work and still their children and the elderly are taken care. I don't know where it lies at the moment. But the point that, these are some of the indicators which primarily when we work on ground, we see that, the community may not be able to define the way we are trying to attempt, as quote unquote the technical or the so-called technical expert. But one of my visits, let's say in Meghalaya, we work with the farmers community in Meghalaya. And for your information, the ginger is one of the best known product in the world. Now, while I was interacting with the community, she did not say that, it's happening because of the erupt heat. But she said that, the ginger production these days has come down. It is impacting their monthly income, and so as the expenditure on health, on education, and things like those. And that really strikes that, you may not hear the direct connect between these two subjects, and as somebody who is on the ground has to connect the dots. And it may not always come as a challenge, but it will come as an experience. And that's for us to decode that where you are fitting in. And that's where, as somebody who is working in public policy and working directly engaging with the government has to convey this, and that's where I look at it, and I'm sure we will have opportunity to talk about that, where do you fit in the policy part of it, and maybe you'll have to move your circle from the urban space even taking to the rural space. And the last example I'll bring in where I think we are making some difference is about, some of the district we started working, let's say 7-8 years back, has no impact of flood, and right now, and it's in Assam with the Brahmaputras, what we are realizing, they don't have an alternative means of livelihood which can help them to continue, and they always relies on the farm-based livelihood, where you as an external bring in that non-farm-based practice which can continue their livelihood practice, so that the earning goes back to the family, just not retain with you as an individual. And that's where I think this topic, when we are looking at climate change and the health, has a lot of long connect, which we as a practitioner need to recognize.
Thank you, Satya. I think that was a beautiful round of, learning, and also I could see everyone in the audience listening very intently to each of you. They genuinely want to understand what it is like to kind of work with communities today, and want to probably also take away something from here that they can start implementing, say, directly, say, tomorrow itself. And so that brings me to our next question, which is, how can we, as leaders in the social impact space, in the development space, in whichever capacity we work with, how can we be, like, say, better, more empathetic, but also more action-driven leaders in the face of this crisis? Because the climate crisis is large, but the basics of, like, say, human compassion, innovation, innovation inspired by local action, the philosophy still holds true in 2025 as well. So you all represent very strong communities and very huge communities that you work with. So what is personally like for you to kind of keep on with the emotional baggage of kind of taking this, and what advice would you like to give to the audience here that they can take away from? Johnson, would you like to go first?
Thank you. So I think as we started with that climate change is real, and then we don't have much time left, We have to act upon, and everyone has to join hands. And there is intersection, there are society, there are structural causes of poverty, vulnerabilities. We understand all these things. But maybe action is still we are discussing in the conference halls, but it requires, people are waiting for us on the ground. And I come with a few examples that we have done it and it's working out. And I feel that we need at scale that we can think about it. How do we bring those changes around climate action? So one is that, and I think we as community, as one of the largest democracy that we keep on talking about it, and wherein we have demonstrated the crisis that we all faced, 2020 COVID crisis, and we all of us came together with one voice. And a collective action demonstrated how we managed every spheres of life. We could see the Himalayas very clean. We could see the sky during those lockdown period. Earth was breathing, and we are witness of all those happenings. And that's the power of collectivization. That's how we should be working together instead of sitting in isolation and doing in isolations. See, some of the examples that we have done in Jharkhand, because Jharkhand is a state which keep on, we talk that one of the rich in mines and minerals, but one of the most vulnerable communities live there. Everything from Jharkhand goes as raw materials. Even human beings go as raw materials. And we provide very cheap labor. We don't ask, you haven't paid for a week, doesn't matter, we live. So that's how it has been, human trafficking issue, malnutrition, mudda, all these things are happening. So what we have started working, a few examples, because we work very largely in the Schedule 5 area, predominantly tribal communities, almost 16,000 villages out of 32,000 villages. And that's where entire playground, mining lobbies there, big companies are there, they want to take out things, huge displacement mudda and all, climate change happening. So working with the Gram Sabhas is something very, very important facet that we have started with. Gram Sabha means village council, And 75 years down the line, still we haven't been able to really translate Panchayati Raj institution to the ground down to the fourth tier of the Gram Sabha, which is constitutionally enshrined institutions. The way parliament runs, the way Vidhan Sabha runs, similar way Gram Sabha has to function, because it has 8 standing committees, the way we have departments. So Gram Sabha also has departments. You have a health committee, you have a village development committees, you have education committees, you have a monitoring committees. Likewise, we have 8 committees. They are actually departments. The way you see it MORD, you see it Health Department, the Government of India. It's exactly the same. But such a powerful institutions are not being touched upon the way they should. They should make those policies, rules and regulations, and then think about a Gram Sabha consists of, if you look at Panchayat, it consists of about 5,000 population of around I would say 3 to 4 habitations, which comprises of around 3 to 4,000 land mass, which consist of commons and private land and tributaries around. So that's the resources. Can't these Gram Sabha manage their natural resources? Can't they manage their migrant laborer? Can't they manage human trafficking menace? Can't they run their Gram Sabha economies that God has given them? In the matter of land and water, the natural capital that they have. They don't need to go to cities, they can make it. But we haven't created those conducive environment. We haven't built their capacities. Traditionally, these Gram Sabhas are very, very powerful. That we call it traditional governance systems, which prevails in PESA area, Panchayat extension to schedule area, schedule 5 area, which is very, very powerful institutions. And they can even do many things. I remember during vaccination days, deforested landscapes, the vaccination was very, very poor. And I would say that huge efforts were made by the government, and we could not go beyond 10 to 15%. Huge resistance by the communities, and those landscape, you have Maoist presence, you have the paramilitary forces, deep forest areas, and people are not going for vaccinations. We catch hold of traditional leaders like Manki, Munda, Padha Raja. These are traditionally known names. They have a large convening ability in the region, and they are respected. And we engaged with these traditional leaders and told them that vaccination is something very, very important. If something happens, entire villages will wipe out. If something happens, what will you do? They joined hands, and within 2 to 3 months, we had a 90% vaccination done, because they took up to the communities. So such a powerful traditional leaders are there. How do we connect them? So now we have started establishing those facts that we can make a change. And therefore, if we have to say that what agriculture we need to do, how we need to conserve water, how we need to protect forests, these traditional leaders have to come forward, which gives you a lot of opportunity in PESA Act, and even the way it has been constructed, society has been constructed. But they were kept aloof in the past. So we are connecting them, and we are seeing the result on the ground. They are talking about not individual lands, they are talking about 1,000 lands together. What shall we do together? So these are some of the things that we have done, and we see that no need to make these organization of institutions dependent on any NGO or a civil society, because it has been, even within the civil society fraternity, we have made them so dependent that for anything they look forward. We made it a point that if Manrega has to happen, you have to do it. You have to create community assets. Government is giving you some resources, but do it. If you want to do health, nobody was talking about health per se. Even if there is annual planning, we call it a GPDP, Gram Panchayat Development Plan. And health was never been an important aspect for them to discuss and deliberate, that we need to see that ASHA worker has to come to us, Anganwadi has to function, injections have to be taken up. So all these aspects, so that has become, people have started questioning. Social audit, we talk about Manrega and infrastructure. Nobody talks about public health. So we were trying to bring in, if we have to do something, Gram Sabha has to anyway take up the responsibility and ask these few questions to the service providers. You being a voter, you can ask questions. And that's where these things are becoming very, very active. Another that I would like to example, just for 2 minutes, and I conclude, forest is something very, very important for Jharkhand, The entire food systems depends, the indigenous wisdom, the kind of diversity that we have. We need to protect. Jharkhand was one of these states least performing on the Forest Rights Act. And entire Adivasi community thrive on forest. And the bureaucrats used to say that the records of land in Jharkhand is well documented, so you don't need to implement Forest Rights Act here. But if some mining groups come, you will immediately displace the community. At least if you have a FRA, Forest Rights Act, it will give you a weapon to at least ask questions and negotiate and have a bargaining. So we launched a campaign called Abua Bir Abua Dishum Abhiyan. So this is हमारा देश, हमारा जल जंगल जमीन और हमारा राज्य. And it was in fact conceptualized FIA Foundation, launched by the Honorable CM, that FRA is something very, very important. Make it to a political will that FRA has to be implemented, because FRA is one of the largest land reforms scheme in the country and in the world. And all Adivasi community thrive on it. And this entitlement has to be realized. And we were able to really take off a group of civil society organizations, almost 30 plus organizations. We joined hands in the past, working in isolation, bring them together, have an MOU with the state government, the tribal welfare, and have started this campaign. And we see that although it is, you have to keep on, because huge resistance from the forest department. They think that the tribal community will take away the forest and their feudalism will get questioned, and a lot of fight, a lot of huge resistance. But we have taken a flag because we believe that we have not been able to really do it, but we believe that we will be saturating Forest Rights Act in Jharkhand. That would give a lot of power to the community to manage their resources, which they have been doing before British came into existence there. And I believe that the food system will get to strengthen, nutrition will get to strengthen, the governance on the forest will strengthen, climate action will become rejuvenated. And a lot of work around the forest landscape is going to happen, and we are going to champion that. Thank you.
Thank you, Johnson. Sandeep ji, will you want to go next? I just want to say there are a few chairs here up ahead that are vacant if anyone wants to sit. Sorry, please go ahead.
Apologies in advance if I take a minute longer. So मैं start करता हूँ उस point से, like एक street vendor क्या होता है, थोड़ा उस पे आते हैं. एक स्ट्रीट वेंडर समाज के प्रति बहुत सारी रिस्पॉन्सिबिलिटी ऑलरेडी निभा रहा है. किसी भी शहर की, किसी भी अर्बन स्पेस, अर्बन सेटअप को अगर हम इमेजिन करें, तो वहाँ की जो जो थोड़ी हम कह सकते हैं जो गरीब जनता है, वो डिपेंड करती है स्ट्रीट वेंडर्स के ऊपर. स्ट्रीट वेंडर सिर्फ अपने आप को सर्वाइव नहीं कर रहा है, वो अपने साथ साथ कई सारे लाखों के ये पे रोजगार पैदा कर रहा है. वो किसानों के लिए सपोर्टिव है, वो ट्रांसपोर्टर वर्कर्स जो हैं वो उसके लिए सपोर्टिव है. जितने भी स्मॉल स्केल इंडस्ट्रीज, कॉटन इंडस्ट्रीज रन हो रहे हैं, उनके प्रोडक्ट्स स्ट्रीट्स पे बिकते हैं, वो मॉल्स में नहीं बिकते हैं, तो वो उनके लिए भी सपोर्टिव है. वो देश की इकोनॉमी में कंट्रीब्यूशन कर रहा है. और ये हम नहीं कह रहे हैं, ये भारत सरकार कह रही है, उनके रिकॉर्ड्स में ये सारी चीज़ें हैं. इतने सारे कंट्रीब्यूशन के बावजूद भी इन रिटर्न स्ट्रीट वेंडर्स गेट always humiliation, abuse और manhandling और extortion, most of it. So ये सारा कुछ हो रहा है. तो हम चूंकि हम अभी क्लाइमेट के कॉन्टेक्स्ट में बात कर रहे हैं, तो ये सारी चीज़ें तो है. स्ट्रीट वेंडर की उसका जो योगदान है समाज के प्रति, हमारे लोगों के प्रति, यू कैन नॉट इमेजिन कि एक स्टूडेंट, जब दिल्ली में स्टूडेंट का हब है, तो क्या आप इमेजिन कर सकते हैं कि कोई स्टूडेंट हर बार रेस्टोरेंट में जाके खाना खाएगा? तो ये स्ट्रीट वेंडर होता है जो सारी सस्टेनेबिलिटी को मैनेज करता है. इन सब के बावजूद स्ट्रीट वेंडर को जो मिलता है वो कुछ नहीं मिलता, सिर्फ गालियाँ मिलती है. अब हम जब क्लाइमेट के ऊपर बात करें, तभी भी हम साफ तौर पे देख सकते हैं कि वो कहीं ना कहीं क्लाइमेट के लिए कंट्रीब्यूट ही कर रहा है. एटलीस्ट वो कुछ भी क्लाइमेट को नुकसान पहुंचाने की तरफ काम नहीं कर रहा है. तो हमने अभी जब पिछले साल मैं थोड़े कुछ आंकड़े पढ़ना चाहता हूं जो पिछली बार बोलने में छूट गया था, कि 80% ऑफ स्ट्रीट वेंडर्स ऑब्जर्व अ डिक्लाइन इन कस्टमर्स numbers during heat waves. 68.92% street vendors have heard about the heat waves, but 9.56 street vendors have heard about Delhi's heat action plan. Only 9.56% street vendors heard about the heat action plan. 7 out of 8 women street vendors reported experiencing high blood pressure. 82.74% of street vendors have no guidance on how to handle heat waves. So in this all this concept, और भी आंकड़े मैं बहुत ज़्यादा, एक और आंकड़ा मैं ज़रूर आपके सामने रखना चाहूँगा. 50.86% of the respondents face the burden of increased financial expenditure or strain due to additional household expenses. और ये एक्सपेंस का हमने एक एवरेज किया था 4,896, अप्रॉक्स 5,000. तो एक स्ट्रीट वेंडर के लिए 5,000 रुपये महीने का एक्स्ट्रा बर्डन बड़ा है. सो एनीवे, दीज आर द चैलेंजेस, दीज आर द सिचुएशन। हमने इस बारे में हमने बात की, जैसा मैंने पिछली बार भी कहा कि हमने पॉलिसी मेकर से बात की, अथॉरिटीज़ से बात की, गवर्नमेंट से बात की। आपको जान के शौक लगेगा कि हमारी अथॉरिटीज़ का, एमसीडी का, उनके रूल बुक में ये मेंशन है और वो इतना एक सिंपल लाइन चेंज करने तैयार नहीं है कि अगर स्ट्रीट वेंडर रेन से बचने के लिए, धूप से बचने के लिए अपने सर पे एक छतरी लगाता है तो दैट इज काउंट एज अ इंक्रोचमेंट, और वो छतरी के बेसिस पे वो आपका पूरा माल उठा के ले जाएंगे और आपका माल वो जब्त करके रख लेंगे। आप कम से कम अगले 10 या 15 दिन के लिए काम करने के लायक भी नहीं रहेंगे, आपकी पूंजी जब्त कर ली जाएगी जस्ट कि आपने अपने सर पर एक छतरी लगाई है। तो दीज आर द सिचुएशन, और उसको वो बदलने के लिए तैयार नहीं है। इस बार अभी तक कुछ नहीं हुआ। हमने इस बार अपने लेवल पे इनिशिएटिव लिया। हम सरकार का और उनका इंतज़ार करने के पक्ष में नहीं थे कि वो कुछ पॉलिसी में बदलाव करेंगे, वो कोई एक्शन लेंगे। तो हमने इस बार एक टर्म सोचा है, आपके सामने रख रहा हूँ। मुझे बहुत अच्छा स्टेज दिया है आपने ये रखने के लिए। VSR, CSR हमने बहुत सुना है। नाउ वी आर कॉलिंग इट इज VSR, वेंडर सोशल रिस्पॉन्सिबिलिटी। हम वैसे भी समाज के लिए बहुत सारी रिस्पॉन्सिबिलिटी निभा रहे हैं। अगर आप 1 मिनट के लिए, मैं एक्सप्लेन करने में नहीं जाऊंगा, टाइम जाएगा, आप 1 मिनट के लिए आंख बंद करके सोचेंगे तो स्ट्रीट वेंडर के इर्द गिर्द अगर आप देखेंगे तो वो समाज के लिए ऐसी जिम्मेदारियां निभा रहा है। वो सड़कों को सुरक्षित भी करता है। एक महिला के तौर पे आप देखिए कि अगर रात में ऐसी बहुत सारी सड़कें, इवन दिल्ली में, दिल्ली जो देश की राजधानी है, ऐसी बहुत सारी सड़कें जहाँ पे लाइट नहीं है, वहाँ पे स्ट्रीट वेंडर होता है, वो अपना बैटरी वाला लाइट लगाता है, जिसकी वजह से वो रोड गुलजार होता है, जिंदा होता है सड़क। तो इन सब रिस्पॉन्सिबिलिटी के बावजूद उसका कोई रिकॉग्निशन नहीं है। हम इस बार क्लाइमेट की तरफ भी VSR करके हम ये टर्म लेकर के आ रहे हैं। हम इन सारी जो रिस्पॉन्सिबिलिटीज़ हम प्ले कर रहे हैं उसको भी डॉक्यूमेंट करेंगे। और इस बार हम ये कर रहे हैं कि हमने दिल्ली के 50 मेजर मार्केट्स को आइडेंटिफाई किया है। उन सभी मार्केट्स में हम हाइड्रेशन पॉइंट इंस्टॉल कर रहे हैं। हमने ऑलरेडी ये काम शुरू कर दिया है। हम कुछ मेजर मार्केट्स में, बिकॉज हमारी कैपेसिटी जो है वो बहुत कम है, हमें कोई फंडिंग नहीं है, हमारे पास कोई सपोर्ट नहीं है, हम जो कुछ भी कर पा रहे हैं सिर्फ पार्टिसिपेटरी प्रोसेस में कर पा रहे हैं। तो हमने अभी रिसेंटली एक मीटिंग की थी हमारे मार्केट लीडर्स के साथ में, और हम अपने लेवल पे ये कर रहे हैं कि हम हाइड्रेशन पॉइंट इस्टेब्लिश कर रहे हैं जो न सिर्फ स्ट्रीट वेंडर के काम आएगा, वहाँ आने वाले आम नागरिकों के भी काम आएगा, रिक्शा पुलर्स के काम आएगा, गिग वर्कर्स के काम आएगा, जो उन सड़कों से, उन स्पॉट्स से गुजर रहे हैं जहाँ पे ORS की व्यवस्था होगी, मेडिकेशन फैसिलिटीज़ होंगी। और हम हर हफ्ते या फोर्टनाइटली ये में जैसा भी पॉसिबल हो पाएगा, कितना कोलैबोरेशन हो पाता है उसके आधार पर हम हेल्थ कैंप भी ऑर्गेनाइज कर रहे हैं, जो सिर्फ स्ट्रीट वेंडर्स के लिए नहीं काम आएगा, ये और भी जो भी वहाँ पे बेनिफिशियरी हो सकते हैं, जो फ्रंटलाइन वर्कर्स हैं, उसका फ़ायदा उठा सकते हैं। और इस तरह के सेटअप हम कर रहे हैं। हम कूलिंग सेंटर डेवलप कर रहे हैं जहाँ पे हम इको फ्रेंडली मटीरियल के साथ एक सेटअप बना रहे हैं जहाँ पे 10-20 लोगों के बैठने की व्यवस्था हो सकती है, ताकि अगर आप एकदम एक्सट्रीम हीट एक्सपोजर में हैं आप, और आप बुरी तरह से एग्जॉस्टेड फील कर रहे हैं, तो आप वहाँ जाके बैठ सकते हैं, पानी पी सकते हैं, ORS ले सकते हैं, और फर्स्ट एड किट भी होगा। और स्ट्रीट वेंडर ही वो पहला रिस्पॉन्स पॉइंट हो सकता है। अगर सड़क पे कोई बंदा गिर जाता है हीट स्ट्रोक पे आकर के, या किसी तरह की परेशानी में पड़ जाता है, तो दीज स्ट्रीट वेंडर इज द फर्स्ट पॉइंट, वो सबसे पहले आपको मदद के लिए सामने आ सकता है। तो हम अपने वेंडर्स के साथ, अपने मार्केट्स में, अपनी कम्युनिटीज़ में इन चीज़ों को लेकर के अवेयरनेस डेवलप कर रहे हैं। और हम सिर्फ ये एक्टिविटी करेंगे ऐसी बात नहीं है। आने वाले दिनों में आपको दिखेगा दिल्ली के मेजर मार्केट्स में, एंड आई विल इनवाइट यू ऑल्सो, कि हम वहाँ पे पूरा अवेयरनेस कैंपेन रन करा रहे हैं। हमने अभी IMD के साथ मीटिंग की है, IMD के डायरेक्टर के साथ हमारी मीटिंग हुई है। IMD के साथ हम एक जॉइंट ट्रेनिंग भी कर रहे हैं। हमारे हम इन्हें क्लाइमेट वॉरियर कह रहे हैं, जो हमारे मार्केट लीडर्स हैं, दे आर द स्ट्रीट वेंडर्स ओनली। वो वहाँ पे खुद वेंडिंग करते हैं, लेकिन वो लीडरशिप प्ले कर रहे हैं। तो हम उनको लेकर के ये ट्रेनिंग कर रहे हैं ताकि वो जो अर्ली वार्निंग, जो IMD के अलर्ट्स आते हैं, उसको समझ सकें। और हम मार्केट्स में बहुत बड़े बड़े बैनर लगाएंगे जहां पर हम ये सारे जो फोरकास्टिंग है, जो अर्ली वार्निंग सिस्टम है, वो डिस्प्ले करेंगे। सिर्फ इतना ही नहीं करेंगे, हीट वेव से एक आम आदमी कैसे अपना बचाव कर सकता है उसकी जागरूकता करेंगे। साथ ही साथ हम ये डिमांड रेज करेंगे कि हीट वेव या ये जो क्लाइमेट के डिजास्टर्स हैं, इसको नेशनल डिजास्टर घोषित किया जाए। और ये जो हमारे फ्रंटलाइन वर्कर्स हैं, लॉस एंड डैमेज के नज़रिए से भी इनका देखा जाए कि इनकी लाइवलीहुड का कितना लॉस हो रहा है, कितना डैमेज हो रहा है और उसको कैसे कॉम्पनसेट किया जा सकता है। इन सभी इनिशिएटिव्स में हम अथॉरिटीज़ को कोलैबोरेट करने की कोशिश कर रहे हैं, लेकिन फ्रैंकली स्पीकिंग कि हमें रिस्पांस उनकी तरफ से बहुत कम मिल रहा है। कल एक मीटिंग मैंने कोशिश की है सीएम के साथ मिलने की। अभी रिसेंटली उन्होंने सीएसआर इनिशिएटिव की बात की, मैं उन्हें अपने साथ हमारे साथ वीएसआर इनिशिएटिव दिखाना चाहता हूं, लेकिन देखते हैं क्या हो सकता है। मगर हम ये वेट नहीं कर रहे हैं कि हमें कोई मदद करेगा, कोई सपोर्ट करेगा, हम बिल्कुल इसके इंतज़ार में नहीं हैं। हम आने वाले दिनों में इन सभी मेजर मार्केट्स में हेल्थ कैंप तो ऑर्गेनाइज कर ही रहे हैं। हम हमारे वेंडर लीडर्स ने बहुत, वो रॉ लोग हैं, बहुत ही एकदम बिल्कुल उनको कोई पॉलिसी कोई इससे मतलब नहीं है। उन्होंने अपने लेवल पे बोला कि भैया हम नींबू शरबत बांटेंगे वीकली, हम सत्तू बांटेंगे, हम आम का ये घोल ये करेंगे। तो ये अपने लेवल पे वो खुद से रिस्पॉन्सिबिलिटी ले रहे हैं। तो जब तक कि सरकारें और बाकी सब कुछ सोचेंगी, हम अपनी तरफ से ये इनिशिएटिव ले रहे हैं, इस पे काम कर रहे हैं। तो
Thank you, Sandeep ji. Thank you so much. Aisha, would you like to talk about how your personal experience has been working here, and also about like what lessons the audience can take going forward?
Sure, thank you. I can say that in terms of lessons and of course personal experience over past several years, what I'll do is I'll share a story of one of our women leaders who works in rural Maharashtra, and she primarily works with the tribal community. And वो पिछले 4-5 साल से ये समझने की कोशिश कर रही थी कि जब कोई भी डिज़ास्टर आता है उनके एरिया में, तो वाई इज़ इट दैट द ट्राइबल कम्युनिटी को सबसे ज़्यादा इम्पैक्ट होता है, एंड उसमें भी वाई इज़ इट दैट women and girls are the ones who are the most disproportionately affected when it comes to health issues and so many others. And she realized that poor menstrual hygiene was a big factor of why the women and the girls were being the most affected in those rural Maharashtra areas. And it was a long journey for her. She spent several years. She said that poor menstrual hygiene isliye hai because there's no awareness. People don't want to be able to use the menstrual pads because of the cost, pricing, and so many other factors. It's a taboo also, a lot of those things. So she started to think that how could she solve that problem as a community leader, and what she could do for these women, because she was extremely passionate about that. So उन्होंने कोशिश किया that she'll develop, and of course she also found out what are the other products, the menstrual hygiene products, and she said that कि menstrual cup है, it is low cost, it is economical, so why don't women want to use this? अब उसमें she figured that the menstrual cup को लगाने के लिए was the big challenge. That was the rate limiting factor, because you need a certain amount of training, and people are not able to drive that behavior change, whether you're using a cloth, how do you suddenly start using a cup, and you have to really insert the cup within your body. So there's a different kind of behavior change that is associated with it. So she said ki chalo, let me develop a menstrual cup applicator, which will really enable and empower women ki chalo, now we'll get more comfortable to be able to use the menstrual cup. She spent about 1 to 2 years in trying to figure out how to develop that prototype. And she's not an engineer. She was just a community leader who wanted to solve the problem. She brought a lot of people together, worked with institutions, engineering, medicine, doctors, all of that. But ultimately, she had a prototype, but which was not really still solving the problem. And then 2 years ago, she worked with us as part of our community leadership programs that we do at Women Lift Health. And during that 1 year journey, she said that she got that direction, intentionality to really go back and restart her project, which was lying dead on the ground. And then, of course, she got more resources, more access. उन्होंने और प्रोटोटाइप्स बनाए और टेस्ट किए प्रोटोटाइप्स को, एंड फाइनली अब उनका एक प्रोडक्ट तैयार हो गया है जो वो पेटेंट करने के लिए रेडी हैं. एंड शी इज़ ऑल्सो नाउ wanting to work with startups जो already menstrual hygiene में कर रहे हैं काम, so that she is not going to suddenly become an entrepreneur. वो तो एक community leader ही रहेंगी और उस community के लिए ही काम करेंगी, but वो ये चाहती हैं कि अब वो product license out हो जाए किसी startup को, so that more and more people can use it in different parts of the country. So I think this is an example again that I want to highlight. I know हम इतना ज़्यादा technicalities में घुस जाते हैं हमेशा कि हमें ये problem solve करनी है और कैसे भी करनी है, तो हम उसी के enhanced capacity building पे focus कर जाते हैं. But I'll come back to the same point. What we really need is community leadership. And I'm very glad संदीप ने भी बात किया कि market leaders वो बना पा रहे हैं जो EWS के बारे में, the early warning systems के बारे में communities को बता रहे हैं. इसी तरह के community leaders हमें सबसे ज़्यादा चाहिए. तो आई थिंक जो मैं एडवाइस करना चाहूँगी वो यही करना चाहूँगी कि समटाइम्स जस्ट पॉज, रिफ्लेक्ट, स्टेप बैक एंड आप ये देखो कि जो प्रॉब्लम आप सॉल्व करना चाह रहे हो, क्या आप उसमें एक लीडरशिप पर्सपेक्टिव ला रहे हो या आप इतना डीप घुस गए हो कि आप सिर्फ प्रॉब्लम के अंदर ही घुसे हुए हो और आप उसको एक 360 पर्सपेक्टिव से नहीं देख पा रहे हो. So in my mind, community leadership is really the key for you to be able to go back to your respective communities, empower them and solve their problems from a holistic social perspective. So that to me is the most important thing. And just to add a little to the EWS example, ये हमारा अपना story नहीं है, but नेपाल में एक study हुआ है where they said that, you know, of course, women are more disproportionately affected when it comes to disasters. So they said that, you know, how do we ensure that it does not happen? So what they realized is that early warning systems में men जिस तरह से communication करते हैं, information spread करते हैं, is very different from how women do it. Men do it mostly through formal channels, but women do it very differently through informal channels, through the social networks that they are connected to. And therefore, interestingly, women are able to reach a larger population and more rapidly. So that to me is the biggest insight of a community solution development. And therefore, now what they do there is they really integrate women into developing this early warning system solution, and they ensure that women are the ones who are really spreading the information so that the community gets to know it fastest, and they are able to reduce the impact on women during disasters. And this is again a beautiful example not just of community leadership but of gender integration or integration of women's leadership into the decision making. So I think it's the same one thing. If I had to summarize, what you need is good intentional community leadership to solve these problems. Thank you.
Thank you, Aisha. That was wonderful. Wonderful insights. Pranav, what are your thoughts? Over to you.
Yeah, thank you. I think a lot relevant has been shared already. I think when we talk about what the audience can take away, especially in this room, first we're having this conversation in Delhi and not in rural India, where a lot of the people at the last mile are often the first responders to many of the challenges that we're talking about. So taking a step back and just understanding first the difference between how climate change is affecting us and the people across rural India. All of us are equally susceptible to climate change, right? So if there's 45 degrees out there in Delhi, there is a higher degree of air pollution, 200 plus AQI, but we have better measures to take care of ourselves. We're sitting in AC rooms, we're traveling in AC Ubers, so our adaptive capacity is better. But when we go back to rural Rajasthan, let's take an example of an ASHA worker, Asha Basanti Devi, in the Kottada block of Udaipur. Asha Basanti Devi is often seen worn half-torn slippers, carrying 5 to 10 binders on her left hand, and then her 3-year-old child, Bhupinder, on her right hand. She needs to travel 1 to 2 kilometers from one house to another to do her health census and to deliver essential care. Her adaptive capacity is far lesser than us, and hence she is vulnerable, and not us. So how can digital tools identify who is vulnerable in the first place to make sure that grassroots organizations or community-led organizations can focus a proactive approach on reaching them first? So that has been the approach for us to actually say, there's been so much talk around this space, but what could a digital health nonprofit do in this space? So what we did was we engaged and activated ASHA workers as researchers in their communities. Through incentives and through the regular data that they already collect, we also collected socioeconomic indicators, which helped us pretty much model what climate and health vulnerability looks like on the ground. to different environmental exposures. And now with this vulnerability map, you have hyper-local insights as to where vulnerable pockets of populations live at a village level. So what do you do with this data is the next step. You can take this data, go to the government, and help inform evidence or help inform saying that these are the vulnerable communities that live to plan your action plans for climate change and health. But the same data could be used by community leaders like Sandeep in planning what is that solution that I can put in to my community to increase the adaptive capacity of them, which will also see eventually the increase in health outcomes that we'd want to see. When we're looking at climate and health, you can't fundamentally take this siloed approach into solving this problem. You need to have a platform collaborative approach where the funders, the thinkers, and the doers across sectors really need to come in together, because that adaptive capacity looks different for different people. For example, K3 Devi, one of the beneficiaries that Asha Basanti Devi serves, her child is both malnourished and is zero dose. Zero dose in the case, her child hasn't received a single dose of vaccine before she turned the age of 5. And for her, she communicates that she's trading off the time to go to the health center because the water closest to her house has dried up in the well. So she needs to travel an extra 1 to 2 kilometers to go fetch that water. And the only free time that she has away from her daily wage is the time that she would take this child to a health camp. So if you want to increase the adaptive capacity of K3 Devi, you need to work on a solution that's focused on livelihoods, which can also have an impact on health outcomes. So how do you bring all of these systems together is the type of conversations we need to be having in this room, where it's locally led, centrally governed, and then globally driven, where you have the resources being allocated for decision makers who are proximal leaders. So when we're now thinking about designing these district action plans and block action plans for climate change and health, even breaking that down into, for example, saying heat, and seeing who are the local players at that district working on heat adaptation. How could data-driven tools help identify hyper-local vulnerability based on their occupation, based on their gender, and other risk factors? And who are the players who can come in together to help solve that problem? Could that be prescribed in some level into the action plans and then funded through the state and national action plans? I think that is a very tangible next step that we can think about in a way that people sitting in Delhi or WHS or the community here can see how all of our players could be working together to solve this problem. If that doesn't happen, probably in record time, because climate change is already here, we're probably going to be back next year on the same panel and talking about these challenges again without really presenting evidence of what's working. I think there's enough evidence alluding to the fact that climate change is affecting human health, but I think we need more evidence around what can be done about it, what should we do about it, and how do we get there, I think should be the conversation happening in these rounds. Thank you.
Thank you, Pranav. That was helpful for the audience here. Moving on to Peter. Peter, in your response, if you can also include your perspective of working with adolescents and many HIV patients also, that would
yes. Before that, I would also like to give some generic comments. Especially, I work a lot in advocacy. Co-panelist Johnson also meant that we need to come together. And what I'm witnessing in the state of Goa, I don't know whether it's there in other state, that especially civil society organizations are not willing to come together, basically with the fear of being targeted, losing the FCA area and things like that. And certain issues which we were supposed to speak boldly, those are not being spoken about. And especially I've been seeing, like when it comes to climate change, the environmental degradation that's happening in Goa with all massive hill cutting. Everybody from the other state would like to have a house in Goa, plot in Goa, and that's actually affecting a lot of us. And we don't know how to respond to this because money becomes a huge thing, and it is literally affecting our small villages, as you know, who have visited Goa. So that's something which is worrying. Other thing I wanted to highlight is, especially in the government setup, that most of our program become very tokenistic and basically event management. small campaign like even Beti Bachao, Beti Padhao, we don't have that concrete plan how to address. At the end of the financial year, we just organize a massive program, put all the money one day, the whole fund photographs are sent. So that culture is come in social development space, which is very worrying that we are not addressing the real issues. Our work is not creating that required impact. Issues remain issues forever. And that's worrying, and I have been trying to work on how to get this addressed, because as a person who has worked for 21 years, even in the space of HIV, like, we are witnessing something like, we are not worried, like, I just lost an adolescent just before I came, 19-year-old, not of HIV, because of mental health. Now, that's something which is very worrying, because why we have acts in place, we have guidelines in place, we have everything in place, but we are not able to innovate that or ask. So I think that is something which we all need to do, because if we talk about children, we talk about adolescent, especially the funds which are meant. I know at one point of time the only scheme, centrally funded scheme, earlier it was known as Integrated Child Protection Scheme, now called Mission Vatsalya. Our unspent balance reached 7 crores. And no one in the system, no one in the civil society space asks the government why it's not being utilized, a scheme meant for protection of children. So I think we need to ask the government, forget about our FCRAs, forget about our, that fear that we already have. I am doing that and bearing the brunt also. But I think we need to rework our strategies.
Thank you. Thank you, Peter, for sharing that. Before you go, Satya, I want the audience to keep their questions in mind, because we are going to have the question answer round after Satya. Over to you.
No, thank you, Peter, to be honest and bring this fear and the insecurity, and that's also takes me to one of the strongest observation and the advice, because see, this topic of climate change is boundaryless. You cannot say that, I'm working in this geography and it is not impacting us, so why I need to refix and revisit my strategy. Now, that question is obsolete at the moment, and that's why one of the practice which we have adopted and we have been working in all our working philosophy is to connect source and destination. So let's say we heard about migration, and when we are talking about the impact and the connectivity of climate and the migration, is somebody from Jharkhand is opting for a distress migration and let's say coming to Delhi, and how Delhi is protecting that person from Jharkhand, and that's where increases the vulnerability of the person who is migrating. And that's where in our working philosophy we want to connect these dots, the kind of services you have available, somebody who is migrating from Jharkhand and going to Delhi, and that brings to this whole the element of rights-based approach within your thinking process, that it's just not that somebody is using and I am not affecting, I am not contributing to it, just like what Sandeep said. The data says that the hawkers, they are not contributing to it, but they are highly impacted by it. But whether government is recognizing them and their rights or not, and the answer is quite visible to us. So it takes me to my second observation and maybe a strong advice, that as a workforce in this sector, and this goes beyond India, that, how do you also take a step back and realize that whether this topic can fit within your working space or not. Let's say 8-9 years back in my organization, we were not using this word climate change, but I remember when I was in grads, I wrote a paper with my principal, about South Asian haze in Delhi, and it was in early 2000. you know, and now we know that, you know, around winter time or post Diwali, how Delhi, you know, catches the attention of whole of the world, you know, and all the embassies also come up with the advisory, please stay back from Delhi, you know. But now the point that it's just not a Delhi problem, you know, and that's where we say that, you know, it's boundaryless. But the point that, you know, we attempted to write a scientific paper 20 years back, and now it's quite visible. So you cannot say that, you know, we work on education, but can you bring in this whole piece of climate within your intervention around education? Just like we started going back to children, and the children in Manipur will be defining climate change very differently from a child in Noida. You know, so how do you contextualize within this whole education framework is very important. You know, and that's where, you know, I would say, you know, and I will call that all the organizations who's working in this space has to revisit their strategy and say that how do they fit within their own narratives. You know, you may be working on women rights issue, on health issues, HIV, education, you name it, and we know that it is impacting because of the climate impact as well. So there is no harm, you know, in saying that, you know, I need to learn about it, you know, rather than opening up your insecurity. Oh, how come, you know, I have 30 years of experience in this space and I'm still sitting in a room to learn something. You know, there's no harm in doing so and accepting this as a fact. Until we are not arriving at this point, I don't think we can keep on discussing, as Pranav said, you know, year on year. But we need to, you know, say that this is the urgency and we have to start acting. Thank you.
Thank you. Thank you so much for all of your wonderful insights. I think the audience was not just listening from their minds, but also their hearts, and you provided them with amazing takeaways. But wait for more. We'll have the audience ask you questions and grill you further. So if someone can pass a mic around and you can start, yes.
Hi, thank you so much. Like, this was really an insightful discussion. So my name is Dheeraj and I'm from World Resources Institute. So my question is very simple, like, because there is a ample of problem and you are working on some of the solution side, but is there any framework where we are capturing, like, if a person is either dying from the heat waves, or is there any a person or the women is going to die with the lack of electricity in the labor room? And if you have done so, like, how we can inform the policy maker or the district official or any of them who are the decision maker, so that they can collect the evidences and this reporting system comes very well mannered, so that, like, some of the action can taken from the government. Thank you.
So this reminds me of one incident in Madhya Pradesh where a senior police officer, you know, almost at the position of a DGP, she said that she got a case, a child died and a family died because of hunger. You know, and so there was an inspection, call for an inspection, where the district authority was advised to visit the house and find out whether the family died because of hunger. You know, and none of the district official has the courage to put on paper that the family died because of hunger. You know, because it goes back to the accountability which the government has to take on their head, you know, and it's connect to directly to your question. Because see, when you establish evidences, this call for an extra accountability of the government agency onto the community, you know, and unfortunately that's the distance we are still managing with that discipline, you know, that, you know, we don't want to cross that line, and you may not like to, or you may not be comfortable to say that this has happened because of the heat stroke, because then the district administration has to call for a different services, you know, to this authority. So still, I think we need to, I don't want to say that we need to create a pressure group like an activist group, but still, as a practitioner, how do you start documenting as an evidence and bring it to them, you know? So that's going to be an important piece here. But thank you for bringing this.
Yeah, just want to add on. We're actually, the Climate and Health Vulnerability Index that we're building in Rajasthan is part of the State Digital Health Mission. And one of the key criteria of this is to link all of these data points and indicators together. So there is a reporting mechanism that tracks deaths attributed to heat, and then also morbidity for heat and other issues. But you also have different reporting mechanisms to track information on supply chain, personnel, etc. So something that we're doing is we're bringing all of these data points together on an integrated dashboard for decision makers. And the idea is to see that linkages throughout the care delivery process. And something that we've also learned through this, a key learning has been, I think it's also a shared learning with Swasti's work in Andhra, is many of the cases are underreported. And it's not necessarily the fault of community health workers. The capacity building to actually attribute something or a health outcome to climate change is yet to happen. And I think the National Program on Climate Change and Health is still working on launching what does that systematic capacity building looks like for different frontline healthcare workers. I think the next step would be to see how that systemic approach of going through that traditional training of trainers module and actually increasing capacities of ASHAs to pick up these cases, would that lead to more cases being reported to this is yet to be seen. But those are some of the processes that are happening to make sure that now you have systems where you know that there is underreporting, but you know the hotspots. If there are 2 cases, that might be 20 or 30 cases. So you can base your interventions based on that predictions.
Thank you, everyone. It was a very insightful panel. Quoting Aisha out here, that good intentional community leadership, as you said, is the solution to all these problems. And a lot of us do recognize that. And I think that we're here because the question that we're faced with is scaling this, any kind of good community leadership and making it accessible to all. We wouldn't be here if it weren't for, we do recognize that everybody works hard and is able to do it at a local level. It seems like the agent for that kind of scale is still only the government. We're not able to figure out which is the agent that could be that agent that looks at making fit to, the localized, ideal, scalable model everywhere. It still seems to be the government. So my question to all of you in your experience, that do you, knowing what the beast, so to speak, that the government has and those problems, etc., is there some other actor or agent that you see in this ecosystem that we have now for actually finding solutions to that is beyond the government? Or do you see some sort of aspect in which we can work outside of it? Do we have to integrate it, or what is it beyond this? It's a meta question, and I'm not sure if I'm articulating it well. But my concern is that I don't see that to be the agent that is apart from the government. And if the government is continuously an agent that resists, in your experience, have you found, what has been the moment in which there's been a change from the government?
Other than the government, is who else can scale? Yes, please, Aisha.
Thank you. I know you may not be very satisfied by the answer that I'm going to give, but government, it's important to understand why is government the big agent? Because of the money. It is primarily the funding, the resources, the scale, the access that they all have. So I think what we are beginning to see is that there is philanthropic funding which is coming into the ecosystem. Now what is happening with that? It is very scattered. Each of those different kinds of philanthropics, they have their own very special focused agendas, and they want to see their names, they want to see the flashy outputs, only then they want to give them money. So what is beginning to happen in the ecosystem is that this philanthropic funding is getting converged together. There are institutions who are now acting as conveners for this philanthropic funding, so that you can really bring in large amount of money so that you can work in alignment with the government. You will unfortunately never be able to really cut out the government. That is not possible at all. So there is evolution in thinking happening, that how do we bring partners who are ready to put in the money. And when we go back to these philanthropies, the biggest question is they want to understand impact. They just don't want to blindly give out the money. They don't want to anymore give out the money for, let's say, 1,000 number of trainings conducted, 1,000 households, communication happened. They really want to see outcomes and impact and not inputs. And government is also now moving towards that. So like I said, there's no straight cut answer to that, but yes, there are forces evolving. We have to ensure that we can tap those forces and show them what they want to hear, which is the impact. Yeah,
Thank you,
thanks.
thank you. I think no one wants to replace the government, but how do we kind of make it more efficient? Johnson has a point, and then Satya.
Maybe scale and speed is something, all of us think, and maybe there's some solutions have to happen. Definitely, as Aisha was telling, that government is the biggest agency who should be doing it. But again, that collaboration piece which I spoke earlier, that during the COVID time, all of us joined hands together and we could address it. So perhaps if you want to have a scale and speed, government has to recognize the role of civil society organization, philanthropic institution, and create those spaces of dialogue instead of, you are doing like this, you are doing like this. Instead of that, we should dismantle these walls and work towards the community leadership, which all of us are talking about it. One example that I would like to narrate from the government of Jharkhand is that when we worked on the migration labor, we conceptualized a program called Safe and Responsible Migration. People are anyway going to go, and they have to go. But how do you restrict the distress migration is something was the agenda. And we were able to, I could say that a large number of people from one region called Santhal Pargana used to be working in Ladakh, almost 25 to 30,000 every year. People used to die because of the climatic factors. We engaged with the BRO, Ministry of Defense, and we could monitor and track and then have some solutions. And they agreed that there is exploitation in the supply chain, and this has to be addressed. Today, if you look at Jharkhand, as far as the labor migration is concerned, we were able to put through in the system and state migrant control room up and running, which we started during the COVID response time, that anyone is dying anywhere in the globe, in case of natural death, accident, because of the atrocities, that mortal remains come back to Jharkhand, and government is funding to reach their mortal remains to their respective villages, ensuring social protection around, ensuring that some compensation are being paid, and also engaging with the external affairs and within the in-country departments to have that mechanisms where they are dignified way they are being handled and dealt with. So that we have been doing, and it's happening now. So we know where the people, what is happening.
So, see, I'll take this back to the point I said that, why you are saying government. More than government, I'll say the state has to be responsible for it. And why state will take the responsibility, just not because it's a global issue and everybody wants to talk about it. Because I want to take it as a rights approach. That's the rights to survival, right to existence, right to live and dignity. In all aspect, it is being impacted. And that's why just creating an extra department or adding, as part of their SOP is not going to fulfill the dream that, we are at a place where we are competently addressing it. And that's why even if you create data-centric point, you need to look at the intersectionality which is impacting. And just I'll give an example and end it. So let's say when we were working in Pokhran, which is one of the place in India which attracts highest sun rays, and that's why you have a lot of solar plants there. Now there is an early child marriage because and there is a death also of these young girls who are pregnant in early age. Now these are indirect data points which goes back because of the heat Pokhran receives. Unfortunately, we are not yet prepared to address and document this as an evidence. And that's why when we say that it's just not Department of Forest and Environment who has to be held accountable, that it's your job to fix it, and that's why when you're talking about scale and speed, because we are talking about urgency, just like COVID time, You know, so we did not waited. You did not try to look at your egos and other egos. You know, who are small, who are big. Everybody, wherever you are available. You know, please join hands. So that's where we are talking about, and that's why we are talking about speed and scale. You know, so yeah.
No, thank you, Satya. I think we can make use of the fact that there's no next session and there's only lunch and take a few more questions. Anuja, you have a question?
Hi, thank you so much, Anuja from Swasti. Thank you so much for the important, conversation. And like Priya said, almost everybody in the room was listening intently to your experiences and your insights, and definitely echo to our experience of working with the communities. My question is, when survival becomes a priority, everyday priority for vulnerable groups, especially rural women, how do we, their health, their own health often gets pushed to the background, especially reproductive health. Things like menstrual care. So you spoke about impact of climate and menstrual health. Very prudent point. Access to maternal health services, even mental well-being due to climate stresses. All of these conditions, they don't get the adequate attention that they should, right? So from your experience of working with the communities, working in the space of climate and health, what do you think, how can we bring these invisible issues to the center of climate action and ensure that women's health becomes a core part of the resilience rather than just an afterthought? Anybody who would want to respond?
So recently, like you also mentioned, we are trying to document all the issues. It's never been documented actually. हम जिन कम्युनिटीज़ में काम कर रहे हैं उनके साथ अब तक इस तरह की बातचीत की शुरुआत भी नहीं हुई थी. जितने भी ऑर्गेनाइजेशंस काम कर रहे थे वो जो डेली स्ट्रगल्स हैं, अगर हम स्ट्रीट वेंडर कम्युनिटी की बात करें तो उसके ऊपर बातचीत चल रही थी कि उनके क्या राइट्स हैं या उनको क्या एक्ट में क्या प्रोविजंस हैं, कैसे उनके सर्टिफिकेट्स होने चाहिए एंड ऑल. तो आप अगर अभी थोड़ा पीछे मुड़ के देखेंगे तो बहुत सारे ऑर्गेनाइजेशंस काम करते हैं स्ट्रीट वेंडर एक्टिविटीज़ के ऊपर, लेकिन ये क्लाइमेट इम्पैक्ट्स के ऊपर, हेल्थ इम्पैक्ट्स के ऊपर बहुत कम काम हुआ है, बहुत ये रहा है. तो हमने अभी यहाँ पर ये जो अभी लाइक VSR इनिशिएटिव, इन सब चीज़ों को जब हम पिछले 1 साल से प्लान कर रहे थे, सिंस वी हैव लॉन्च द रिपोर्ट, हीट हैवॉक रिपोर्ट, सो in that scenario we are just planning and we are now started to execute all these things कि हम इसको रिपोर्ट, हम इसको डॉक्यूमेंट करना शुरू करें कि उनके चैलेंजेस, उनके प्रॉब्लम्स आ क्या रहे हैं, या उनकी तरफ से लाइक आयशा ऑल्सो मेंशन कि उनकी लीडरशिप सामने आए, वो खुद से बताएं कि उनके प्रॉब्लम्स क्या और वो खुद ही से बताएं कि उसके सॉल्यूशंस क्या हो सकते हैं. तो हम इसके ऊपर डॉक्यूमेंट करना शुरू कर रहे हैं कि उनके चैलेंजेस अब तक, क्योंकि अब वो बात भी नहीं करना चाहते थे. सिंस एक और प्रॉब्लम थी हमारे साथ कि अगर आप इस कम्युनिटी में देखेंगे तो ये मोस्टली मेल डोमिनेटेड कम्युनिटी है. यहाँ पे जो लीडर्स हैं, जो बात कर रहे थे, जो काम कर रहे थे, वो भी पुरुष थे. तो महिलाएं पुरुषों के साथ इतने डीपली ऐसे बातचीत नहीं करना चाहती हैं. तो हमने पिछले 1 साल में विमेन लीडरशिप को आगे लाने का काम किया. हमने वो सोचा कि हम और हमारे जो मेरे जो कुछ फेलो एक्टिविस्ट हैं, साथी हैं काम, उन्होंने किसी ने अपनी बहन को सामने घर से समझा के लेके आए कि हमें इस पे काम करना चाहिए. किसी की वाइफ इसमें सामने आ रही हैं कि अगर तुम जाओगे तो वो तुमसे बात कर पाएंगी, वो कनेक्ट हो पाएंगी. तो हम अभी उस पर काम कर रहे हैं. हम लगातार इसको डॉक्यूमेंट करने की कोशिश कर रहे हैं, उनके जितने भी चैलेंजेस थे. और लाइक यू ऑल्सो ये कि हम इसको कैसे रिपोर्ट करें, कैसे हम अथॉरिटीज़ तक लेके जाएं. तो वो पूरी मैकेनिज्म पे हम काम करें कि हम डेटा ड्रिवन फैक्ट्स और जितने भी एविडेंट डिटेल्स हो सकता है वो कलेक्ट करें और हम उनको लेकर के सामने जाएं. तो दिस इज़ द प्रोसेस वी आर इनिशिएटेड एंड थिंकिंग कि हम इसको किस लेवल पे लेके जा सकते हैं. सो वी आर वर्किंग ऑन इट.
Hello, thank you so much for such an insightful panel. I have a question to Ms. Chaudhary. You mentioned about how the informal networks of women have been very helpful in early warning systems, and I can't help but draw parallels to one of the research I did on the farmers' protests in the country and how women, while operating within one of the most patriarchal belts of the country, managed to mobilize in such large numbers there. So my concern is that when these informal networks of women are formalized, they often become bureaucratized and lose what it was that was making them so effective and their community roots. How can then we strike a balance in recognizing them, but at the same time keeping their essence and ensuring that women reach the most interior parts and don't lose the outreach that they already have? Thank you.
Thank you very much. I think that's a very beautiful insight what you brought out. And how we try to look at it is that, and if I again go back to leadership, leadership always does not need to have a formal authority. It is just about really trying to get the perspective, using data, using stories to be able to put forward your voice. Oftentimes, we want to attach formal authority to it, but my question is why? Why would you want to? And India is a very unique country where if I have to take the example of health again, because that's where the maximum frontline workers, 80% of them are women. They are not formal workers of the government, but they are still delivering 80% of the healthcare. So I don't think we should really get these things into the boundaries of a formal authority. We can, if we are able to get the desired impact that we want by bringing the voice through those informal networks also, then the question is, why do we want to formalize it? So I think in my mind again, let's say hypothetically कि formalize कर भी दिया हमने, अब उसमें अगेन आपको क्या अलाइव करना है? अलाइव आपको यही रखना है कि जो आपने फॉर्मल अथॉरिटी बनाई है उसका जो कोर इसेंस है, कोर विजन है, कोर इम्पैक्ट है, वो करप्ट नहीं हो रहा है, वो चेंज नहीं हो रहा है. और वो कौन मेंटेन करेगा? अल्टीमेटली 1, 2, 3 लीडर्स ही चाहिए जिनका इंटरनल पैशन हमेशा अलाइव रहेगा, जो हमेशा लार्जर एजेंडा को पहले रखेंगे और पर्सनल एजेंडा को बाद में रखेंगे. And yes, when you get power, when you get authority, it tends to corrupt you. It tends to create an adrenaline rush. तो इसलिए मुझे लगता है it is a lot about internalization. It is a lot about looking inward. What is success to you will matter at that point in time. If success is just probably getting a picture with the chief minister, then you are not the kind of community leader we want. If success to you is spending that 2 hours with probably somebody in the community, listening to their problems and ensuring that when I am able to go back and have somebody go meet the CM, this parcha is what you want to hand to the CM, not a picture. So that is your success. That is the kind of people you want to ensure are the ones who are able to take that formal authority forward if you want to formalize those networks. It's a very tough one, but it is possible. It is a lot about internal, external. Thanks.
Hi, I'm Aditi. I work with Swasti. So I'll just quickly pose this question. So we spoke a lot about participatory methods when it comes to designing the DPRs and action plans that we do with the government. I'm not sure if the talk about financial DPRs got missed, because a lot of time what happens is on the field, although the activities are pretty planned out, but the funds are disbursed through the panchayats. And there's a delay with the funds in the panchayat. So, and we all understand how much those funds are important for the community to actually put that to fruition. So, do we also work within that? Is there any, participatory method that we work with the panchayats? Any those kind of insights? Because I know activities can be planned, but what about, and if we don't, let's say, if that's not the focus, then are we kind of escalating that? If there's any process for that we worked on, I'd greatly appreciate if anyone can answer. Thank you.
So, interesting question, So we had 2 insights, and one was a failure and the one, we still tried. And I'm not shy of talking about the failures because that's where you learn it. So we were thinking something around preparing a community-based water security plan. and I know the area is vulnerable for drought, doesn't have the ability and the skill to kind of tap the rainwater, and then how do you work the different the check dams and the rainwater harvesting system, and then from where the money will come, So the idea then, it goes back at a panchayat level that, okay, the exercise started with brainstorming which department is directly responsible for doing this. And then you look at the intersectionality, where are the other schemes which can come together and address this as a problem and fix it up. You'd be surprised, we had almost 20 departments who were held responsible for this, and you have to go back and activate their schemes, Obviously, it won't happen in one go, but the point that when you're making these community-led institutions to be aware about it, that you are walking in their doors and asking, even the officials, they would say we were not aware of it, right? And that's the power of the civil society, where you are not creating a pressure group, but you are creating them aware and the informed, a community group where they know that this is there, And as Peter said, let's say Mission Vatsalya receive a very bare minimum fund from the central government, and even within that, if you are not able to use 7 crore, it's like a criminal offense, So are you making somebody accountable that you fail to utilize this? And that's where it's important. And the second example, which was very interesting, and obviously Swasti and the CMS group, credit goes to them, and that's connect back to what we as in civil society is doing. We have a one single approach, and which is mostly looking at the project-driven approach. Okay, so when you're going to the community, you say, no, we promise something X to the donor. We'll just focus on the X, but you can also achieve Y, Z, and the other stuff too, and we went for one health security plan, and we learned that there are almost 8 to 9 schemes with the same beneficiary eligible to receive it, So I think, and that's where we need to revisit our own strategy. You are not liable just to the donor, but also to the community, because they're not coming to Mandapam and asking, hey, help us. You are there, so you can be an informed one to those community members and make them empowered. So I think that's where the answer lies.
Thank you so much. I know there are a couple of more questions you want to take. Okay, later. Thank you so much for being a wonderful audience. I think you should clap for yourselves. Thank you for asking very in-depth questions, as well as the panelists. They deserve a huge round of applause because they are champions who've chosen to not look away in the face of heat, in the face of dust, in the face of extreme climate crisis. They've decided to kind of stand with their communities and kept this conversation very grounded. So my heartfelt gratitude to each of you, as well as to Blockchain for Impact and Swasti, who have helped deliver this session to you all. Can I request you all for a group photograph before we break for lunch? Thank you.
I'm Swasti, the co-host of this panel discussion. And thank you very much for being here for this panel discussion on ending AIDS by 2030. It's also a great privilege for me to introduce the chair, moderator, and the distinguished speakers who have come from different parts of the region. And first, I would like to invite David Bridger. David Bridger is a country director of the UNAIDS India office, leading a coordinated UN response to HIV in the country, providing strategic direction, advocacy, coordination, and technical support. He also served as...
David. That's enough one.
Yeah. So it's my pleasure to invite David to the dais, actually. A warm welcome to you, David. And next one is Dr. Adiba. Dr. Adiba is a professor of medicine and infectious diseases. She's also a pro-vice chancellor and president of Monash University, Malaysia. She's an immediate past president of International AIDS Society. Dr. Adiba has been a formidable advocate for HIV programs, especially for KPs around the world. And thank you so much, ma'am. And Dr. Chinmayi Das is a public health specialist at the National AIDS Control Organization. She is responsible for strategic information, including information technology, care, support, treatment, and supply chain management under NACO. Thank you so much, Dr. Chinmayi. And Madam Varapon is the Deputy Secretary General at the National Health Security Office, Thailand. She also plays a key role in the development and implementation of public health insurance policies and strategies, significantly shaping Thailand's healthcare landscape. Thank you so much, ma'am. Dr. Sheila Godbul doesn't need any introduction. She's the Director of National Institute of Translation Virology and AIDS Research, formerly known as NARI. And yeah, thank you so much. I'm delighted to welcome you, ma'am. Thank you so much. And finally, Madam Alka Narang is a seasoned development professional with more than 30 years of experience in strategic planning, advocacy, and program management, particularly on HIV prevention and care. Thank you so much, ma'am. And we welcome now, and once again, thank you very much for joining us. And now I'm happy to hand over the session to David. Thank you so much.
Great, thanks, Edwin. Thanks for getting us organised and getting us started. Now, look, good afternoon, everybody. Let me start by thanking each of you for being here this afternoon, and thank you for joining what is going to be the best session for the afternoon. I also need to convey some apologies. Apologies from Mr. Eamon Murphy, our UNAIDS Regional Director for Asia Pacific. He fully intended on being here this weekend to chair and moderate the session, but unfortunately due to a family emergency, he had to withdraw at the last moment. So you are stuck with me as chair and moderator. And before I turn my attention to the absolutely distinguished all-female power panel that we have, could I also acknowledge our partner in hosting today's session, Swasti? And I think there's a couple of Swasti staff here. Yes, stand and just let's say our appreciation to you for giving us this slot. Swasti have had a long connection and partnership in the HIV response here in India and in many countries around the world. So let me acknowledge and thank you. I also, as I look around the room, I really see a whole host of colleagues, activists, individuals representing organisations who have been a part of the response here in India, part of the HIV response in partnership with the government of India. And I really would like to acknowledge you and thank you for your past, present, and ongoing future support and contributions to the response. And please, I really look towards you to sharing a lot of your valuable experience when we come up to the question time and open the floor. So a couple of ground rules. We're here for just under 90 minutes, so set your watches. Having attended a number of other sessions over the last 2 days, I recognise that for the first 10 or 15 minutes, there can sometimes be a little bit of turbulence as the back door opens and shuts and people come in and out, and sometimes there's a little bit of noise in the background. Apologies for that. To try and get us through that, I'm going to submit you to a short 10-minute presentation and overview of the HIV situation in the Asia Pacific region, and also just for anyone who's visiting from outside of the region as well. I hope that allows us time to settle down, compose your thoughts, but also perhaps digest lunch. So, today's session is entitled Leaving No One Behind, Ending Inequities and Ending AIDS for a Sustainable Future in Asia. In 90 minutes, we seek to seed a conversation. And I really want to seed a dialogue that needs to happen now, but also needs to continue over the coming months. Globally, the UN Joint Programme on HIV and AIDS, UNAIDS, which I work for, has been tasked this year with developing the next global AIDS strategy from 2026 to 2031. Regionally, and here in India, we plan to convene and partner with others in convening a series of dialogues and conversations that take stock of where we have been, what the current situation is, and mapping our way forward over the next 4 or 5 years. So clearly, we're not going to cover all of this in the next 90 minutes. But I think we have a star-studded panel and a wonderful audience to get this well and truly started. So for anyone here not familiar with the region, I'm going to offer 8 very quick lightning slides, and I'm going to go very quick, okay? So, excellent, we've got the right slide. So, the goal of ending AIDS by 2030 is ambitious, but it's not wishful thinking. In Asia Pacific, several countries have made really impressive progress. Some are treating more than 80% of all people living with HIV, including in Cambodia, Nepal, New Zealand, and Thailand. Nepal is also among 4 countries globally that have reduced new infections by more than 75%. So they're well and truly on their way, and they have real potential for achieving that 90% target by 2030. Also, 18 countries and territories have eliminated mother-to-child transmission globally, including 4 in Asia: Malaysia, Maldives, Sri Lanka, and Thailand. But in light of what's possible, the region as a whole is underperforming, and that's why we're here today. In 2023, 78% of people living with HIV were aware of their status in the region. But that also means that a quarter of people were unaware of their status. 67% of people living with HIV were on treatment last year, and 65% of those people achieved viral load suppression. So roughly, my message here is that 1/3 of the people living with HIV in the Asia Pacific region are not getting all of the care they need to stay healthy and to not transmit HIV forwards. Asia Pacific has the world's largest HIV epidemic outside Eastern and Southern Africa. In 2023, there were 6.7 million people living with HIV in the region. To end this epidemic as a public health threat, the Asia Pacific region, with its huge populations, will play an absolutely critical part in the response. India is and will be critical, and it has so much to offer. In the region, there were 150,000 deaths due to AIDS, and since 2010, AIDS-related deaths in the Asia-Pacific region have declined by more than a half. But the reality is we really do have, in this region, a HIV prevention crisis. This region has accounted for a quarter of the new infections in the world last year. In 2023, there were 300,000 new infections in the region, and since 2010, there has been just a 13% reduction in new infections for the region as a whole. Now, that compares with the global average of a decline of 39% in new infections. So we're not getting closer to the epidemic control that we really want to achieve. In some countries and communities, the epidemic is rising rapidly. 4 of the world's 10 fastest growing HIV epidemics are in the Asia Pacific region. For example, in the Philippines, new infections have increased 6-fold since 2010. And that's largely being driven by a young men who have sex with men epidemic. New infections in Fiji have tripled, and in part this is due to a growing intravenous drug use issue that has emerged only since COVID. In Afghanistan, we've had a 175% increase due to limited service access and the public health disruptions. And in Papua New Guinea, the epidemic has doubled, and now there are 5 children born every day to HIV. These trends threaten our joint mission for epidemic control and sustainability. 4 of every 5 new infections in the Asia Pacific are among people from key populations and their partners. In some more mature epidemics, like we're seeing in some states here in India, we've seen an increase in the proportion of new infections among the general population as well. Across the Asia Pacific region, new infections increased by 1/3 among men who have sex with men since 2010. MSM epidemics are rising steeply in some countries and declining not fast enough in others. Key populations often face rising HIV rates, low service access, and stigma and discrimination. And these communities often face intersecting risks. Now, the point here is about young people. 27% of new infections are among young key populations in the region. But in the bottom graph, if we look at the general youth populations, we can see in 6 countries in this region, 1/3 to half of new infections are amongst young people. In the top left, you'll also see that we see rising new infections among young people in some countries, particularly Papua New Guinea, Afghanistan, and the Philippines. And HIV prevalence among young men who have sex with men has doubled in some countries like Indonesia, Malaysia, and Vietnam. So why is it that even where treatment services are available, people get diagnosed and disappear into the shadows? This brings us to the social and structural factors that really drive people away from services. There are legal barriers to the HIV response across the region. I won't read through all of those, but you can see 38 countries criminalise some aspect of sex work, 17 still criminalise same-sex relations, and 28 criminalise drug possession. For people from key populations, communities, and those living with HIV, these are real reasons to remain fearful and hidden. Criminalisation and marginalisation deepen their vulnerability and make it harder for them to reach services. And there's a real interplay between these laws and social attitudes that manifest as stigma and discrimination. Finally, I want to discuss the elephant in the room, which is funding. So over the last decade, we have really seen external funding for HIV programs in this region decrease dramatically, and decrease by 60% over the last 10, 15 years. While we've seen domestic resources increase by 47%. So several countries in this region still rely on international sources for more than 50% of their prevention financing. The region still has a high donor dependency for prevention, and this is becoming and is a looming crisis. So on one side, we really do applaud the increase in domestic allocations, but most of that money, if we look at it, is actually going towards treatment and commodities. At the same time, we're seeing a dramatic reduction in international funding. We must quickly address the investment gap in the region, especially when it comes to spending on key populations and prevention. So look, today's discussion will really explore some of the actionable insights, strategic directions, and priority areas for scaling efforts towards ending AIDS by 2030. As I said, we are seeding the beginning of a discussion that we hope will go for the next 4 or 5 months. Now let me turn to the panel. Okay, so now we can relax. I think we've spent a good 8 minutes just settling everybody down. I'm going to just turn to the panel with a question for each of them, and then we will open the floor for questions. So please just take note if there's anything in the responses from the panel to these questions that sparks a follow-up question, that would be absolutely wonderful. Dr. Adiba, Salamat Datang. You have an enormous wealth of experience built through various perspectives of the HIV response at national, regional, and global level. We continue to push for innovations and technologies that will advance our prevention and treatment efforts, as well as increasing ease and access to services. Is this the pathway to end AIDS in Asia and the Pacific? Help us understand what's working and what we need to be doing more of.
Thanks very much, David. And it's a real pleasure to be here this afternoon with all of you. So I think, you know, those figures that you've just shared with us of the less than stellar performance of the region is very sobering. And, you know, we have, I would say we have a lot of tools to get there, to end AIDS by 2030. Some countries, as you know, are already doing it. Do we need more innovation? I think the short answer is yes. I think we will still need a vaccine. I mean, let me just touch very quickly on what was called the game changer by many people of the long-acting lenacapavir, the long-acting injectable, 2 doses a year, 100% efficacy in clinical trials, in 2 clinical trials, one 100% and another 99%, one in women and girls, the other in men who have sex with men. Now that's amazing. And I think I just want to touch on that very briefly, knowing the elephant in the room is who's going to pay for it, right? The price is something like $40,000 per year, but research has also shown that it can go down to $400 per year if we put our minds to it, if we work together just as we did for the COVID vaccine. So in answer to that specific answer, I think we will need to continue having innovations, but we also need to do better at using the tools that we have. For example, the injectable lenacapavir. Using tools such, and I'm very conscious that I'm in the middle of a country that's done amazingly well in digital technology. I firmly believe that, particularly for key populations, and you've touched on stigmatization, et cetera, that is one of the tools. I mean, of course, digital technology goes all the way from smartphone to telemedicine, et cetera, and I think this is also another tool as a group that we have on our hands to reach out to key populations, from awareness all the way to treatment adherence. And the studies have shown various results, but on the whole, I think this is something that we need to use a lot better. So I think, yes, we do need more innovation, but we also need to maximize the tools that we already have.
Thank you. Dr. Chinmoy, namaste. India is developing its new national AIDS strategy for 2026 to 2030? Yeah, 31. So it's a time to reflect on the many successes, but also a time to look forward. Sustainability is the buzzword. how is India navigating towards sustaining its HIV response to 2030 and beyond?
Thank you, David. Good afternoon, everyone. The question, the word sustainable, I think that's what India stands for, be it any health program. So as you might be knowing, the word Atmanirbhar, that's the buzzword these days. So that means our government is self-resilient, self-reliant, and we have invested enough resources for our health programs, including HIV/AIDS and STD. So what we usually miss out is the STD part of the component. So what we have done is, under the 5th phase of National AIDS and STD Control Program, we have a fully domestic funded program with very little finance coming from the donor partners. So that's how we have ensured that we are Atmanirbhar. I'm using that word again and again. So for this, I'll tell you what exactly we do. The national strategic plan that's formed for each of the phases of the program. So it's done in a very scientifically evidence-led approach and in a participatory and consultative approach. So we are right now also embarking on the journey of writing the strategic plan for the next phase, and with all the stakeholders' involvement, with ensuring that we have enough scientific evidence coming from surveillance, coming from research, coming from the programmatic data. So we make our indicators accordingly. We invest resources where it is needed. We ensure that we give more resources to those hard-to-reach areas, hard-to-reach populations which need more. So accordingly, every fiscal year, the annual action plan that is made by the government includes all the 36 state AIDS control societies, and of course ensuring that we give them what they need. So that's one of the ways in which we sustain. So sustainability also includes active community participation. So we have community-led monitoring program, we have community system strengthening, and we have identified community champions also who help to sustain the program. Other than that, institutionalizing a program is the forte of our NSCP, be it for surveillance through the regional institutes, be it for research through our NIHAR institutes, or be it for the program implementation in various hospitals, in the laboratories, be it through the social contracting models. So we have an institutional mechanism. So this is the forte of the program for sustaining the financing mechanism. We also have many other parameters. So for example, if I talk about the quality assurance part of laboratories, if I talk about in every medical college through the National Medical Commission, it is a mandate to have a ART center. So that is again a way of sustaining the efforts. We also ensure that this sustainability is taken care of through integrated approach. So we work with various national health programs, be it the tuberculosis program, viral hepatitis, NCDs for diabetes, hypertension, and also for mental health, we are working on it. And also with the RCH program, the Reproductive Child Health Program for elimination of vertical transmission of HIV and syphilis. That's another way of sustaining. And of course, here equitability is also taken care of. So we also have the HIV Sentinel surveillance, which does surveillance not only for HIV and syphilis, but also for hepatitis B, hepatitis C, and now also we are doing random blood sugar and blood pressure being measured. That is all integrated into the surveillance system. So this integration of various programs and various activities, institutionalization, community participation, domestic funding. So all these, that's how we are ensuring that we sustain our response, because sustainability is actually looking into the progress that has been made till today, and it's a promise for tomorrow. We have to ensure that we keep our promise for tomorrow. The hope that HIV has to be normalized into the system. the healing of HIV, the prevention of HIV, the detection in all those remote corners, in those unreached population. The last mile we know is difficult, so we are also working on it. And the impact of all this, our estimation report and our Sankalak very clearly mentions the impact of all this sustainable and equitable response that you see is very clear, because we have had a more than 44% decline in the new infections since 2010. We have had more than 79% decline in AIDS-related deaths since 2010, which is far beyond the global standards. So I guess looking into sustainably funded, domestically funded program is the forte of the program. So thank you.
Thank you, Dr. Chinmoy. And I think we have your tagline, which is the promise for tomorrow. Okay. Dr. Sheila, namaste. You have dedicated a large part of your career to research. And Dr. Chinmoy just mentioned the importance of the evidence-based and evidence-informed innovations and programming in the India response. So you have been reassuring us that the interventions that we are using are proven and based on evidence. But do you see some frustration, especially in the region, where we see it's taking so long for evidence-based interventions to actually get to scale and to save lives? What or should we be doing to accelerate and get things from pilot to programming?
Thank you. Thank you for having me here, Swasti and UNAIDS. I think that's a very good question, but it has a lot of different contexts to respond to that question. Earlier today, I was in a session that was talking about research priorities for research on vaccination and vaccination programs, implementation research. And there we saw that even if you had a good vaccine that was efficacious, it did take a decade or more, and sometimes 2 decades, to bring it into the public good. So for any research-based evidence to become public good, takes time. While you talked about frustration, I must mention that 2011 we first published the HPTN 052 trial results. 2015 we started test and treat in India. So that was a very short time. And in fact, very quickly by 2012 we had even raised the bar for CD4. But we've slowed down since in that sense. And that is also because, first of all, the belief that probably put the money where it makes the most impact. So treat the infected and prevent new infections. Possibly treating the infected for us at that time was the biggest priority. Now we have the time to do the mop-up. And this is when I think we start to look at those prevention interventions that have been proven. And as Dr. Adiba mentioned, there is the pre-exposure prophylaxis. And it's not just the prophylaxis, but a prophylaxis that uses a drug that doesn't have to be given very frequently. And we are living in India where you get a license to manufacture, and we can manufacture at scale, and we can manufacture at much less cost. So for this, not just for India, but for this region, that is something that we must all plan together as a whole region, because that is where we can then bring in the multi-pronged intervention that we should be doing. So not just treat those who are infected, but also who are likely to be infected. So I think that is one of the biggest, the second elephant in the room that we need to address. And we've already tried to look at evidence for that, because our institute, which is now the Institute for Translational Virology as well as AIDS, has also finished working on a demonstration project to show how well it can be accepted and how well we can work on PrEP as well. Research always walks about 8 to 10 steps ahead of the program. The program has to think about equity, it has to think about the rolling out costs, it has to think of the financing. And the word that Dr. Chinmay just talked about, sustainability. So we can't just start something and have fall flat in a couple of years. So bringing research into the program requires not just advocacy. And I remember going and it was in 2014 that we went and talked about the 052 trial results in a huge meeting in front of the TRG, the antiretroviral ART TRG at NACO. And then it came up very soon. So it requires research advocacy, and there was a session on public health advocacy the other day, but it requires financing, and it requires the infrastructure that needs to be developed. But I think we as a country can do that very well, because we are the country who have managed to bring, we are the leaders in direct benefits transfer, aren't we? And we have big companies. I mean, we have one of our better known startups, our food delivery startups like Swiggy and Zomato. Why don't we use something like that to deliver our medicines to the people? Have them come in. We are the digital leaders in the region. Why don't we have apps to speak to the participants, or speak to the patients, and then they come in only for a drug pickup once in 6 months and their medicines, and the rest of the time they use their self-agency to call for the medicines that they need. And then we have some AI-based tools that look at how, where the shortages are for the individual. I'm not talking about the distribution system. So we can do a lot if we decide to do our yoga and stand on our heads and change the system, because I think the next 5 years, the next iteration of the program is going to be most important for us. And we need to be also looking at point of care testing, particularly for early infant diagnosis. The evidence is there. We need to change our systems probably, because it's important for us. We are one of the countries that has not yet eliminated mother-to-child transmission. So there are a lot of things where we can leverage and use technology, not just technology, but also evidence. But I recognize it can be frustrating, but at the same time, one can understand why it's taking longer. Thanks, David. Maybe that's not the answer you wanted.
No, that is the answer that I wanted. Look, thank you, and thank you for addressing the other elephant in the room. Okay, Ajahn Warapon, Sawadee Krap. Welcome back to India. Look, you've focused a substantial degree of your work and efforts on health financing. The path ahead will involve convergence and integration of HIV in many countries in the region back into the health system. In your time at WHO Zero here in Delhi, you helped advise countries on universal health coverage. Tell us a little bit more.
In Zero, right? Last 8 years ago, I'm working on Zero for health financing. I support the member state to develop their universal health coverage policy, especially for health financing. And only 9 months. It's not too much for. It's not just like working. It's learning for myself as well. So that is my work at Zero on that day. But for today, I have to talk about the HIV/AIDS. I would like to share about the key challenge in Asia that require urgent policy. And also I would like to share about the strategic we have to move on. Let me begin by sharing some key challenges we are facing in the region, and then reflect on strategic direction must be prioritized that Thailand has taken, with my offer useful insight for others. Asia is at critical point in our HIV response. Despite past achievement, we are now navigating a much more uncertain landscape. First, we continue to face inadequate resources and high donor dependency. In 2020, our region has only 3.7 billion US dollar available for HIV program, with a 60% funding gap to meet the 2025 target. Although domestic resources have doubled since 2010, but from 2021 and 2022, they declined by 5%. But external funding has dropped more than half since 2010. This shortfall is especially worrying for vulnerable groups like migrant, mobile populations, and people in rural or border areas. Second, key population programming remain underfunded. Although key population account for the majority of new HIV infection, only 11% of total HIV spending in 2022 was allocated to this group, far short from the 35% needed by 2025. Most of this funding remain donor dependent, with insufficient investment in addressing human rights barriers like stigma and discrimination. Third, community-led response are fragile. Civil society organizations are essential in reaching those most at risk, but they remain heavily reliant on dwindling donor support. Official development assistance to NGO and community-led organizations has significantly declined in the Asia Pacific. Fourth, there are troubling rise in HIV infection among adolescents and young people, like David showed that. The fast-paced influence of digital platforms and also changing sexual behavior are evolving faster than our traditional prevention approaches. Meanwhile, stigma, discrimination, and also legal barriers still make it difficult to reach young people effectively. We must rethink our strategy to protect the next generation. And finally, fragmented data system and underused digital tools are showing down. The lack of data integration across HIV services providers make it hard to ensure data accuracy, continuity of care, real-time follow-up and monitoring, and also telehealth, mobile outreach, and online prevention tools are still underutilized, particularly for youth and key population. To move forward, I'd like to share 3 strategic directions drawing from Thailand experience that we believe are crucial for accelerate progress toward SDG 3.3 on ending AIDS. First, integrating HIV service into universal health coverage and primary health care, like in Thailand. Thailand is one of the few middle-income countries that finance the majority of its HIV response domestically. 91% of HIV funding now comes from the domestic resources. HIV is fully embedded in our USC system. Every Thai citizen can access a wide range of HIV services, condom, pre-exposure prevention, post-exposure prevention, HIV testing, and ART regarding their socio-economic status. We provide HIV testing twice a year and include self-testing kits under USC. At 2023, Thailand reached 91-91-98 on the treatment cascade and successfully eliminate mother-to-child transmission due to its strong antenatal and delivery care system. A notable innovation is Thailand's CBO, contracting mechanism under USC. Over 82 CBO are certified and reimbursed for delivering HIV services through the Reach, Recruit, Test, Treat, Prevent, and Retain, or RRTGR model. In 2022 alone, this approach led over 250,000 key population members and ensure continued care for over 70,000 people living with HIV. Empowering community and civil society engagement is not optional, it is essential. The second strategy direction is people-centered integration of HIV and other health services. Thailand has further strengthened its HIV response by integrating services for related health conditions into its USC system. HIV services are now co-delivered with STI, TB, hepatitis B, hepatitis C services, both in hospital and through community-led health services point. Key results in 2024 include over 2 million people access TB services, with nearly 200,000 TB HIV co-infections. 2.7 million people were screened for hepatitis B and nearly 300,000 for hepatitis C across 6,000 health facilities. This approach ensures continuity of care, maximize efficiency, and build health system resilience. The third direction is investing in innovation and technology to advance HIV prevention and strengthen community response. Thailand is expanding access to HIV self-testing, offering tele-PrEP consultation, and using our centralized national AIDS program data system to track service delivery and reimburse provider. These tools are also enabling community-led groups to reach people online and provide services in a discreet and effective way, especially youth and hard-to-reach people. In conclusion, to safeguard our HIV progress and accelerate toward 2030 target, Asia must prioritize. The first is sustainable integrated financing to USC and strengthen public health care. Second is increased domestic investment in key population, emerging HIV risk group, innovation and technology. And the last is structural reform that protect and empower the most affected. Last but not least, Thailand experience showed that health equity and financial sustainability are achievable even in challenging economic challenge times, when HIV is positioned not as a separate burden, but as a core component of health and human rights. Thank you for your attention.
Kunwarapon, thank you very much, because I think that was an excellent example of how all those core elements of a HIV response can come back into, be integrated into a government response. Alka, namaste. You have worn many hats and have worked tirelessly across a number of development fields. You're currently working with the Catalyst Group here in India, an organization that's worked in strengthening community leadership and capacity. There's still a lot more we can do and should be doing. What are your thoughts and perspectives?
Okay, thank you, David, and good afternoon, everyone. I just want to take you back by a decade, if it's okay, and if you permit me to take you back.
As long as you're taking us back to go forward.
Oh, sure. Sure. You know, we were looking at the success of the India program in HIV, and we have done exceedingly well, and as was mentioned just now. And what we were doing was, when we were looking at the success, we were saying, what was it which has added and contributed to India doing so well? And the framework, we were looking at 7 components. So the first component, these are not rocket science, but then that's what we have. So political will and leadership, and there's plenty. So we have it. If the funding is coming from the government is taking on everything. Atmanirbhar, sustainability, sure, there is political will. Then we were looking also at the enabling legal policy framework. And there is a very sound, and you did show the list. And in India, we are doing very well on all those counts also. So that is the legal and the policy environment. The third was the program design, management, the system, and the structure. And program design, obviously, which is coming on and which is building on evidence, which is very robust, which is coming on data, which is there, and the structures which have been set up right up to the district level, starting from the center, and that was another contributing factor to the success of the program. Then comes the financing and the accountability. That's what we were looking then. Then we were not Atmanirbhar in terms of the funding. We were relying a lot on the donor funding, but now the scales have shifted, so it's there. But we did look at that. And the other component which we looked at was partnerships. The National AIDS Control Program in India has the history of and has done exceedingly well on partnerships. When I'm saying partnerships, I'm not talking about the public-private, the way traditionally we talk. AIDS is the only program or the only response where you have the international donor community, you have the academicians, you have the industry, you have the community representatives, you have the civil society, you have the individual experts, all coming together on a common platform, and you have partners contributing to the program and what it is, and responding to the 3 1s principle of the UNAIDS. So you have partnerships. And also, when I say civil society, it's not just individuals, but also the coalitions of the civil society coming together and supporting. And the networks also. Then Ms. Chinmaya mentioned participation of the community. And the community participation was there. And obviously, the moment you say community participation in a program, and that's when we were looking, you have to have confidence in the community. You have to have trust in the community and invest in their capacities to do well, to participate actively. So that's what has happened. And I've already made a mention of the evidence and the response. So all these 7 elements were the ones which contributed to the success. So that's what we were. Now we come to the present. When we look at the present, it is important, I believe, to look at on which of these components have we sustained the efforts, have we enhanced the efforts, or possibly diluted, and where have we diluted, or where they have got diluted just because the program was successful. So sometimes, you do tend to say, okay, things will take care. So that's what is wanting to mention. You were talking about, and Ms. Das mentioned, Ms. Chinmaya mentioned about communities' participation. I would like to, and I dare to, I have the mic so I can, dare to say community participation, all components of the community participation, not just a consultative process in terms of, and including them in the form of designing a program. But I'm very glad you mentioned the community-led monitoring which is happening of the program. And the community which is becoming part and parcel, it is not an outsider, but it is their program, and who is managing everything, right from the design to the implementation to the monitoring, because we know the positive impacts and whatever is happening. So what more can be done? That was what you wanting to know also now going future. So present is where we are. What more can be done is, my sense is that we have somehow, because of the changing financial environment, because of the changing environment, the ecosystem change also, the community involvement and engagement has got slightly diluted. Government has, of course, just recently, and working with UNAIDS, they have brought up the community system strengthening approach they have just put forward. But I personally think that it is a lot more can be done, especially when we're talking about the youth, especially when we're talking about the community in today's context. The community and community equals KPs, key populations in the conversation in this room. But I will also take it to the larger community. So with respect to KPs, the KPs, the nature of their work, the nature of solicitation, the nature of them approaching or getting into risk behaviors has changed. They are more dependent on technology, So is the program keeping pace? Is the design keeping pace with this new nature of how the KPs are moving, where they are moving? That's what a question which we need to think about. And also when I say the community definition, and if I dare to expand the community definition and include all of us as community, because we are equally at stake and we have a stake in the program, then that community in terms of partnerships and platforms for partnerships, possibly that needs to be done a little differently, a little more aggressively. That's what will add to those 7 components moving forward. Also, it was mentioned when we were talking about, in the community, yes, we are doing treatment, yes, we are doing testing, but one of your slides showed how the money which is going into the proportion of money which is going into prevention has become slightly less. So with the current financial situation which you're talking about, can and should NACO, as NACO, National AIDS Control Program, be doing everything which is needed to be done? My answer is no. It has to get partners on board. NACO has had a brilliant experience of partnerships with 18, the last which I know of, 18 different ministries, who have very strong connects with the community, larger community, and maybe larger community part of the KPs also, so can that be revitalized? That platform be revitalized? Can that be revitalized? Because you then become the orchestrator, you become the coordinator, you become the convener of pulling partners together and pulling the different ministries together. Why I'm saying is because the young people which we talk about, the new, and that has been my statement right from the beginning, ever since I got into the AIDS arena. HIV is not the end of my life. I have to live, I have to eat, I have to support my family, I have to look after the other things. Then social protection becomes an extremely important thing. Can NACO do it? Should NACO be doing it? The answer to me is no. NACO has to facilitate it, ensure that the Ministry of Rural Development, if it is providing livelihoods to collectives, does include the communities which we are interested in and working on. If they are doing skill trainings, are their skill trainings inclusive? The last when I saw in one of the states, I'm not going to mention the state, the skill training centers were not inclusive. So can the advocacy ensure that you do that? So to me, what needs to be done is partnerships. What needs to be done is definition of community and reaching where, using technology and reach where you need to be reaching. So that's what I would say for the moment, and I can talk later.
Thanks, Alka, and thanks for reminding us that, again, we need to we need to look back in order to look forward. And if we do look back, we often look forward in a much more constructive and positive and far-reaching way. Now, just could I ask you all to just give one more big round of applause for all of the panelists, because I think they have given us plenty of food for thought to now open the floor for questions. And so I'm going to take 2 questions at a time, and I'm going to ask each of you, if you are asking a question, to please introduce yourself and just say who in the panel you would like to answer the question. We don't have time for the question to go to every single person to have a turn answering. So I have my mic assistant ready, and some hands for any questions. Shiv, first off the block up the back, and one more question over here to the right as well. Okay, so we'll take the 2 questions and then we'll have the answers.
Hi everyone, I'm Shiv Kumar from co-founder of Swasti. Question, ma'am, to you from NACO. The long tail of any infectious disease is usually much more difficult. We saw that in polio, we saw that in leprosy. So what is the estimate of both money and effort required by NACO to ensure that we end AIDS, number one? And number 2, how can we all work with you? In what way would you like civil society and other actors? There are also, Alka, there are social entrepreneurs like us who also worked very, very closely with NACO. How can you create spaces for us so that we can help you in doing exactly what is the national agenda?
So, Dr. Chinmoy, not yet. You've got a couple of seconds thinking time, and we'll take the second question.
Hi, hello David, I'm Dr. Sam. I work with AIDS Healthcare Foundation in India. First of all, thank you for the wonderful panel, but I just want to also, the presence of the royalty here from the community, the very first Indian royalty who is gay and come out as gay and announced himself as gay, Prince Manvendra Singh Gohil. So this is an inclusive room, I would say, if not a panel. But I also came armed, David. Yeah. Okay. I came with the king, so I came armed.
Okay, we will allow props.
Yeah. Thank you. But definitely you should allow one more prop, which is my love condom. So we heard from you, from the panel, about, let me hold my, my warrior. So the panels talked about lenacapavir, injectable drug use, injectable, ARTs or, coming in. Also, we discussed about, going back to Alka Narang's discussion about, the social protection measures that you, and also the partnerships that you had in those times. But I just wanted to come to the basics again. Cheapest tool available in the world still to prevent HIV, STI and other infections. Nobody talked about that. I'm a little pained, and I think he's crying, or she's crying rather. Anyway, so this question is open to anyone. Is there going to be anything called ICAN, which is like International Condom Angels, if I may say, network, which will ensure sustainability, ensure that there is condoms. I'm, to piggyback on Sheila Madam's response on technology and AI solutions. I think there has to be drones dropping condoms in all places around. I don't know. Let's talk about that. But the question is, can we have sustainability in ensuring condom programming is still going to be an answer for at least India or even in the Asia Pacific? Thank you.
Okay, thank you. We'll take that as a comment, but also a question. So we'll go to the next round of questions in a minute. Let me turn to Dr. Chinmoy to answer the first question.
David, I'll ask you to please repeat the question that was told. That's what happens. You miss out.
I'll try to be brief, so time for everyone. One is the long tail of any epidemic. What's the resources and effort required, and how can we all help you?
Okay. The resources that would be required, perhaps it's not just money. It's the resources in terms of capacity, the health force, the ARV drugs that we are manufacturing in the country, the free lifelong ART that we are providing, plus all other commodities like test kits, like condoms. Yeah, I mentioned now. So what we were mentioning was prevention services. Perhaps we didn't specifically use the word condoms. I'll repeat again for your interest. So making available all these commodities under the program free and for everyone. So for everyone, I mean each and every facility which is under the National AIDS Control Program has availability of condoms. So here I think I'll mix the two answers for both of you. So we do have condom being procured under the program. We also have condoms being brought in from the maternal health program. So we have two big sources. We have various manufacturing companies who are supplying us. But what I'd like to mention here, the focus on condoms, we have always tried to maintain under the program. But maybe I'll take this with a pinch of salt, that when we are trying to talk about free availability of drugs for prevention, I mean PrEP, so we are somehow missing out on the messaging for the additional protection layer with condoms. That's one of the reasons, Dr. Sheila will agree with me, that's one of the reasons in some pockets we are seeing a sudden surge of STIs. So I put this with a caveat that right now, under the National Health Program, we are still exploring, we are still looking into more data to talk about more demonstration projects, coming up with more evidence that if condom is phased out and we only talk about preventive ARV drugs, are we going to really reach that mile? Do we really want STIs to show up in those pockets? By pockets, I mean geographic as well as population groups. So that's exactly one of the reasons why we are looking at with a little more clarity before we implement. And about the resources, I guess we are enoughly equipped with the kind of resources for prevention, testing, and treatment, and of course treatment monitoring, which is through viral load testing. So here, I would like to say that we are self-resilient that way. We are trying to build the capacity of each and every healthcare force in the country. We have blended clinical trainings, wherein you just not have to come for physical trainings, but also you do online trainings, and then we come for case-based discussions later in the classroom training. That's one way we are trying to ensure that we are equipped. We are using the digital platform to a very large extent, wherein the IT portal that we have, we call it SOCH portal. It embeds not only the person-centric data, but also resources, the inventory, the supply chain management, as well as real-time monitoring. So these are some of the, I should say, strategies through which the program is envisaging going forward. So, and your question about how you can help, well, and also taking cue from what Alka Madam was just mentioning, that participation of community. Well, it's not only in program monitoring, it's also that all the community representatives, be it from the KP community, be it from PLHIV community, they are all a part of our technical working groups, technical resource groups, any scientific committee or advisory meeting that we have, we make sure that we have enough and adequate representation of each of these communities. The national consultation that is happening for the next strategic plan, also the regional levels we are having, these will be followed by thematic consultations. And we are making sure we not only get people who have been vocal, community representatives who have been vocal on various fora, but also we try to get the local flavors. So for example, I'll say, like when we do a meeting in the northeastern region, we make sure that the state level networks are adequately represented. So we make sure that the community participation is there. The other stakeholders, as I mentioned, the different faculties of community medicine, be it the internal medicine, be it obs-gynae, be it microbiology or STD, STI and venerology. So we do make sure that we have enough participation. We have centers of excellence in the country wherein these faculties are totally involved in the program designing, in the program implementation, and also in giving us cue on what more can we do for the program. Then about the civil society organizations, of course, they are also a part of our program. As I mentioned about the social contracting model, India is acclaimed for that. And we have a very good model of ensuring that we have the civil society organizations, NGOs, who are working in the field are definitely roped in various fields. And the way we are doing social contracting model, that is also a model which we hope that other countries can adopt. And it's actually a very win-win situation, both for the organizations and also for the program. That's a third layer. I guess the next layer is about all the partner agencies that we have. So based on the focus of the partner agencies, the areas in which they want to work, NACO has always worked with them, and what the support that we mainly have asked for is please give us good innovative models. Please give us good demonstration projects. If something new is coming up, be it technology, be it in any fora, like we really appreciate that some partner agencies helping us by bringing in the global know-how, by bringing in any scientific knowledge which is perhaps a little less in the country, and of course helping us with this demonstration projects. So I guess these are the ways in which we ensure that there is participation of all the stakeholders. And when I talk about all stakeholders, I definitely should not miss out the state governments. I should not miss out the other national health programs. I should not miss out the other ministries and departments, government or private, with whom we work with. And again, to answer to what Alka Madam was just mentioning about the engagement with 18 ministries and departments which we had MOU with. Right now we are in a situation where we came up with the HIV/AIDS Prevention and Control Act. In 2017 it was implemented. After that we are not signing MOUs with any ministry, because under the act we ensure that we have enabling environment to safeguard the human rights. We have adequate safeguards for ensuring that the stigma and discrimination in the country, be it for the community, be it for the people living with HIV, is taken care of. So these are some of the points in which we ensure stakeholder participation as well as resilient and sustainable program. Thank you.
Thanks, Dr. Chinmoy. Very impressive answer. Okay, I think I was just going to see, did you want to add? No? Okay. Sorry? You can. Okay, go ahead.
So, condoms, after so many decades of HIV programming, are built into our psyche. One doesn't need to talk about it once again. So that was the reason. Both Dr. Adiba and I were talking more about what's coming up new, because that was the question we were asked. And we did make the reference to multi-pronged prevention strategies. And one of them, and the main facet of any prevention, is always and will always remain the condom. Whether there will always be 100% free access to condoms, that's not for us to say. But condoms are always and have always been the mainstay. Everything is built upon them, both the research as well as the programming. Because even when we do our research, we have the arm that uses all existing methods of prevention, and we build the newer prevention method on top of that. So it will always remain. So there was no way we did not want to, or we wanted to say it's not required anymore.
Thanks,
That's
Dr. Sheila. Okay, condoms are here to stay. We need more condoms and we need better condoms. Now, two more questions. I know I had one up the back here, and the two of you together, perhaps.
I'm Dr. Alex, basically an epidemiologist from SRM University, Chennai. Recently, we happened to be RISE partners for evaluating the TA project. So I would like to hear from our neighbors, what is the, that is one of the ideal or best practice we are having, TA project. So what are the learnings from the neighboring countries which can further strengthen this? Thank you.
You might need to explain the,
Targeted interventions. Targeted interventions.
Yeah, this is Lavkesh Arora from South Africa. So one of the highest prevalence of HIV in the country. My question is that India being a very low prevalence from the disease perspective, what approaches are we using in terms of targeting, mobilizing the resources for the screening and testing of the disease? So just want to understand the approach.
Who wants to take... okay.
Thank you. I was actually anticipating that I'll be bombarded with questions, and thank you, because these are some of the points which I missed out in my remark earlier. Well, when we are talking about mobilizing resources, and we are talking about, testing, screening, yeah. So I'll tell you what we are doing in the last 3 years. So we have started a few special campaigns. One campaign is called Integrated Health Campaign. So we identify, is that a timer? Okay, thank you. So Integrated Health Campaign, what happens, we identify districts or geographic areas where we believe that the prevalence is high or the burden is high, the numbers are high or the prevalence is high. So in that, we try to pull in all resources. We pull in resources for IEC before we go on for doing a camp. We do enough IEC in that area so that we mobilize more people who come forward for screening. Now, what are we screening? We are screening along with HIV. We're going to screen for TB. We're going to screen for we have been doing this since last 3 years. Syphilis, hepatitis B, hepatitis C, along with HIV and TB, I said. Okay, so what we came to know is you cannot just call someone, please come, I have a camp, I'm doing HIV screening. So hardly anyone comes because we understand that it's a stigma discrimination which still prevails despite all the efforts that we are making. So when we tried to expand the screening to other diseases, so the footfall was really, really good. And in some areas, I like to name a few of the districts like Namsai district in Arunachal, Nagaon district in Assam. So what they found out was in these camps, they could detect as high as around 20% HIV among those who came for screening for other diseases as well. So the other special campaign that we did was, we call it ISHT campaign, Integrated Campaign for Syphilis, Hepatitis, TB, again. So here also this was done among the prison and other close-sitting inmates. And here also in some pockets we did find the prevalence of HIV because our focus was also on HIV and syphilis. So we had resources from the other programs coming in. We shared data with them. And of course, after screening, taking the patient for a confirmatory diagnosis as well as linking them to treatment was the other thing that we did. Other than these two, so the other campaigns, I won't rather say it's a campaign, but it is a programmatic activity which is dual test. So we have dual test kits which are procured under National AIDS Control Program. We also have these dual test kits procured under the NHM Maternal Health Program. And here the dual kits screen for HIV as well as syphilis. So these we have ensured that we make available everywhere. So screening, again, when we talk about screening, are we screening the right people? that's always the first thing government thinks about, because we just randomly cannot screen everyone. We have prevalence, say, around 0.2% only. But we are estimating that we have 2.5 million people living with HIV in the country. Though we have reached around 2.1 million right now through our testing, but definitely we have a long way to go. So this dual testing, and for every antenatal case, we ensure that dual testing is the screening method at the first step. So other than this, to increase screening more, in some districts where we have high prevalence, in especially some of the northeastern states, there are some other things have been piloted, like ensuring through OPD screening with partner agencies. We have also tried to demonstrate that model. We are also ensuring that every person who has tuberculosis is screened for HIV, and vice versa, of course. And now, going forward, we have started this HIV NCD collaborative framework. It is under pilot in 22 ART centers of 11 states. And I'm sure that is also going to give us way forward on how to operationalize and link the various health programs in the country. So I think these are some of the ways in which we are screening. Thank you.
Thanks, Dr. Chinmoy. I think there was one more question, which was, yes, did you want to? Yep, great. Professor Adiba will take a shot at that.
Yeah, I'll take a shot at that. I think it's important to go back to the I've been in the HIV world for quite some time, and I want to take you back to the old mantra of know your epidemic, know your response, which we don't hear that much these days. And using Malaysia as an example, back in the early or mid-90s, for quite some time, the epidemic was concentrated amongst people who inject drugs, and we implemented the harm reduction program, and that has successfully reversed that epidemic. But as you saw, the data that David shared at the very beginning, we're now seeing an increase in young men who have sex with men. Now, we believe that part of that driver is also substance use, particularly chemsex. So the old method of outreach, using, with outreach going out to traditional pots and geographic locations, and a slightly different population of, the people who use drugs need to be changed. The drug trend has changed. The drug using population has changed. So we ourselves need to adapt. And I think this is where technology comes in, both as an enabler of drug use and the networks, as well as reaching out to those people. So knowing your epidemic and knowing how to respond appropriately remains, I think, the framework in how we should work.
Thank you. Okay, 2 more questions, that's all. So one here and one over there.
Hi, good afternoon, everyone. My name is Amit, and I'm from Unite. And thank you, welcome, ma'am, for supporting the community voice. I'm also living with HIV. I'm taking my treatment from past 14 years. I have not much about pointing anything. I just have a two, three concern. First is about CBO. I was part of a CBO. I have supported formation of many CBOs at the ground level. But now I'm receiving the concern of community member that what is the future of this CBO. That is my first concern. Second is CLM that we have seen. That is the best concept I have ever seen, and I was a part of that CLM. Earlier we have done a very good thinking, but due to some funding constraint or recent donor crunch, so we have also lost this thing. So what is the next plan of NACO? How they are going to take this on under their funding, sorry. And the third thing is, because we are good that we have mostly from our domestic funding. We are not damaged that much that other countries has, but communities somehow has got impacted of this other funds. So how NACO is going to support the communities? Third thing is, ma'am, stigma is also there. I belongs to Uttarakhand, okay, and we are still receiving stigma cases a lot. But the concern is they are not getting reported. Even it's my fault as also being a community. We are not able to get the cases reported on the system. Many people are still facing stigma at the health facility level, at a different level, okay? And when we talk about the reporting of that stigma, they are not getting reported. So how NACO is it like going to take this? Thank you.
Okay, I mean, I'm going to intervene and play the chair role there and just invite Chinmoy to just address one part of that question. And you are welcome to choose one part, but I'm sure the two of you have many opportunities to talk about the other parts of the question, but maybe just one part of the question, okay?
I can touch
Do
on
it
both
now,
in
and
one
then we'll go
sentence,
to
and
the-
that is that we are having the NSCP phase 6. The consultative process is going on. So I hope that in the next phase, we do ensure that we have enough funds for the civil society organizations and CBOs, but I can't really promise right now. So it is a long process that will take. And regarding stigma discrimination, I will urge perhaps everyone in the room that we have ombudsmen identified in every state. We have, like every organization which is called an establishment should have a complaints officer. That is a mandate under the HIV/AIDS Prevention and Control Act. I don't know why that mechanism is not being used in Uttarakhand. As you mentioned that stigma is still prevalent. Please make sure that the ombudsmen are aware about any of the persons who are discriminated or facing stigma. Okay, thank you.
Okay, and our last question at the back.
Thank you so much. So my name is Shweta, I'm an independent consultant, but having worked for long years across both SRH and, HIV/AIDS, I have a question from my perspective, from my experience, given the rising infection among the young and the adolescents. And, the perception is, because I've worked in SRH and you just mentioned about integration and condom use, is that the young perception, with relation to condom use is only about not getting pregnant. They do not associate the risk of either HIV or STI to the use of condom, and because we get the over-the-counter pill so easily without any prescription, I guess it's also adding to the whole, risky behavior, because that's the only focus, that we don't want to get pregnant. But so I have counseled so many of young adolescents talking about HIV, because I wore that hat previously and, have been wearing it intermittently, about it's not just about getting pregnant, but it's also about HIV, STIs, and especially in educational facilities, because we're talking about setting up access of young students we know to SRH services. And that's, what I wanted to bring to the notice of the table, because we're talking about rising incidence amongst young people. Thank you.
Thank you, Shweta. I think that's a very, very important point that you have made. The data from surveillance also shows that probably the most vulnerable are the young girls who have gotten pregnant below the age of 19. Every year we get a new crop or a new generation of children who are growing into adulthood. If we look at it, Gen Z, the youngest of them are going to be 13 this year. Okay, so they are supposed to be less risk takers than the millennial generation, but we still need to talk. And yes, that's why we must thank our Condom Mitra there for bringing it up in here. So our prevention messaging, probably there's been a bit of an intervention fatigue with everybody. The generation that now needs to do the interventions has to be also closer to the generation that needs the intervention. So we need more younger people who come in and talk about HIV. But then what's happened is HIV has lost its glamour. And so the scientists, the technologists, the the people who work with societies and communities are no longer seeing that as a major problem. But we must recognize that in the next iteration of NACP, we have to go back to the adolescent and focus on them.
Good point. Yep. Yeah. Thank you. Okay, now I've had my arm twisted for just one last question, which I will allow, and then we're going to sum up and close.
Thank you, David. Ma'am, my question is to Ms. Varapon. Apologies if I've mispronounced your name. Ma'am, you spoke about HIV and UHC. So can you talk about your experience of implementing it in Thailand, especially given the key population and S&D issues that we have around it? How do we navigate that? Stigma and discrimination and key population and vulnerable populations, if HIV is also to go towards the UHC route.
And thank you for your question. And for Thailand, because all people cover under the universal health coverage, so HIV individual can access to care, and we use the the anonymous data. So we have the data system with anonymous. No one know who you are, so everyone can access to care and use like a anonymous number for them. That is our system. Another one, I have to respond about the condom use and not a little bit because sorry that we observe that when Thailand provide PrEP, pre-exposure prevention, we observe that the condom use is lower in body worse because so you how to say they get provide the PrEP, so a condom is no need, something like that. So we have to convince about condom use along with the PrEP. That is observed in our system on monitoring about that. Another one is about the condom use is about the finance, domestic finance. I convince you to move forward universal health coverage because if everyone can access, I think like a domestic finance will go to the HIV person, and also the for the civil society. We in Thailand we have the matching fund between central government and local government to take care of the people in the area. So I think this is more can strengthen the system to provide care for everyone in the area. That I answer your question in the first, right? Thank you.
Thank you, Kunwaran. And I'm also going to allow Adiba just to come back on the condom issue just one last time before we close and before the bells go off.
Okay, I must declare a conflict of interest because I am chair of a company from Malaysia called Carex Berhad, which is the world's largest condom maker. So I'm going to go home to Malaysia very happy to tell the CEO and the family of the Carex company that condoms are alive and well, despite lenacapavir and other innovations in HIV prevention and treatment. Thank you very much.
Thank you, Adiba. Okay, look, thanks everybody. And look, my concluding remarks are that this is clearly not over as a conversation. I think both regionally and here in India, over the coming months, we have plenty of time to reconvene and keep on discussing a number of issues. I've taken down just 3 quick takeaways from the panel, and I've turned them into a little bit of UN speak, so forgive me for that. I see that we need to invest in relevant and innovative key population prevention services, including community-led approaches that offer people a variety of prevention options. I see that we need to ensure that community leadership is fully integrated, resourced, and continues as a central pillar of the HIV response moving forward. And I see that we need to enhance sustainability, pairing policy and programmatic priorities with accelerated domestic resource mobilization in countries unlike India that are still catching up in terms of their domestic resources,
but also including from the private sector and really maintaining critical external financing where possible and where needed. So look, I want to thank everyone here. I think stay tuned. This is just the start of the conversation. We need the dialogue required to shape the next global age strategy. We need your voices. We need those voices to be heard, and there'll be a number of regional and national opportunities coming up in the next 4 to 5 months. Thanks, everybody. Now, could we just also have the panel for a quick photo, but also we'd like to give you just a little token of appreciation as well.
Yes. Good afternoon, everyone. My name is Karthik. I'm the regional advisor for digital health in WHO. Before we get started, what I wanted to do is, just in interest of time, and to just set the stage, because there are going to be colleagues who are coming, who are going to join in. And we also have one colleague who is joining us virtually from Netherlands. The essential problem statement that we have is, as WHO, we certainly cannot do most of work on our own. So we are essentially looking at collaborators who can help us in digital health and AI. And in the region, that is the Southeast Asian Regional Office, for all these 11 countries, we don't have a single collaborating center for WHO in digital health and AI. Now, the journey of becoming a collaborating center can certainly be longer. It certainly takes at least 2 years to become a collaborating center. We've signed some kind of a project collaborating agreement with some of you. There are some that have shown interest and have submitted paperwork. And yes, WHO has a lot of paperwork. We are bureaucracies of 11 countries, so sometimes you'll have to be patient with us. We also have FENSA clearance, which is the framework for non-engagement of state actors. This is essentially a member state-driven organization, so member states essentially don't want us to work with anyone other than governments. And when we want to work with non-state actors, which means even government institutions, we have a framework of engagement. Now, in that framework of engagement, we certainly cannot engage with organizations that work with tobacco or have any affiliation with arms. So if there is anyone here, my only request is we certainly cannot engage with anyone who does tobacco trade or has received funding from tobacco or works actively. I certainly know that none of you are, but I have to share this as an important red flag with WHO.
As a research institution, we work with the tobacco board. Somebody else in the institute, somewhere in the institute, we do work with Indian Tobacco Board. That's a regulator.
That's a regulator. There's a regulator.
That's a regulator.
I'm talking of company, a tobacco company.
No, not company.
Yeah, perfect. Thank you.
Openly that we are working with the tobacco board.
Wonderful. Thank you. So what I want to do is I basically want to open this up. This is not going to be a regular meeting. This is essentially trying to create a network of such collaborating centers. We have some of the finest institutions of the country here. What we want to do is we want to kind of use this space to understand 3-4 things. First is, what does it take to become a collaborating center? So we have Professor Prabhakaran, who's running a WHO collaborating center, not for digital health, but for NCDs. So I will also ask him to share his experiences. We also have Professor Goul from a collaborating center in Netherlands. He's joining us virtually. We also have a prospective collaborating center from Indonesia. We have Professor Rachmani joining us. So what we want to do is we want to first listen from the experience of someone who's been running a collaborating center for a very long time. Again, it's not in the space of digital health, but we want to essentially learn. And so, Professor Goul, what we would want you to talk about is, how has this experience been of being a collaborating center? What are the challenges that you've had? How easy or how difficult it is to work with WHO? And I don't want to say that. I want you to share that. So we want you to essentially give us some insights, and then we will open it up to our academic institutions and partners from India and Indonesia. We also have from other countries, essentially to learn on how is this journey going to be. And then what we also want to open up is, what are areas where each of this prospective center, what areas they're going to work in digital health. So it is just a kickoff to create this network. So over to you, Professor Goul.
Professor Goul, can you hear us? Your microphone is muted. He's frozen, I think. So maybe, yeah, he's frozen, clearly. Everybody's.
Go down and unmute.
Go to participant. Go to participants. I think we have enough computer engineers here to get this right.
So, thank you.
Perfect. Great, we can hear you.
Perfect, perfect. So, thank you for inviting me. My name is Koen van Vol. I'm from the Netherlands, as you already said. I'm with the National Institute for Public Health and the Environment. I have a couple of slides that I would like to present, if that's okay.
Please go ahead.
I'm not sure if I can share. Oh, sharing is not turned on, it says. Then I will do just by informing you. So the National Institute for Public
We'll turn the
Health
sharing on. We should be able to turn it. Yeah. Give us a second.
So the National Institute for Public Health and the Environment is a government agency. We work under the
Dr. Van Gool, the
Ministry
sharing should have been turned on. You can try again.
Okay. Yes. And then in presentation mode. Yep. Does it show on the screen?
Yes.
So, RIVM, or the National Institute for Public Health and the Environment in the Netherlands, it's a government agency. We work under the Ministry of Health, but we work independently, scientifically independently. And actually, we host 10 WHO collaborating centers on a multitude of topics. We work in the field of pandemic preparedness. We work on in the field of environment, air quality, water quality, nutrition, food safety, but also in the realm of the international classifications of WHO, and that's where my direct involvement is. So the network, the Family of International Classifications network, is actually one of the oldest networks within WHO. It runs since 1970, approximately, and WHO has organized a network of collaborating centers to work together on the implementation of the WHO health classifications, and also to have them advise on the proper use of the classifications, to do the maintenance of the classifications and the updating. And it's a worldwide network. It's spread all over the world. Some areas in Africa that lack to date still a collaborating center, but other than that, it's a fairly widespread network of collaborating centers working together with WHO. Now, within that WHO Family of International Classifications network, there are sub-committees and sub-reference groups to divide the work on the classifications. And it's to the benefit of each collaborating center to engage in the different committees and the reference groups, because that's a good way, a great way to learn from each other and to collaborate on shared goals. And that's exactly what WHO wants to achieve. They want to move away from bilateral relations with institutes or collaborating centers, and they want to engage into multilateral networks where you have shared goals and you have you work together to achieve those goals, not just in one-on-one relations, but in a network. And WHO, in assigning collaborating centers, always tries to achieve this goal, to establish multilateral networks. So for me, it's a no-brainer. It's a clear win-win situation. By becoming a WHO collaborating center, WHO gains access to the top centers worldwide and to institutional capacity. The organization, WHO, is able to exercise leadership in shaping the international health agenda. And of course, for the center, it creates enhanced visibility and recognition by national authorities, and it offers opportunities to mobilize resources from funding partners. So that being said, I think becoming a WHO collaborating center may be a bit of an administrative process, but the wins, the advantages are very, very worthwhile. And that's all I had to say at this point. Thank you.
Dr. Gul, it must be pretty in the afternoon for you. So what I'll do is I'll request our academic institutions and our partners, if it's okay with you, to ask a set of questions that they have for you, and then we'll probably let you go because I know you've got other important things to do. So friends, colleagues, if you have any questions that you have for Dr. Gul, who's been running a collaborating center for quite some time, any questions? Dr. Ravi?
One question from my side. Dr. Gul, I really appreciate the network that you showed. Rather than just a hub and spoke, it's like now multiple connections. But connections between centers, do they have to be routed via the WHO, or do they form separately on their own and it's information?
Well, that's a very good question. They do not have to go through WHO. For example, our collaborations with the German collaborating center have been very good, long-standing relations, and also with the French collaborating center on the classifications. We engage in some of the same reference groups and committees, and we also have contacts without being in the HUFIC network setting. So of course, the network setting helps, but it's not exclusively for collaborating.
Thank you very much.
Other questions?
May I ask questions?
Yes, please, Dr. Achmani, please go ahead, please.
I'm interested about the committee and reference group in the collaborating centers. Can you explain more about that? Because I'm new in this area. Thank you.
Thank you for your question. So this specific network, the WHO Family of International Classifications Network, has the goal of implementing and using the WHO reference classifications, the health classifications. And the work to achieve that goal is so big, so multifaceted, that they have divided the work into sub-tasks, so to say. And that's when the reference groups and the committees come into play. So the committees, they typically deal with cross-cutting topics, and the reference groups typically work on keeping the different classifications up to date. They are more content related.
Any questions? Okay, now they're all being shy to ask this question, but I want to ask this question on behalf of all of them. Dr. Gul, how do you sustain in terms of funding from WHO as a WHO collaborating center? And especially, I know it's been a long journey for you, but when you become a collaborating center, if you could walk through how those first 2 years are. Essentially, when we see throughout the journey of collaborating centers, especially in LMIC countries, initially there's a lot of enthusiasm, but after 2 years, we certainly see a large number of them fading off and not becoming eligible to become a collaborating center. So what is some guidance that you have, or what is it that you've been able to learn, because you've been a part of a bigger network? If you could share one on what are the financial incentives, is there any funding that comes from WHO once you become a collaborating center, and how is those 2 years journey like based on what you've seen?
Thank you. So it is possible to receive funding from WHO, although it is not very typical. It will involve some agreed program of work, so specific assignments. But the easiest way to be funded for the work for WHO is through your own government. That's the easiest way. And that's how we have approached it as well. Our Ministry of Health thinks it's very important to have a collaborating center specifically on this topic. So they fund this collaborating center that I'm chairing. It is also possible that you receive funding for parts of your work through donors. That's also very, very well possible. But the most important thing is to be visible within your network, within your communications with the ministry, for donors. You have to be vocal. You have to be. You have to share what you're doing. You have to be visible. That's the most important thing, and you have to have some persistence.
Any other questions, Dr. Ajay? Yes. Okay. Yes, Dr. Neha.
What are the metrics?
Could you speak into the mic?
Hi, Dr. Goul. This is Neha Verma from IntelliHealth. What are the metrics of success that you look for in the next 2 years to be recognized as a collaborating center? And what are certain failure modes we should avoid?
Ooh, that's a very good question. I don't think it can be expressed in terms of metrics, because, as I said, our Ministry of Health thinks it's very important to have this collaborating center on the classifications, and we do have, so we have terms of reference with WHO, of course, but we also have terms of reference with our Ministry of Health, and as long as we comply with those terms of reference, they will continue the assignment of being a collaborating center with WHO. And those terms of reference, they can be very ambitious or less ambitious. That's a matter of negotiations between you and your ministry or assigning entity, so to say. But for us, it's keeping the WHO classifications up to date and available in Dutch, and making them available online. That's basically our terms of reference with our Ministry of Health.
Awesome, thank you. Now we also have Professor Prabhakaran, who's essentially been running a collaborating center in NCDs, and he certainly does not get funding from Ministry of Health to become a collaborating center. So if you could walk through what that journey has been for you, that would be very helpful.
Right. Thank you for asking me. I think this was, I was just put on the spot. I was asked to come just 5 minutes before. So, it goes. Okay. So we have been a WHO collaborating center from 2012 onwards. This is our third, because it's a 5-year cycle. We are in the fifth 5-year cycle. Now, when we started out initially, it was broad-based and it was a little non-specific. And we were designated, I mean, the designation remains the same. We were designated as a WHO collaborating center for cardiometabolic disease, capacity building, research and implementation in Southeast Asia region. That's the title. And as part of that, we were mandated to assist WHO CRO then WHO headquarters and WHO India in that order, or WHO India before WHO headquarters, in terms of whatever the activities of WHO was within the country and within the region. And we have been assisting WHO in many ways in terms of organizing workshops in collaboration with the government. For example, we have done 2 or 3 consultations with the WHO for the National Program for Prevention of Cardiovascular Disease, Diabetes and Cancer, in the so-called NCPDS program, which is now subsumed under the National Program for NCDs. And we have done 2 or 3 consultations, and then we have done other activities. For example, we have been very active in digital health, and they wanted us to digitize the PEN package for 2 countries, Maldives and Timor-Leste. Timor-Leste didn't work out, but Maldives, we actually did the digitization of the PEN package, and that's being used. In fact, we're one of the first ones to digitize in the iOS method, because most of them were Android earlier. So we did both on Android and iOS. And in the last iteration, I think we have tough taskmasters. One is Dr. Karthik, of course, now, and before that, Dr. Cherian Varghese. They put in very specific clauses and also wanted us to put in time. How much is the time commitment of the people from WHO? So, including me and 2 other or 3 other people, we contribute almost 10% of our time, but without any payment. So you should brace for that. You don't get anything paid for your time, but you have to work pro bono. So it's a fun thing. It's very prestigious to have the WHO Collaborating Center. It opens doors at many levels, and it's useful for your organization for branding purposes, as well as you do some good work. Now, what is the work in this? I don't know how to define this 5-year period. In this period, we are supposed to do a systematic review of all the digital health work that's going on in the Southeast Asia region, and we are doing that. Second is identify the gaps and challenges, and third is actually to give a kind of roadmap in terms of how to implement digital health in these in the Southeast Asia region. So we are at the 2nd year, and we have done the systematic. It's almost ready. We have just collected all the data, and then it's in the writing up process. And we do it in consultation with WHO. Dr. Nalika Gunawardhana from CRO is our nodal officer, and we consulted Dr. Karthik because he is the regional advisor for digital health. And there have been specific advice given in terms of what is to be done. So many times the question is asked, do you get, a lot of people ask me, how much is the funding from WHO? Actually, it is minus, because you're putting in funding to do the WHO work. And so if you're expecting funding, I think you should not apply. But the other thing is, sometimes specific work, you can have what is called as an APW with WHO, and they provide funds for doing meetings, doing programs. Sometimes there are individual APWs in terms of consultations where you provide a draft consultation or framework for the work that they would want to do. So those are the kind of mechanisms that are available. And sometimes you can get large grants, but that's extremely rare. And large grants means up to $500,000, not more than that. But those are extremely rare. But I also hope, I think there's a WHO Foundation now, and I think that's one source which we can tap. And I think WHO should consider to prioritizing WHO collaborating centers in terms of access to those grants. So I'll stop here. If there are any questions, I'll answer.
No, thank you so much, Dr. Prabhakaran. I mean, this is precisely the reason why we have collaborating centers, right? If you weren't a collaborating center, I wouldn't have asked you in 5 minutes to come over. So thank you so much for your kindness. So here we have a very eclectic group. Let me place this way. So we have at least 3 of those centers with whom we've already signed a project collaborating agreement. So we have 3 front runners, IntelliHealth, Ashoka, and ThoughtWorks. And then we have some of them who've already done the paperwork and who have applied, and they're in the process. And then there are some who are exploring with us. So we have 3 different groups. So what I want to do is, yes.
I just wanted to add one more thing. Actually, I forgot to mention, the government of India has a major role to play, because once the WHO thinks that you are likely to be a center, it is sent to the government of India and they have to approve it. Many times they don't reply, and it's a good thing, because if they don't reply, I think by a certain time, then you're deemed to become a center. So you hope they don't reply.
Well, I will only smile because I'm on both the ends. So what I will do is I'll first put Dr. Neha on the spot, and essentially, if you can briefly talk about how has the journey been for you in terms of getting this project agreement, collaborating agreement signed off. How much time did it take? How useful, how painful it has been, and please feel free because all the pain will be because of me only. So I want you to be upfront about that. And then if you can talk about your area in which you've signed the project collaborating agreement, what are the areas that you want to look into, and if you can briefly talk about your work with us, that'll be wonderful.
So I got a random email in my inbox from Dr. Karthik, which I was a little suspicious because it felt like a Nigerian prince offering $1 million. It's like, no way, how is this happening? But I will say that the process was actually rather painless. It is one of the fastest agreements we have ever gotten into with WHO. I think end to end, it took 6 months, 9 months at the max from when we started talking to when we had it signed. It started off by discussion on what are the competencies that in telehealth has that we could bring to the table, what is it that WHO CRO office needs, and then drafting a TOR accordingly. And I think we went back and forth on the TOR, but not too much, maybe just 2-3 rounds, and Shivani was a big part in that process. And a part of the TOR is how do we build capacity of ministries and WHO offices in the CRO region to meaningfully implement telemedicine. So we thought through a bunch of things in the TOR. One was guidance documents that we could create, peer-reviewed literature that we could publish from our experiences with eSanjeevani, a webinar series that we are now doing, 1 webinar every month to disseminate knowledge. 2 webinars have already happened. The 3rd is next week. And those webinars bring Ministry of Health officials from different countries as well as WHO CRO office. But it's not just limited to CRO region. We are also highlighting countries broadly in other regions as well. And and then we had to go through FENSA clearance after the TOR. And once everything was signed, and then we did a very helpful kickoff meeting in Delhi, where we very clearly put like a goals sheet and milestones that we wanted to hit, like X number of publications, Y number of webinars. So put some, milestones and metrics to it. And there was also a process of getting all the comms in order, when to use the logo, when not to, how to, and all of that our team was trained in. And then we started the webinars and started the work on the collaborating center. Aside from the webinars, we've also done things like support the Ministry of Health of Indonesia in designing a telemedicine program. So it's not just being so far, just doing the project collaboration agreement has already opened a lot of doors for us, which are turning into projects which we carefully document to put as a supporting evidence to be a collaborating center later.
Thank you, Dr. Neha. Now I'll ask Anurag, because Anurag has been, there's an allegation that's going on with both of us that we're essentially spouses in meetings. So Anurag, you'll have to talk a little bit more, because there's also colleagues in WHO who feel I spend more time in Ashoka than in WHO. So you'll have to tell us how is this collaboration, what time did it take, and what is your journey been with us? And don't tell us good things. Tell us how it could be better.
So it's a very interesting journey. So we're introduced partly through Rizwan, some of the connections. And the very first day, I think Karthik was supposed to visit Ashoka. I realized he does not come at the time he's supposed to. He comes an hour earlier. So he can make up his mind after that, before that, 1 hour before people are prepared for him to see what the ground reality is and whether he even wants to have that meeting at the end of 1 hour. So in any case, we found that well before we started the meeting, he'd already done rounds of Ashoka, checked out a variety of things, and found that whatever good or bad is said about us is probably true. So from that point onward became a question of what could Ashoka, as a place full of younger people, interested in digital health. We already had the Koita Center for Digital Health at Ashoka placed over there, and also interested in biosciences at the cutting edge, including interfaces with wearables, computer science. Professor Subhashish Banerjee, to the left of me, is the head of the Department of Computer Science. What could we do that wasn't already being done by other people? One of the other things going in our favor is that, continuing from a Lancet commission between Ilona Kick-Bush, me, and other people that we had worked on for growing up in a digital world, we have had a digital transformation labs with a branch at Ashoka focused on young people and their vision of health. And so what we came to, and this took some degree of discussion, was there are better places than us for tech in the IITs. There are better places than us for many other things in real health delivery. But young people's version of what is important to them in health, with an ecosystem that contains a center for well-being, multiple other centers focused on psychology, other issues, and centers focused on digitization in society, what we could look at was a more comprehensive digital first health systems that might target a younger population growing up in this world. And this actually went back and forth, and Raita over there was collaborating a lot with Shivani in getting the paperwork right. And the FENSA process also takes time. Again, we are not government. Not being government is not in itself a disqualification, but it means you have to jump through hoops and bars and stuff. And questions that we fail to answer well in the document, if any, then have to be answered from the WHO side as they pass the papers forward. So I think a great part about the interaction was it was a co-developed project, really looking at what can we add that might be unique to our circumstances. And very similarly, as that first MOU has been signed, we have furthered the conversation even more towards responsible AI. And I'll just mention this because it's a continuation. And again, the reason to do that is one, the person sitting on my left, who at some point I'm sure is going to have a comment on how good AI really can be, current generation. But the point being, Ashoka is a place where the Department of Computer Science and the Department of Philosophy are already holding lectures on, ethics of AI in this age. And again, in a futuristic vision, even if AI were to become as capable as a human or more, what we would want AI to do becomes less of a technical question, more of a philosophical question. And at some point, a liberal arts university that contains philosophy, computer science, application all together may be a good place to at least start a discussion. This one is more another discussion with IntelliHealth. So we are trying to create, for example, here a set of lecture series again trying to invite some of the best minds in the world in a very similar format to what worked from you. So in a sense, that horizontal networking of potential centers is already starting to happen. Why reinvent the wheel? And then we brought in some good people. We are trying positions to work with us. It was very clear from the beginning that the reason to do this cannot be money. The reason to do this has to be impact. And not just talking about impact, actually delivering some measurable impact on which hard timelines would be set. We are early, so we haven't yet had opportunity to miss a timeline yet. So I don't know what Karthik is like when that happens. But I guess based on his track record as a civil services officer, I don't want to miss that timeline. So by and large, that's roughly where we are. Raita, anything you want to add? It took about 3 to 6 months? Around 4 months. So it was a very easy process in that sense. And again, I'm told a lot of it depends on the person sitting on the other side and how much work they are willing to undertake on your behalf while answering a minor question, as opposed to sending the entire package back to you for correcting it. So I think it's a very painless experience, but I also think it has a lot to do with Karthik here. So over from my side.
He's only been kind. Now move over to ThoughtWorks. Now ThoughtWorks again is a private organization and they have a project collaborating agreement with us. So Akhil, if you could talk about how your journey has been, which has been slightly more different than IntelliHealth and Ashoka, it'll be wonderful. And please also introduce about your work.
So our journey, I'll echo the thoughts, right? Our journey has also not been very difficult. It has been rather seamless, right? It took us around, I think 6 months to get the FENSA clearance and all the paperwork in place. Of course, there were a couple of back and forth because, the legal departments right, in both the organizations decided to make some changes. So that took a little bit of time, but it wasn't very difficult. It was rather easy. And I think rather from, you know, it was on our part that we had to convince our legal department, but you know, on WHO's part, it was rather smooth. Now, talking about what we generally do, we are a for-profit organization, multinational, you know, IT services company. But what are we doing here? Basically, we have a mandate for impact in, you know, for social impact, basically, and health is one of the biggest, you know, areas where we work in terms of social impact, and digital health specifically because we are, you know, a technology company. So this feels like home, right? So digital health is a space where we have been working for, I think, more than 1.5 decades, right? Having said that, we are a 30-year-old company, right? And we have always been, you know, interested in health. So it started with, you know, with BAMNI, which is one of the open source hospital information systems available. You know, it is a DPG. It is also one of the systems, the first open source systems to be ABDM compliant, right? So, and we are, you know, present in more than 50 countries, around 600 plus implementations that we know, because it's an open source system, right? We assess, you know, by the number of downloads we get on our website, that it could be much more, but that's the official number that we have, right? So, you know, collaborating with WHO, you know, we have been working on, you know, like promoting DPGs, right? So WHO has opened doors for us to, you know, to present, like, you know, Dr. Neha said, to do webinars and, you know, make other country offices aware of BAMNI. So we have been working on that, but we are very early in our journey, right? So we have done only one webinar with Mauritius for now. Yeah, we are yet to see how it pans out for us, but I hope it's going to be good.
Thank you, Akhil. Now we'll move over to those institutions that have applied, that have essentially submitted paperwork, and they are essentially in the process. I'll start first with Professor Ranjit from IIT Bombay. If you could talk about this co-development process, if you could also talk about what is the work that you would like to do with WHO, that'll be interesting. Thank you.
Yeah, thanks, Karthik. Yeah, so I'm from the Koita Center for Digital Health at IIT Bombay. We are kind of, the center is about 3 years old, and so something that we have been discussing with Dr. Karthik, that we want to be a collaborating center, and then the discussion has been, so IIT being a place for education, something that we hope to do is to develop a framework for long-term digital health competency in India, and the requirement, what are the kind of competency that will be required at different levels, from doctors to all the different levels. And I'm yet to understand the full challenge of the situation, but the discussions we had was, of course, as far as I understand, the digital health competency for India is not even very well defined in all areas. So we also hope to think about it and work through it and define some in all the areas, and some of them could be quite unique to India, and then develop the appropriate competency in collaborating with all the groups, all the interest groups, and all the related government as well as medical council for education and others. So that's one aspect that we are hoping to collaborate. And of course, we'll also have the seminar series, that the webinar series that we are also hoping to have, something which we are proposing to focus on some kind of translation in the following sense, that, so since we are being a digital health department, biomedical informatics has a lot of discoveries in the last several years, and many of them have been translated in the context of the clinical setup. So we are going to have a set of webinars on going from a kind of a pure research to something that is getting translated to the clinical side, and how the journey has been and so on and so forth. So that's something that we are hoping to have.
Thank you. Can we then move to Dr. Ajay, because essentially you've submitted your entire paperwork and we've been collaborating on that. If you could talk briefly about how has this process been and what are areas that you would like to collaborate with WHO?
Yeah, I think we've been speaking for a few months now, and to be very honest, I don't know how much of it's been a delightfully easy process so far, because and I don't know how much of that is the individual we're talking to and how much of it is the institution, but it's because we've started collaborating, I think, in real terms way before any of this paperwork has happened. We've started working on a scientific publication on a DPG that we've been developing and co-developing with the government on the health claims exchange. But what we'd like to do, and we, on our own as SWAST, we have had conversations with organizations in other countries, but I think it'll be great to have WHO, because we develop open source tools and open source infrastructure. And for us, it is a great way to actually reach more places than India, and it is a lot more meaningful when it goes from the WHO rather than going from us. So we're very, very excited to not just continue to develop, but also to scale the impact. And for us, a lot of it is, how do you really link DPGs to health outcomes, right? I think we've talked a lot about all kinds of different DPGs, and for us what's important is, how do you really link it to health outcomes, which is either access or access to financing, or its actual health outcomes, or it is really the responsiveness of the health system to the needs of the community. And to me, that is the holy grail that we are going after, right? So all of this tech ultimately has to result in real impact in that way. And that's what we're hoping that the WHO will be wind under our wings. Yeah.
Thank you. Now over to Raghu. Raghu, I would want you to also talk a little bit about the work that you want to collaborate with WHO, and your entire paperwork is there with us. So again, if you could reiterate on how painful the process has been, what did it take for you to think about WHO? You have other potential partners as well. So why WHO?
I'll not go into why WHO again. I think folks have said that. I will also say a fair amount of why WHO was also why Karthik. Right? Karthik came and signed us up, and basically, right? Right. So now, how easy? Quite honestly, we we are an entity created to develop applications and support development of applications of AI. Right. So in that sense, we are a bunch of doers. If you look at our team, we are engineers, we are designers, we are folks, entrepreneurs. Yes, we think deeply and work with organizations in developing those applications, and we have a way of doing that. But until, quite honestly, you came along and nudged us, we didn't seriously think about, do people want to understand the methodology of this? Should we be documenting the thought process behind this? Do people care? So I think the process made us think more deeply about this, right? And the realization is that, yeah, actually there is, yes, we talk about certain principles of how we do our work. We talk about steps of doing that. And on reflection, realized that actually working as a WHO collaborating center is going to actually force and enforce certain discipline in documenting this, improving this, and of course, disseminating it, right? And it all goes back to, in fact, I don't know what the right term for our WHO collaborating center should be, right? We think of ourselves as folks on how to build AI-based solutions responsibly, right? And I think there's a lot to be said in the how that often gets lost in the what. Sometimes we do address the why well enough, but I think the how is really where the missing bits is. And in the conversations with you, we realize that that's the bit we should bring forward more strongly.
Wonderful, thank you. Now over to Professor Sutapa, because this is another institution that has submitted all the paperwork. So Professor Sutapa, if you could also talk about your experience, because you've certainly taken a lot of time. We've also had to rework, spend a lot of time. So if you could talk about it as openly as you can, and also introduce your institution and the work that you want to work with us.
So thank you, Dr. Karthik. I am Dr. Shutapa Nyogi. I am the director of IHMR Delhi. IHMR stands for International Institute of Health Management Research. So frankly speaking, our communication started almost a year ago, I think in last May 2024, when again, as Neha said, that we suddenly got an email saying that if you are interested in becoming a collaborating center, please write to us. Then that time we had a couple of meetings also with WHO to understand what is their requirement from our side. And also this was followed by several rounds of meetings internally. We also had to ask our management board also whether we can actually go ahead with this or not. But then going by the requirements of WHO, it took us quite a while, so we literally went into hibernation. And then we suddenly got up in the month of February when I again met him in Bangkok. And since then, we have started working on an application. We were guided by Dr. Karthik and his team on how to fill up the application, because it's not a simple application like the way we do for any other project proposal. So the first time when we submitted our application, we were told that it's looking quite vague, and it has to be crystallized in a manner that in case WHO wants to evaluate our performance after 2 years or so, they should be able to do so. So then again, after several rounds of internal meetings, etc., we decided to focus our work on health system strengthening through digital health system, and the focus is going to be on primary health care. So this is what we have decided to do till now. So I think our application was submitted in February. Knowing that the incubation period may range from 4 to 9 months, we are hoping to hear something maybe after July. Thank you.
Thank you. Now let's go to Indonesia. Professor Rachmani is online. She's again someone who's been very patient with us. She's been very kind as well. So Professor Rachmani, if you could briefly talk about your institution, the areas of interest with, in areas of work that you want to work with us in digital health, and also briefly talk about the journey that it has taken for you. We've of course had a lot of to and fro, so if you could talk briefly about it, that will be wonderful.
Okay, thank you, Dr. Karthik. Can you hear my voice clear?
Yes, we can hear you. Please go ahead.
Okay, thank you. My name is Eni Rahmani. I'm from Faculty of Health Science, Universitas Janus Suwantoro, Indonesia. Actually, my journey applied for WHO is around maybe 1 year, same like before. Actually, I try to apply and make collaboration related focus in primary healthcare center. The first one is we apply that we want to build like a framework for digital health competency, especially in primary healthcare center. And the second, we want to doing mapping for the competency in primary healthcare staff, because in our experience in our institution, primary healthcare staff is usually have a low digital health competency, and also the adoption is also low. So after doing mapping, we have a plan that we like activities to building capacity for adoption of digital health in primary healthcare center. So I don't know, the paperwork is still in process, but after I in the meeting, I think as our activity is too much, maybe I will discuss more with Dr. Nora and also Dr. Karthik, because we have only 2 years, right? So maybe 3 TOR is too many activities. Maybe in the next meeting, I try to make simple or maybe like focus in one TOR. So maybe after 2 years, our institution can continue to do another plans like building capacity and another. I think that's that I can explain to all. Thank you.
Thank you so much, Dr. Achmani. Now over to Ravi. Ravi, we've again been talking for months now. So
I was just looking up. Our first interaction started in September.
Okay,
Yeah.
so not bad.
Not too bad.
Okay, so Ravi, I want you to briefly talk about of the first journey, and then also potential areas that you think we can collaborate at WHO. Sure.
Thanks. So I am Ravindran. I'm from IIT Madras, and so we have this interdisciplinary school of data science and AI. So under which we have multiple activities going on, and one of these is the Center for Responsible AI that I have. So so Raghu was talking about the how, what, why, and all that. In fact, we don't even know. The what is actually a question. So what is responsible AI itself is a big question, especially in the context of, the global south. Or I guess I was told by you or somebody from your team who told me I shouldn't call it global south, I should call it global majority. So
I love that better. Yes.
yeah. So so I think so the what does responsible AI mean for the global majority? That is something our center has been very involved in, and not just in the healthcare piece, but also looking at other sectors as well. And one of the things that we find is there's a lot of cross-cutting learning that could happen, and partnering with the WHO would give us a much broader reach than just the the few partners that we have, largely in the US and Canada and of course in India. A lot of people that we partner with in India, but we really like to reach out to Africa, and to other Asian countries where I think we need to take a fresh look at what is responsible AI, and particularly in the context of healthcare. And we had some discussions already on this. So that is one area we would like to work on. And the other thing is there are several groups within our school that have been looking at building both reliable but also affordable healthcare across the stack for deployment in India. And one area that we do a lot of work is in mother and child health. Right, so again, we work with multiple partners around the country, but that is another topic that we have been talking about in terms of collaborating. Again, working with WHO, we were very clearly told to us from day one, I guess, we shouldn't be expecting any funding from WHO, so we're not coming into it with that mindset at all, but more about the network, the partnership, and the reach, and the broader impact that we would have by working with WHO and the network of collaborating centers that will bring it to us. That's one of the reasons we're really looking to do this. And so some of you were saying that you are not government institutions, so that you had challenges. So we had one challenge because we were a government institution, because being a government, being an IIT, right? If the military wants to work with us, we cannot say no. Right? So that became a challenge in terms of drawing the boundaries and lines. I think we have a acceptable resolution to that now, and I'm not sure, Shivani, did we get our clearances, everything? Not yet. Okay, there you go. So, see, she knows better than us as to where things are, and that is why it's been so easy working
Right spot later, but thank you. So can we now move to Srinivasan from IIM Bangalore, because again with Srinivasan a very chance discovery. And now I also wanted to share this, Anurag. I haven't known any one of them before getting into my WHO position, because I've been away for about 10 years. I haven't known any of them personally, none of them from my the IAS network, because Swasth again came to Punjab after I left. So essentially we were in a transition. So all of them are as new as anyone else. So again, so therefore for me at WHO, creating this network itself has been a great learning experience. Over to you, Srinivasan.
Okay. So pretty much like that Nigerian prince, I got an email from Karthik. It was about Karthik, not about WHO when we started. Karthik wrote to me saying that I heard that you have created a center and maybe let's work together. So I started talking to Karthik as a potential co-author. I run a Center for Digital Public Goods. The center is as old as 13, 14 months as we speak. We are a management school, and in the management school, we have very little to do with creating anything. All of you create something. I heard everything. We build, we create, we do this, we do. As a management school, our philosophy has been to be able to study, evaluate, impact, and document what has been created. So therefore, our idea is to be able to shape creation, shape design, shape policy, rather than create anything. So therefore, the Center for Digital Public Goods is also about, there's so many DPGs that have been created, right from our Aadhaar to everything else. And therefore, let's look at understanding, documenting, evaluating, so that other people can maybe replicate, transplant, modify, adapt, re-implement somewhere else. Or 2.0, 3.0 of each of these, what's worked, what's not worked. So that's the center. So one fine morning, I receive a mail from Karthik saying that we want to talk, we want to collaborate. And then I started a couple of three or four meetings we've had in that collaboration thing. And then another Botswana queen, Shivani, writes to me saying that we are considering WHO CC. So I go to the internet, go figure out what is this WHO CC, and I find all medical schools. The first name I see is AIIMS and JIPMERS and medical schools, and like go back and say that, okay, what is this that we are going to do? One of the things that I also have at the IIM Bangalore is we have a Center for Public Policy, which is possibly as old as the institute itself. We are 53 years old. The Center for Public Policy has been there right in the beginning. And the Public Policy Center has been working on impacting policy. Their mandate has been policy impact, and they've been doing a lot of work on health policy. Right from the 70s, they've been working on health policy. So I went back to the Center for Public Policy and said that, okay, what is the health work that we have done? What is the WHO? There were two of our colleagues came back, oh, we do a lot of projects with WHO. We have enough this thing, and we've been doing a lot of work. I said, but what is this WHO CC? I don't know. I don't think we have ever evaluated going that path. Because apparently, in their minds, WHO CC was about people who were contribute to WHO's mission of creating something. The broader understanding was WHO as an organization does not create. They're collaborating with other institutes who would create something. We are not creating as an institute, therefore we don't think, we have never even considered that path. So, but when I spent a little more time, dug deep, figured out that, there's something possible that maybe there's an interest in WHO to not exactly create, but also to be able to evaluate. There's also monitoring, evaluation is also a significant part. And to me, our interest has always been that we will be focused on building or evaluating DPGs, digital public goods, digital public infrastructure, and all of this open source and all of that. As individuals, we have worked with a lot of corporations, IIMs, work with a lot of for-profit organizations. Our students do a lot of entrepreneurship. We have a wonderful entrepreneurship center where we have incubated a lot of healthcare startups. But on the larger purpose about what we are interested in the WHO network is to be able to evaluate, monitor, add value to people who are creating DPIs and DPGs, convert closed source networks to be able to make open networks. We have the wherewithals, we have the knowledge base. If there is somebody who's created a closed network application, make that open, we'll be able to help all that. So that's the larger research agenda. Even within the Center for DPG, I am the least engaged in health. I have my colleague Mayank. Mayank has recently joined us. Mayank, would you want to tell us about the proposal that we're looking at, the ABDM and all that? What work you have been doing and all of that? I don't think I'm doing any technical. I'm the convener of the center. I largely work on data markets for data, and I work on building platforms. He is the one who is likely to technically work on
please.
Health.
it's on kind of doing the impact study of ABDM. So ABDM, which has a lot of potential. We had several panels in the morning talking about the ABHA idea and its importance in building a longitudinal data and then giving continuity to the care. But has ABDM been successful? Do we even have a framework through which we can evaluate whether ABDM is successful or not? So that's the project we are hoping to do, that we come up with a framework to evaluate ABDM and then go and study its impact, and then can we come up with some suggestions and framework to make ABDM more useful in our setup when it has its implications in giving continuity to the care. That's a project we aim to do.
And possibly for some other countries who want to create something like ABDM, how do we start? Where are the readiness? What are the building blocks? What are the foundations for starting something like an ABDM? Or what can they reuse what they already have? So that's the larger interest of the program.
Wonderful. Thank you. Thank you, Srinivasan. Now, there are some whom trying to allure them into becoming. They've not even started. There is some initial luring that I'm doing. So on that side is Joy. So Joy, I want you to talk about your institution and see how because CMC essentially has a large number of collaborating centers. So if you could talk about one, what is the work that you've been doing, and two, what is your potential interest in becoming a collaborating center for digital health, and also talk a little bit about the areas that you would be interested in working with WHO.
Check. Thank you, Karthik, for this invitation to be here and part of this group. I'm a pathologist. I work in blood transfusion as my day job and spend some time moonlighting with health informatics. We've been trying to put a group together, so we have a cross-departmental group. We call ourselves Biomedical Informatics Unit, and I have one FTE on that. So we're a really young organization within a 125-year-old organization. So it's hard to move 125-year-old organizations, as some of you know, older organizations know. There are advantages of being old, and you can pull out all these sepia-tinted pictures. But when you come to making decisions and moving things, sometimes we are like government, no offense to that, but it is challenging, let's say. But we are working on it, and we've, in this last 2 years that we've been working virtually, we've engaged with several organizations, Dr. Ravi's group in Sirai, Art Park here, then some other technology institutions also, trying to build relationships that we will use to leverage our strength, which is we see a lot of patients, maybe around 10,000 patients every day, and about 4,000 beds. And we've been, sometimes I see it as an advantage, sometimes I see it as a legacy burden. We've been digital for some 40 or 50 years now. So we have a lot of data, but how good that data is and how ready we are, when we scratch those surfaces, we will know. Traditionally, we've just done thesis and research, which are very targeted based on that data. But when we look at large-scale data and how to extract it and to make it research-ready as large clinical data sets, that's something that we are looking to explore, and that's an area that we would like to work with. The other is training. We are always, we've looked at education as the first pillar of our 3 missions, other being service and research. So since we have a large cohort of people whom we train and send out, we want to be on the training front. Just makes so much sense. When you get people in young, you want to train them about digital health. We want to develop courses for them. We're working with a Gates-funded grant to understand what is the current level of knowledge and perception among healthcare workers, and we hope with that we will develop capacity building modules also. And the third thing is, given that we have this data and that we are at this intersection of where new products are coming in, we are really wanting to be at the place where we develop evaluation frameworks for these kind of products. Being a healthcare organization and this being completely different technology from what we are familiar with, we need new evaluation frameworks. We need to know what are the questions to ask beyond sensitivity and specificity and positive predictive value. And then to see, give feedback, one to the development side, and then for ourselves to see how often should we do this, what is the kind of data we need to do this, how do we simulate it in an environment that is really challenging on a day-to-day basis when you see large numbers of patients and you have operations to run? How do we bring these into systems without being too disruptive about it also? And like all legacy institutions, we have certain ways we do things. And so to convince all our friends to get on board and to move forwards is going to be a challenge. It's only, I think, 3 months since I met Karthik. So I think ours is the youngest relationship. And we hope that we will.
There is younger one as well.
Oh, okay, okay. Okay. So I'm optimistic. So certainly look forward to working together. I know that I just pinged one of our nursing colleagues. They have a center for midwifery and a collaborating center which is already functional. So perhaps some of the paperwork will be easier to get through once I talk to them also. Thank you, Karthik.
Thank you. And so to the best one now. So to Dr. Kritika, essentially AIMS has multiple World WHO collaborating centers. So, and we've not even had a conversation. So we're going to start the conversation here, right? So, and I asked Anurag very specifically to say that there need not be ones that I know. I mean, there could be some whom have not even reached out. So therefore, I wanted to, one, introduce yourself, introduce your center, and then also talk about how would you see, having heard all of them, on your center of excellence essentially becoming a WHO collaborating center.
So thank you. I think I'll have to begin with thanking you for having me here. It's very it's opening up my mind to listen to so many people and so many experiences. So I'm Kritika. I'm a radiologist by training. I am an associate professor of radiology in AIMS. And we have, like you said, this is a center that's not even formed. So it's really just leading an effort to set up a center of excellence for AI in health. And I'm a bit disappointed. I'm going to miss the Nigerian prince experience. So it's come up over here where we're actually discussing it. So part of I think what we are thinking of right now is where do we fit in, because I think the job begins all the way from starting to decide what is a good problem to solve. Starting to decide what parts of these problems can be solved by AI and what cannot be solved by AI. Deciding what are the other pieces that you need to fill in, because not everything is necessarily technological, and if you don't solve those non-technological parts, then you're failing by default. So just because you're a center of excellence in AI, you can't restrict yourself to just the AI pieces. And then going into some of the even tougher problems, which is like how do you source data which actually solves that particular problem and is representative enough to actually come out with a real solution, which I think is a very important and very challenging problem that we're going to face. And then how to make this data widely available to everybody so that you can get the best solutions out of it, and at the same time be compliant with all the standards that we're expected to be compliant with, not even starting to mention problems around data security. And then what is the best way of developing algorithms? And this is also a space which evolves so rapidly, so it's already outdated before it's actually available. So before you actually present something, you realize what you're presenting is actually very old. So how do you get to the right kind of models, right kind of AI to solve that particular problem? And then what's already been highlighted around how do you evaluate it, because a lab evaluation is so different from an on-ground evaluation. And then how do you continue to monitor this? How do you continue to keep it safe? And how do you, again, integrate into existing systems? Because again, if you're doing it in silos, you're actually never going to solve the real problem. So when you look at the MOHFW and what they already have in terms of digital platforms, how are you going to go and integrate into that and ensure that it actually reaches the last mile? So we're looking at this really end to end. And we'd be, I think to begin with, we'd also sort of be very happy to learn from your experience, because you come with such a large network. And I think the first step is really going to be even learning from all that you have seen around the world, even just learning from, we're trying to get 25 institutions together. It's a consortium of 25 institutions. So how do you ensure that everybody feels empowered enough to actually contribute and feel like an equal partner, each of these organizations, and not restricted to these 25. We're going to need a lot of more expertise coming in. So yeah, would really look forward to sort of reaching out to you, learning from you, and would hope to sort of be a collaborating center at some point.
Wonderful, thank you. So in all this wonderful story, there's actually one great bright spot. Shivani, I want you to come here. Now, I'll be very, very honest and very upfront. I'm an absolutely horrible person to work with. And very, very horrible. I would be very horrible to work with. So Shivani has essentially been tolerating me for the last year or so. So this is Shivani, all my emails, everything she manages. So I just want to say thank you to Shivani. And for everything that has been possible, very honestly, it's been possible only because of her. So I just want to say a big thank you to you, and also putting that name to face is very important. All the emails, every part of the admin work is essentially being done by her, and she does not only report to me, there's also one more person that she reports to, and yet takes a huge amount of burden of work in an organization which is essentially very difficult to work with, very honestly. So thank you to Shivani. But I want to open it up now for questions. Any other questions, thoughts?
See, one thing that's right from the time when we started putting that, the paperwork in, it was very clear that actually our thinking is going to evolve regarding what we are going to contribute to this network and what we should be learning from the network. So how does this initial paperwork allow for that evolution and change over time? Because we may say we'll do this. Over time, we might realize, actually the focus needs to be something else for whatever reasons, right? There's organic learning.
Yes, so what I will do is I'll answer that from my end, but I'll also ask others who've been in this process to answer this as well. So the way I see this is being that I see WHO as a science-based organization where we need to do guidance and do work of impact for the countries, right? And very often what would happen is these keep changing as well. So there's a project collaborating agreement that we would sign off. Now, initially, I would want to keep it very achievable for you as an organization, because for me, the institution that is putting in effort to work with me, I want it to be successful at the end of the day, right? Now, so therefore, I don't want it to be too ambitious. I want it to be enough that it can achieve. There are organizations that start very ambitious, and having done research, I know what it takes to come out with high quality scientific output. It does take a lot of time, because when I give guidance to countries, there is a difference between research and guidance. Because when you give guidance to countries, it has to be so evidence-based, it has to be very high quality advice to them. Because governments and member states are going to challenge us. And so as WHO, when we go in, we got to be very careful with the kind of guidance that we give them. So therefore, what would happen is, we start small, we start in a way where we can work, but then as we make progress, we do come back to them and say, hey, here is a request that has come in. Now, for example, Anurag will speak about it. Anurag did not start with a responsible AI framework. He essentially, in his project collaborating agreement, had only digital health for younger people. But then as we started working, we realized here is an opportunity, and it's been very seamless. In fact, we have to go back to the project collaborating agreement and add this work that they're working with us added to it. Because that's something which I want them to benefit after 2-year cycle, that they've not only done this work, which is in the collaborating agreement, but more than that, right? And then they'll also add one more piece. Now, for example, with Dr. Neha and her team, as I saw their productivity, I realized that there were other opportunities that emerged. Say, for example, I hear from government of Timor-Leste, they wanted us to help build telemedicine guidelines. Now, I could go in and build the telemedicine guidelines, but it'd take more time for me, but rather than going to someone who's already an expert in that. So what I'm trying to do is I'm taking that requirement from the government and actually diverting it to her and the team and say, can you help us build that for us, right? So now she's not signed up for it. Timor-Leste building telemedicine guidelines do not exist for her. in her project collaborating agreement. But this is a conversation that we have, and if it is agreeable for her, and then I'll of course give her some resources to get it done. And in that way, it's of great value to the member state and great value for us and for the organization as well. So I certainly want to always see it as a win-win. For me, most important thing is, am I creating impact for the member state? That's my client. My client is a member state. And in the process, I would want it to be a win-win for the collaborating center as well. Now, we've had a request from Government of Telangana, right? And Government of Telangana said, help us build a responsible AI framework for health. Now, Ravi essentially said, we don't even know what is responsible AI for health for the global majority. So I said, as WHO, we have global guidance, but how do you take that global guidance and make it to the state? I don't know that. So I said, I don't know, but I'll get partners to help me build that. So I essentially reached out to you, I reached out to Ravi, I reached out to Anurag, I've had I've reached out to Joy, and we've created a collaboration here specifically to that project. And now whatever Anurag and the team contributes will be something that they would have delivered. So what I'm trying to do is I'm trying to come up with projects as I work together with partners, which will get added into the project collaborating agreement. So if for me, the way I see it is a dynamic process, and it may not be very similar to all of them, but I will be as transparent as I can with each one of them, right? And that's the way we wanted to work. You want to add something?
Yeah, I think the Telangana example is a great one. The likelihood of the government of Telangana ever directly reaching out to Ashoka to assist them with a responsible AI framework is zero, right? Yet we have people like Subhashish, because Center for Digitization Society, looking closely at likely points of failure. So many places do have good people, but as a network, all the relevant people can be tied in for the best possible answer to a given question. And sometimes, at least in our particular case, what could have been useful, for example, was a bunch of people whose entire task in life, JD, rotates around these areas, right? I mean, that's difficult to do sometimes. And at Ashoka, that also resonates with the Koita Center for Digital Health. I mean, the reason it was set up by the Koita Foundation was to help scale the adoption of digital health. Now, in that sense, this request ties in perfectly with the intent of the donor, because at Ashoka, a variety of our centers are donor-based. There is nothing possible that could be more aligned to the idea of the donor than to create a framework in which digital health adoption through AI, responsible AI, grows. So very quickly what we were able to do was to put out those JDs and directly, quickly chat. Some CVs have come, we can check them out. Now that is of course easier when you have donor money to use for these flexible things. But as Karthik said, in very specific cases, where resources can also be provided, here I didn't want to wait. That is my unique situation. It is faster to get started, put the JDs out, get good people, get going, and use the donor networks that Ashoka uses to make it. And for each one of us, it might be a bit different, right? On a government project using GEM, it may not work this way at all. But on the other hand, if many of us are working together, some of us would have some types of constraints, some of us would have different types of constraints. So again, I think as a network, if we are working together, we could use each other's strengths and cover each other's weaknesses while doing this. And I think responsible AI in particular is a great example. Anything you want to add to this, Subhashish? Because you also have the...
No, I just wanted to relate my experience, because younger colleagues, they're very aggressive. They come up with questions like, what is it in there for us? Why should we do this? So I told my colleague 3 things. Number 1, I quoted Harry Truman, horrible president of US who bombed Hiroshima, but he had one of the finest quotes for organizations and collaborations. He said, it's incredible as to what we can achieve if you don't ask the question, what is in there for me? That's number 1, told him. Second is, in any case we are doing this, it's an organic activity, it may be a little bit more. You give the credit to WHO, it doesn't matter, right? The third thing is, you think of this as an academic CSR activity.
I think that's a great way to put it. I mean, ultimately, at least from our point of view, the donors come in for impact. And we would never have this impact without the WHO reaching out to us. I mean, even if we had wanted to, even if we had everything ready. So I definitely agree with you. And even if it was not, you're spot on. Why always ask what's in it for me? As long as the ecosystem is growing, is a rising tide, it will lift all boats anywhere.
Ravi, you wanted to say?
Very quickly. So, I mean, just to go back to the original question from Raghu, right? So, one way to think of this agreement that we right now is more like an enabling framework and not a limiting framework, right? So it's not something that we stick to, and this will allow us to have this conversation going and expand as we see fit.
And I just wanted to add a couple of points to what Anurag added. Now, here is a situation where there could be an organization X which has a resource, doesn't have technical strength in that, but can see a partner who has a technical strength and then can say, I don't want this resource, I'll give it to you, and you help me deliver what we need to deliver. And that's primarily the reason we want to create this network. And so with your approval, if you all agree, we certainly want to create a group, if it is in a very respectful way, so that you can all connect. And it's not going to be something, we can be out of it.
Please stay in.
Yeah, but we essentially want this to be a one where you can have conversations, you can connect and you can talk and you can post things. We want to create that space both as an email and whatever format that works. Yeah.
Yeah, I actually wanted to ask something about that. I'm very concerned about how less Shivani might be sleeping at night, because I don't think she even sleeps. Her response comes within minutes whenever you message her. How can we better collaborate with one another? I think for us, when I went to our board saying there's no funding for this, should we do this? The answer was very obviously yes, let's do it. And it took us a while until the collaborating agreement was signed that we could talk about it publicly. But as soon as we did, the donor money actually flowed in to support something like this. So then we could hire people to run our webinars, and now we have some funding to do work at the intersection of AI and telemedicine. And that's why I reached out to you saying I think there's a lot of complementarity in our work and also overlapping degrees in our work. How could we get each other's contact, reach out to one another, and how can we highlight the collaboration of collaborating project collaborators?
And that is why I wanted this to be more like a Chatham rule thing, where you feel, it as an open, safe space where you can talk about it, right? Like, so my communications have been more one-on-one till now, and that's the reason why we wanted to bring everybody together and then see for you all to decide how would you want this community to be.
And I believe in one of the things is already starting, right? So both Suvrankar and Rayata have been in touch. So whatever works well. I mean, we are very flexible on our side.
Yes.
So one question, given that WHO is this super bureaucracy, what happens when the people change? Because we are all going to spend time, and eventually people will get transferred, move on, and how do you maintain continuity? And maybe it's a question for Dr. Van Gool, because they've been working for decades. So what does that look like?
Yeah, I think it's good to hear from Dr. Gould rather than me.
Yes, excellent question. So the collaborating center is appointed at the institution and not so much to the persons in the institution. So it is important that you can demonstrate to WHO that you keep your capacity and your expertise up to date, so to say. That's the lesson that I would share with you.
Yeah, my question is also what happens when the people at WHO change?
Depending
when
on
Shivani leaves, Dr. Karthik goes back to GOI.
Well, depending on the person that you're dealing with, we've had some good experiences and some lesser experiences. It all depends on the level of communication that the person at WHO is able to commit to. You can have some bad luck that you will need to do some searching at WHO before you get your focal point again.
No, I think I'll just answer this. This is going to be a problem. Let me be very honest. People change, and they have their own pet priorities, and they might want to put it into the TOR or request you to do it. And when a new person comes, so you have to be nimble enough to adjust to the changes. So the life of particularly NGOs is adjusting to the dynamic changes that happen. So there's no clear-cut answer to this. You have to be smart enough to adapt.
Well, that's why I'm not answering that question because I certainly haven't been on that side, so I don't think I'm competent to answer that. But what I'm trying to do is I'm trying to essentially create a framework wherein even when I have to leave or it's not about me, I want it about the institution. So institutionally, that's the reason why we wanted to sign this project collaborating agreement. One of the reasons why we want to kind of do these webinars is again to show that visibility. In fact, we met in Kenya, and this wasn't really in the initial goal. Initially we didn't have this idea, but then we met in Kenya, we kind of co-developed, we said, let's do webinars, because I want this to be, I've been on this side more as a researcher, right? I've lived almost a decade as a researcher, and I know what it means for someone who's put in all their effort to collaborate and come up with high quality guidance documents. So for them, what I wanted is to be win for them. And for that, what I want to do is I wanted to create a framework. So what we've done is we said, can we also give them some visibility? One is if you just do like what Professor Prabhakaran has with me, which is essentially saying do a scientific systematic review with rigorous methodology. Now by the time it takes, it's going to take about 8-9 months, right? In 9 months, if Dr. Neha and her team can do at least like a 5 or 6 webinars, along with that also do a systematic review, there's a lot of visibility that builds in for them. So I've been able to think through this year on what is it that I can do in terms of visibility. And then what I've also tried to do is with governments, identify projects where they can see great partners. Like for example, Telangana, as I said, I could certainly hire a couple of consultants and deliver that for them. Right? But then I realized that more than doing that, let me find local academic partners and other kinds of partners and then deliver that product for the government. Because that's when there's going to be ownership, right? So what I'm trying to do is create that framework and then create this network. So it does not have to be individual centric. It can then be the organization. And in the organization, there are enough structures. There is enough paper trail that you would leave which would be able to help you as well.
I'll just add to that, in the webinars, you shared a very helpful tip to us, which I would share with everyone else, is that, of course, Dr. Karthik connected us with WHO country office leads as well as ministry leads in the initial days, but now we are going out to make those connections ourselves to make sure that in every webinar, that it's practical, it is like your audience is very clear. It's ministry and it's WHO offices. Maybe you can extend it to other agencies like UN agencies or as your core audience, but being clear about your core audience and inviting them as speakers so that people are learning from peers. I think that really helped a lot, because then we got like 250 attendees in each webinar that we have had so far, and vast, like 80% of people stayed the whole 1.5 hours, which I was extremely surprised. And every webinar we have never been able to run out of, we've always run out of time. There have been more questions. So there's a lot of hunger for that knowledge. And if you're smart with your networking, and it was a wonderful tip that was shared with us, I would say.
Yeah, please.
13 webinars. It's curated as a curriculum on topics in telemedicine. It's only focused on telemedicine. And each topic builds on the previous one. And then at the end, all 13 are posted after each webinar. They're all posted on our website. So you can even do it as like a 13-hour course. And then we are planning to issue a certificate from our institution, not from WHO, for completing the entire series.
Other questions? I think you had a question, please.
Yeah, I was just kind of curious to understand in the the overall framework of creating collaborative teams for digital health. Is there kind of a landscape of all partners globally, so that we know we have a pipeline of solutions? Okay, starting in the continuum of care from primary, secondary, tertiary, across different departments, across different contexts, across different geographies. What is the level of evaluation, monitoring, like Dr. Srinivasan, Professor, he was mentioning about it. Because, when I'm starting with a specific solution, the first thing comes to my mind, hey, has anyone else done it? it's very rare to find digital health solutions being documented in the research format. So any thoughts on WHO? Because this was very useful in the COVID times. I very well remember all the interventions and drugs. There was a one-stop solution. Which drugs, which vaccines, where is it right now? You know, something like that. Is there any effort on that regard? Just a question for you.
This is a slightly different question. Here, WHO collaborating centers, what you can see is these are scientific academic institutions, non-academic institutions, non-profit organizations, all as expert organizations. So on digital health and AI, so on our WHO Collaborating Center website, you can go to each one of them, drill down and see as per the TORs what activities they're working in each year. Okay. So you should be able to see that. Now, the pipeline that you're talking about, certainly not, because that's not the goal, because each one comes with a very different expertise. So the expertise is driven by them. So we don't determine the area in which they need to work. We certainly curate with them. There's a certain amount of curation that happens, but that's not to be directive here. It is they who drive, academic institutions drive where they want to contribute. Now, for example, with Raghu, for instance, where we've done certain amount of co-development, I can see what's the value, but I certainly want to curate it with him so that it is more relevant to member states. Right. So we do that part, but we don't determine where they need to, what areas they need to work on. Yeah, okay. So thank you all so much. I think this has been the major purpose, which is to have a conversation. And I think there is a general agreement that we want to stay connected, right? And so we will, if you all approve, we will connect you on email and as well as on WhatsApp or whichever group that works. We'll put you all in a group so that you can have conversations and ask with each other. So thank you all so much. Thank you. Thank you for this opportunity. Thank you. Please, one photograph. Thank you so much. I think it's probably. Friends, can we have one picture, please?